This is camera.
Hello, everyone. I am Dr. Rashesh Diwan, the organizing chairperson for IASCON 2021. I welcome you all on behalf of the Governing Council of Indian Society of Anesthesiologists and the organizing team of IASCON 2021. We all know we have passed through a very difficult phase in the life, and now gradually we are trying to overcome the situation. Many of us suffered the pandemic, and of course, many of us also worked for the pandemic, for the community, and we were praised all over the country and all over the world. It was a great learning time for all of us. However, we missed the last year completely for the academics. But now we are beginning, and we are beginning with a very mega academic fiesta under the banner of Indian Society of Anesthesiologists. This is the biggest ever hybrid conference and happening for the next 5 days. I am sure you will enjoy the most. We have made a humble attempt to accommodate as many presentations as possible. And in view of the overwhelming response for the presentations, we extended the conference on the pre-CME day. This is the today. We are starting today at 8 o'clock, and we have plenty of e-papers accommodated for 1 day. Once again, I thank you all for the participation in IASCON 2021 and wish you good luck. Stay safe. Long live ISA.
Ma'am, unmute and start, please.
Hello. Today we are starting the morning session of e-paper presentations. Our chairpersons for the session are Dr. Asutosh Vyas and Dr. Bindu Madam George. Dr. Bindu Madam is Professor and Head of Department of Anesthesiology at St. John's Medical College and Hospital, Bangalore. Welcome, Madam. Dr. Asutosh Vyas is Associate Professor at PDU Government Medical College, Rajkot, Department of Anesthesiology.
Thank you, Isaac.
Welcome, Dr. Asutosh. I will hand over the session to you, Madam, and Sir. Please start the session. The first person to present is Dr. Lana.
Thank you, Madam. We can start the presentation. How many participants are there?
Total 22 participants are there, Madam.
Okay. How many minutes for discussion? 2 minutes,
2 minutes, yes, Madam. 2 minutes for question answer.
Okay, we can start, sir.
Dr. Lona is online. Hello, Dr. Lona. Please, Alok, please put the presentation of Dr. Lona.
Warm greeting to all.
The title of my study is a comparative study of unilateral and conventional spinal anesthesia by using 0.5% hyperbaric bupivacaine in lower limb orthopedic surgery. Unilateral spinal anesthesia for lower limb surgeries offers many benefits, including better hemodynamic stability, lower incidence of postoperative urinary retention, lower anesthetic doses, direction of pencil point or cutting needles, slow injection rate, and with 15 to 20 minute lateral decubitus position can be used for unilateral spinal anesthesia. The aim of our study was to compare unilateral and conventional spinal block by using 0.5% hyperbaric bupivacaine. The objective of our study was to compare intraoperative hemodynamic changes, quality of analgesia, and to evaluate side effects between unilateral and conventional spinal anesthesia. The study was conducted in the Department of Anesthesiology in Jorhat Medical College and Hospital. It was a hospital-based observational study. The sample size was calculated to be 90 and 45 in each group. Group A received 12.5 milligram of hyperbaric bupivacaine for conventional spinal anesthesia. Group B received 7.5 milligram of hyperbaric bupivacaine for unilateral spinal anesthesia. In this study, we found that unilateral spinal anesthesia provides better hemodynamic stability when compared with conventional anesthesia. Unilateral spinal anesthesia showed fewer side effects than conventional spinal anesthesia with better quality of analgesia. This is a table showing mean arterial pressure between the two groups, and we found significant differences at 5, 10, 15, 20, 25, and 30 minutes, and a significant difference where the p-value is less than 0.05. This is another table showing the side effects between the two groups. The significant side effects which we found were hypotension, bradycardia, nausea, and vomiting. Lastly, we concluded from our study that unilateral spinal anesthesia is better than conventional spinal anesthesia if feasible for operation on lower limb surgery. Thank you.
Ma'am, unmute and start, please.
Madam and Dr. Ashutosh, please unmute your video to ask questions.
Yeah, all orthopedic procedures or specific orthopedic procedures you have chosen?
Ma'am, we have chosen your lower limb surgeries, ma'am.
Okay, whether when you stick to pure unilateral spinal, whether the patient will be able to lie down like that for a long time, because the other limb also. No, I am asking you.
Okay, ma'am. Ma'am, actually, that was one of our exclusion criteria, ma'am. So
Okay.
if the patient was unable to lie on the operated side, then that patient we won't give unilateral spinal anesthesia.
Okay. And about your objectives, so many objectives were there, whether it was classified as primary objective. What was your primary objective? So many aims and objectives you have mentioned, like some 4 or 5. See, primary objective, only
Yes.
one should be there. What was your main primary objective?
Ma'am, my primary objective was to find the difference between intraoperative hemodynamic parameters between conventional and unilateral spinal anesthesia.
Okay. You found that this was better than unilateral was better. Hemodynamically, patient more stable.
Yes, ma'am.
Okay. Okay, madam. Any other questions, Mathu?
So if no other questions are there, we can go to next candidate, madam.
Yes.
Next candidate is Dr. Madhu.
Thank you.
Hi, my topic is attenuation of the hemodynamic responses during laryngoscopy and endotracheal intubation with 2 different doses of labetalol in controlled hypertensive patients undergoing general anesthesia. Introduction: laryngoscopy, endotracheal intubation, and other airway manipulations are noxious stimuli that may induce profound changes in cardiovascular physiology such as hypertension, tachycardia, and wide variety of cardiac arrhythmias. In our study, we have tried to compare attenuation of hemodynamic response during laryngoscopy and endotracheal intubation with different doses of labetalol in controlled hypertensive patients undergoing GA. Aim to study and compare the effect of two different doses of labetalol in controlled hypertensive patients during laryngoscopy. Materials and methodology. Placebo-controlled study on 90 patients between 30 to 60 years belonging to ASA class 2 with three groups, that is group L1 receiving labetalol 0.15 mg per kg, group L2 receiving labetalol 0.3 mg per kg, group C receiving normal saline. All three groups receiving drugs 5 minutes before laryngoscopy and intubation. All patients were preoperatively assessed, antihypertensives were continued, consents were taken, ASA standard monitors attached, and baseline parameters recorded. Premedicated with ondansetron, glycopyrrolate, fentanyl. After premedicating, the study drug was given according to respective group L1, L2, and C. Pre-oxygenated done with 100% oxygen, induction done with propofol, vecuronium, and intermittent positive pressure ventilation given for 3 minutes, and intubation done by a skilled person by Macintosh blade within 15 seconds, maintenance of anesthesia done with oxygen nitrous oxide and injection vecuronium bromide, and inhalation as sevoflurane. Monitored heart rate, systolic blood pressure, diastolic blood pressure, mean arterial blood pressure, and pulse oximetry and ETCO2. All parameters were recorded at baseline, after premedication, after intubation at 1, 2, 3, 5, and 10 minutes after intubation. Reversal of anesthesia done with glycopyrrolate and neostigmine. After satisfied criteria of extubation, patient was extubated. Intraoperative complications were managed according to standard protocols. A p-value of less than 0.05 was considered statistically significant, and p-value of more than 0.05 was considered non-significant. In observation results, all the three groups were comparable with respect to age, gender, and antihypertensive medications taken. Values of heart rate prior to intubation were statistically not significant between all three groups. At 3 minutes and 5 minutes post intubation, there was statistical difference between L1 and L2 group. There was statistical difference in heart rate throughout the study between L1 and control group and L2 and control group. For systolic blood pressure, diastolic blood pressure, and mean arterial pressure between an L1 and L2 at intubation and 1 minute post intubation were statistically not significant. However, it was statistically significant between L1 and L2 group at 2 minutes, 3 minutes, 5 minutes, and 10 minutes post intubation. And between L1 control and L2 and control, there was statistical significance present. Labetalol is an antihypertensive drug that decreases the pressure response of intubation by alpha 1 and non-selective beta-adrenergic receptor blockade. The onset of action is 2 to 3 minutes and peak action reaches at 5 to 15 minutes. In our study, labetalol of 0.15 mg per kg and 0.3 mg per kg is used prior induction to attenuate hemodynamic response during laryngoscopy and intubation. Labetalol in both doses is effective in reducing the hemodynamic stress response in controlled hypertensive patients in dose-dependent manner during laryngoscopy and tracheal intubation, and was attenuated more with labetalol at 0.3 mg per kg IV compared to 0.15 mg per kg. Thank you.
Hello, yeah. You have taken only hypertensive patients?
Controlled hypertensive patients.
Controlled hypertensive patients. So the last group, control group, you didn't do anything, though they were hypertensive.
No, it was controlled hypertension.
Okay. The higher dose of hello.
Labetalol. Yes, ma'am.
Higher dose of labetalol was considered than the lower dose. Correct?
Yes.
No? Okay. How did
Yes,
you
ma'am.
give,
Higher dose was better
what time, how many minutes before intubation how many seconds before intubation you gave this?
Ma'am, 10 minutes before it was given. Pre-medication was given 10 minutes before. Along with the study drug was also given 10 minutes before study.
10 minutes before. Okay. Okay. That means before taking the patient or inside OT? After taking the patient inside OT, you have given?
Inside OT only, ma'am. After attaching monitors only, study drug was administered.
You gave directly, or whether it was diluted, or labetalol usually we give directly?
Diluted to 5 ml.
Okay. Okay.
Does any of your patients get any type of complications?
Sorry, sir.
Your patient is controlled hypertensive patient. It might
Yes,
be on a remember. So after giving labetalol, does your patient has any complications like hypertension?
No, sir. We have not found any complications in our study group.
not any patients.
No.
Despite they have, they are on another drug.
Ah,
Okay.
We can proceed to the next, sir.
Okay, madam.
Yeah.
Our next person is Dr. Madhupriya. Please play the video.
Good morning, everyone. Today I'm going to present my topic presentation on prognosis of patient with tracheal intubation in the emergency department. So coming to introduction, intubation is one of the most important life-saving procedure used in critically ill patients with unstable conditions. However, not all intubation saves life. This procedure substantially increased between 2001 and 2020. The amount of emergency unit visits increases and more elderly patients seek medical treatments, including some life-saving procedures such as tracheal intubation as life expectancy increases. Considering the importance of intubation, unfortunately, insufficient information exists about the outcome of those patients who were intubated in the hospital. The challenges of different patient population, that is adult, pediatric, obstetric, emergency, pre-hospital, and extubation, has been addressed by specific guidelines. In the critically ill, patient practice may preclude standard airway assessment. Urgency and reduced physiological reserve contribute dramatically to increased risk of profound peri-intubation hypoxemia, hypotension, arrhythmia, and cardiac arrest and death. Despite a high-risk nature of intubation in ICU, most airway incidents occur after the airway has been secured due to airway displacement or blockage. In common with airway guidelines in other settings, it prioritizes oxygenation whilst endeavoring to limit the number of airway interventions in order to prevent complications. Now, coming to the methods, this is a retrospective cohort study which assesses the mortality rate of patients intubated in emergency department. Here is the data collected from health information system database of the hospital and included demographics, that is age, sex, length of being intubated, mortality status, and final diagnosis. The study period was from March 2017 to March 2019. It includes patients who were intubated in the emergency department with all available information. Excluded were the patients who were intubated out of hospital, trauma patients, and unavailable information. The primary outcome was the mortality rate of patients who were intubated in the hospital emergency department. The secondary outcome were the duration of intubation at the hospital and predictors of in-hospital mortality. Based on prior research, the patients' age were divided into 6 groups, and accordingly, the final diagnosis were divided into 7 groups. We had categories of unspecified diagnosis, which consisted of 27 patients who died before diagnostic procedure revealed specific reasons. Now, coming to statistics, we were using IBM SPSS Statistics 22 software for all analysis. In hospital, mortality was primary outcome. We analyzed the bivariate association of each candidate predictor with this outcome using delta 2 variable significantly associated with our outcome was included in the multivariate logistic regression model. These were age, sex, and final diagnosis. Now, coming to results, we identified 594 patients who were included in the emergency department during study period. Data of 74 patients were excluded due to unknown outcomes. We evaluated the data of 520 intubated patients in the final analysis. These patients include the age more than 65 years. The overall in-hospital mortality rate was 80%. 82% descended died within 7 days of intubation. The median length of being intubated was 62 hours. Interquartile range is 5 to 208 hours. Median length of intubation was 236 hours. Only 13.6% of intubated patients were transferred to critical care unit, out of which stayed in the emergency department observation units and equipped mode. There was significant relationship between outcome of intubated patients with age, length of intubated, final diagnosis at a p-value less than 0.01. For all comparisons, sex was not significantly different between descendants and extubated patients who were intubated. Now, this is the cohort selection. Initial data is 592 patients, 74 patients were dropped for missing outcome data. So discussion coming to the purpose is to provide guidance on airway management in the critically ill, irrespective of location in the patient. This is clear, practical, logical, and consistent with the current evidence. You can show here my data are available, and you can also check out the conclusion, that is the prognosis of intubated patients reversely relates with age. As age increases, extubation chances increases, and most of descendants die within week of intubation. There will be high mortality rate. There will be higher mortality rate with internal and neurological disease. Okay, so thank you.
Yeah, okay, Madhu. See, one feedback, your slides are very crowded. So many sentences in one field. Okay, so you should restrict the number of lines and number of words by one thing. And another thing, so many factors can affect mortality in critically ill patients or emergency patients. Whether so many confounding factors are there for this topic, whether all those things are taken into account. See the induction age and use, all those things. See, if you give propofol, one shot, patient will arrest there only. It may not be because of your intubation technique. So many factors are there, whether all those things are taken into consideration. Other than what your positive findings, other than mortality associated with intubation, what else you have noticed? One, you said age. With the increasing age, mortality is more. Other than that?
Madhupriya, you have to unmute yourself. Please unmute.
Yeah. Ma'am, as age increases, there will be chances of extubation decreases. Okay.
Okay. So severity of injury and mortality, that also yes, positive association is there.
Yes, ma'am.
Okay, so many induction age and so many factors can affect the relaxant used or the technique, who is intubating. All those factors you have to take into consideration. And yeah, okay. Sir, you can ask.
Hello. What's your final conclusion then? Hello.
So the conclusion is that as the patient age increases, that is more than 65 years, more than 60 years, as the age increases, the chances of extubation will be decreases, so that there will be the possibility of mortality rate will be more. Mortality rate will be more in patients whose age is more than 60 years. This is the conclusion.
As the question and answer time is over, sir, we'll start the next candidate, Dr. Madhumati.
Evaluating the efficacy of 5 mg per ml magnesium sulfate versus 2 mg per ml fentanyl as adjuvant to 0.125% ropivacaine in labor epidural analgesia. Labor epidural analgesia is the most widely practiced technique for pain relief during normal vaginal delivery. My aim is to evaluate the efficacy of 5 mg per ml magnesium sulfate to 2 mg per ml fentanyl in addition to 0.125% ropivacaine in labor epidural analgesia. My primary outcome are onset of the sensory block, duration of analgesia, VASCO. Secondary outcomes are side effects, if any. Coming to the methods, after obtaining the ethical committee approval, my study period is from December 2020 to August 2021, a prospective randomized single-blind study of which 65 parturients are assessed for eligibility, in which 5 are excluded, 2 are parturient refusal, 1 is failure of the epidural, 2 others are not meeting the inclusion criteria. These are my inclusion criteria, these are my exclusion criteria. Of which 60 parturients are randomly allocated into group F and M of 30 each. In F fentanyl group, parturients received 8 ml of 0.125% ropivacaine and 2 mg per ml fentanyl, and NS is added to make the total volume of 10 ml. In magnesium sulfate group, parturients received 8 ml of 0.125% ropivacaine and 50 mg magnesium sulfate, and NS is added to make the total volume of 10 ml, of which in each group 30 are analyzed and 0 are excluded. Coming to the statistical analysis, randomization allocation was done by using randomly generated computer numbers. Statistical analysis was done using Jamovi version 1.6.23 software. Continuous variables were presented as mean plus or minus standard deviation. P-value was calculated by using the student's t-test, of which p-value less than 0.05 is considered as statistically significant. Coming to my results, onset of the sensory block is earlier in the magnesium sulfate group of mean 4 minutes, and in fentanyl it is 6 minutes with p-value significant.
Coming to the duration of analgesia, magnesium sulfate showed longer duration of analgesia of 180 minutes, and in fentanyl group 69 minutes, which is statistically significant. At VAS score 5 minutes, it showed magnesium sulfate showed 3 minutes, fentanyl showed 5 minutes, which is equally significant, and 10 minutes it showed 0. Magnesium sulfate showed 0.96 minutes and fentanyl 2.56 minutes, which is statistically significant. Coming to the discussion, magnesium sulfate was less explored for labor analgesia, and it offers the advantages in prolonging the duration of analgesia and hemodynamic stability. Magnesium sulfate provides analgesia by calcium channel blockade and NMDA receptor blockade, as fentanyl is most widely used opioid to local anesthetics. So we compared 50 mg magnesium sulfate with 0.125% ropivacaine as alternative to fentanyl in this study. Hassan R. et al. Compared 50 mg of magnesium sulfate and 50 mg fentanyl added to bupivacaine in labor epidural. They observed magnesium sulfate showed early onset of analgesia and has better VAS scores. Banwet et al. Also noted 75 mg of magnesium sulfate has more analgesia and fewer analgesic requirement when compared to fentanyl, which is 1 mg per kg in epidural for hip replacement surgeries. In our study, magnesium sulfate has showed similar results as above in early onset of action and prolonged duration of analgesia compared with fentanyl, and we have not observed any tocolytic action with this dose, that is 50 mg. Coming to the conclusion, magnesium sulfate is a good alternative to opioids with local anesthetics without any significant changes in hemodynamic parameters and side effects. These are my references. Thank you.
Hi, Madhu. My question is whether magnesium sulfate, whether it is safe to use epidural, whether it is approved epidural as an epidural drug. Madhu. Madhu? Not,
Hello, Madhu?
yeah. She's gone, I think. Okay, then, madam, we can proceed with the next. He is not seen now.
Okay, madam.
Got disconnected. Okay. Chaitana, yeah.
Yes, madam.
Now Dr. Mahesh presentation will be there.
Mahesh.
In elective laparoscopic gynecology procedure. Introduction. Supraglottic airway devices are now used widely for the surgery requiring general anesthesia. It is an alternative to total intubation as it secures and maintains patient supraglottic airway devices are now used widely for the surgery requiring by providing a perilaryngeal. It is an alternative to total intubation. The ideal airway is an introduction. Supraglottic airway devices are now used widely for the surgery requiring by providing a perilaryngeal. Supraglottic airway device is designed to fit perilaryngeal and hypopharyngeal structures without the use of an inflatable cup. It is made up of thermoplastic elastomer and a soft durometer, yielding a gel-like feel that provides a glottic seal in patients with a wide range of anatomic variations. Like the procylLMA and laryngeal tube, IGL has a gastric drainage tube integrated into upper gastric tube for gastric decompression, which significantly reduces the risk of acid reflux and pulmonary aspiration. Both laryngoscopy and tracheal intubation produce reflex sympathetic stimulation associated with elevated plasma catecholamine levels, leading to hypertension, tachycardia, EMI, arrhythmias, and intracranial hypertension. By avoiding laryngoscopy and tracheal intubation, supraglottic airway device is assumed to decrease the associated stress response of the intubation. My aims and objective is to assess the ease of insertion and to assess the hemodynamic changes in elective laparoscopic gynecological procedures. My study is a prospective observational study conducted in tertiary healthcare center situated in Solapur. My sample size is 73 patients admitted in OBGY ward posted for laparoscopic procedures. My study period is September 2019 to September 2021. Inclusion criteria: patient aged between 18 to 55 years, Mallampati grade 1 and 2, elective laparoscopic gynecological surgeries under GA with controlled ventilation, duration of surgery less than 1. Exclusion criteria is patient refusal, age less than 18 years, more than 55 years, ASA class 3 and above, Malampati grade 3 and above, emergency surgeries, patient with increased risk of aspiration, patient with obstruction of airway beyond the larynx, patient with decreased compliance of lung. I have concluded that mean age of the patient is 52.52 with standard deviation 5.09. Mean weight of the patient is 53.56 plus or minus 4.76. Success rate of IGL insertion at first attempt is 97.3% and at second attempt is 2.7%. Mean pulse rate at basal is 85.78 plus or minus 15.15. These are mean systolic blood pressure at basal is 122.32 plus or minus 13.56. Mean diastolic blood pressure at basal is 79.33 plus or minus 12.96. Mean arterial pressure at basal is 93.90 plus or minus 11.7. Mean EtCO2 at basal is 29.15 plus or minus 3.68. Discussion. The study conducted by Siddiqui et al. Where the insertion of devices was recorded as excellent, good and poor. He found that the insertion of IGL was comparatively easier and required less skill as compared to LMA, but results were not significant statistically, as p-value is less than 0.05. The IGL having a non-inflatable cuff and firm in consistency is much easier for insertion as compared to the LMA. Similar findings were observed by Singh et al., who found the success rate in first attempt of IGL insertion of IGL was better as compared to the other LMA without any need of manipulation and maintenance of airway in a short time. In a study by Jindal et al. Observed that IGL produces less hemodynamic changes compared to the other supraglottic airway devices. They concluded that IGL effectively conforms the perilaryngeal anatomy despite the lack of an inflatable cuff. It consistently achieves a proper positioning for supraglottic ventilation and causes less hemodynamic changes as compared to the other supraglottic airway devices like classical LMA, which due to its inflatable cuff produces more hemodynamic changes. I have concluded that success rate of IGL at the first attempt was 97.3%. So we can consider IGL insertion technique is better and easy. There are no significant rise in hemodynamic changes after IGL insertion. These are my references. Thank you.
Okay, Mahesh, you compared with the IGL with the for intubation, insertion success, you compared the normal LMA.
Yes, normal.
IGL and normal LMA.
नॉर्मल नहीं मैम ट्रकियल इंट्यूबेशन के अलावा ये बेटर है
Tracheal intubation and IGL.
हाँ
Okay. So IGL placement was easier than tracheal intubation. Whether that is
easier means less hemodynamic changes, insertion attempts are less.
Because you have compared the ease of insertion also. First was ease of insertion, no? So these are two laryngoscopy, all those things. Whether these can be compared, completely different things. So if you should have compared with the same LMA, different types of LMAs. Intubating a patient is different now. Definitely hemodynamic responses will be there. Correct now, Mahesh?
Yes, ma'am.
You should compare with another similar thing. So intubation, you are putting the scope. It is well known that scopy, direct laryngoscopy can cause intubation responses. Heart rate will go up. It is a difficult procedure then. Okay, and again your slides, now discussion and all, you should, when you present, less number of words. People won't read when you write like some 20, 25 sentences. If you write in one slide, it's difficult to read. So, okay. Sir?
We inserted RT via side channel while using IGL or not?
Yes, sir. Please, sir.
Have you inserted RT, small RT via small channel while using IGL in your
I can't hear you, sir. Please.
Have you inserted RT via side channel?
No, sir.
Okay, so we will go for next candidate.
Wait for a minute. Let me introduce myself, Dr. Rashesh Diwan, the organizing chairperson from IASCON 2021. And on behalf of the Governing Council and the organizing team, I welcome you all on this 5 days wonderful academic fiesta. And I'm so thankful to all the chairpersons, particularly Dr. Bindu George, wonderful teacher, and Dr. Chetna and Dr. Asutosh Vyas. Thank you so much, carry on this program. And I also thank all the participants. This is a mega event. We have 2,100 plus papers. And that's the reason we have made this program 5 days this time. And I'm sure it is going to be a wonderful another 4 days from tomorrow. And 11 halls. This is a very, very mega event. And let me tell you, this is the biggest ever hybrid conference happening in the world, thanks to the pandemic. We have to turn to this. We could accommodate 2,100 abstracts for these sessions. And thank you so much, the chairpersons, coordinators, and everyone. Please carry on with the program. And all the best to all the participants.
Thank you, sir.
Our next candidate is Dr. Mahesh Kumar.
Good morning. My topic for e-paper is post-operative analgesic effect of wound infiltration with bupivacaine versus mixture of bupivacaine and tramadol in cesarean section under spinal anesthesia, under the guidance of Dr. Trisla Jain ma'am, Senior Professor, SMS Medical College, Jaipur. So the cesarean section is one of the most frequently performed surgery in obstetrics. So optimal pain relief of mother result in early mobilization, initiation of breastfeeding, and prevention of chronic pain syndrome. So the aim of study was to compare the analgesic effect of wound infiltration with bupivacaine versus mixture of bupivacaine and tramadol in cesarean section undergoing spinal anesthesia. So their objective, primary and secondary. The primary objective is to determine the difference between mean time for need of rescue analgesic in both group and difference in the change in hemodynamic variables from baseline to post-operative period in both groups. So difference in percentage of case who develop side effect in both group, if any. So Metil method. We divided in two groups, 30 in each patient. Randomization was done by opaque seal Arnold method, and each group were prepared by group method, which was blind about the study. After recruitment, every patient was allowed to draw one envelope and group accordingly. Double blinding was done. Observer who measured study variable was different from anesthesiologist who gave the study drug. Both agents were transparent solution and looked the same. Hence, neither the doctor nor the participant were aware of group allocation and drug receipt. The patient was informed that he was given a drug, but specific agent was not revealed to him. The eliminated subject and observed bias. So there are two groups, group A and group B. So in group A, we infiltrated bupivacaine 0.25% subcutaneously 20 ml by 20 cc at time of skin closure. In group B, the incision site was infiltrated with tramadol mixed in bupivacaine 0.25% subcutaneously 20 ml by 20 ml series at time of skin closure. So both in observation, post-op NR score, so both group was similar in demographic parameter and duration of surgery. So in our study, we observed that in group B, NR score after 2 hours was significantly lower, and mean time to give rescue analgesic was more, and mean rescue analgesic dose was significantly reduced. So this is table for mean time to rescue requirement, and this is mean analgesic dose consumption. So we comparison done with the other study in 2017, Rupa Sachidanand, who observed that the mixture of bupivacaine and tramadol would infiltration at incision site significantly lower NRS as compared to patient bupivacaine. Or same as Jevithanusuk K et al. Also noted that the pain relief score defined as the difference between pain score before and after dressing was significantly higher in the bupivacaine group A during first 5 postoperative days compared to control group B in patient undergoing in thickness skin graft occlusion. Conclusion. So we conclude that the wound infiltration with mixture of bupivacaine and tramadol at incision site provide better postoperative pain relief and reduce rescue analgesic requirement without any unwanted effect. Thank you.
Your Mahesh, this tramadol, you can give like that. Subcutaneous is advisable. Tramadol injection. One question: whether tramadol?
Good morning.
What are the routes of
Subcutaneous only.
Mahesh, madam is
Hello. Good morning,
asking
ma'am.
whether you can give subcutaneous tramadol or not.
Yes, subcutaneous only, ma'am, in the second group.
Whether it is there in the routes of administration. Tramadol usually either IM, IV, and all. No? Whether it is approved. When you give some drugs, you have to see whether it is approved. The route of administration. And just anyway, tramadol is otherwise it won't cause major side effects. But the route of administration, whenever you are planning, you should see whether it is approved by drug control.
Okay, ma'am.
Yeah. One thing, and another thing is some places they say that when you give the infiltration, there is more chance of wound infection, especially when you give large doses, 20 ml and all subcutaneously. So whether any that you have seen secondary outcome, you could have seen that any wound infection in the postoperative period.
No, ma'am. Actually, what we did before taking drug from the vial, we have used to clear with the sprit swab properly and take care of the whole sterilization. So we didn't see any wound infection.
Okay. How did you blind the study? Blind the assessors?
Yes, ma'am. Double blinding. Actually, we did because both drugs are labeled with only group A and B, because both drugs are the transparent, ma'am, and that is done by the another third person, ma'am.
Okay, sir.
What is your study?
Sorry, sir.
What is the conclusion and purpose of your study? Is there any
Sir, what we
benefit?
have found that yes, what we have found that the patient who is receiving a mixture of bupivacaine and tramadol, they receive diclofenac about 6 to 7 hours IV. Just rescue analgesic dose will be very less in 24 hours after postoperative, as compared to only bupivacaine.
So duration of rescue medicine will be worse.
Sir, in bupivacaine is around bupivacaine plus tramadol around 5 to 6 hours, or only bupivacaine is around 3 to 4 hours. Yes, sir.
Okay.
Okay, thank you, sir.
Next person, yeah.
So we will go for next paper. Dr. Maitri.
Greetings everyone. I'm here to discuss my study, which is the comparison of intraperitoneal instillation of bupivacaine plus hydrocortisone versus bupivacaine plus dexamethasone on postoperative pain after laparoscopic cholecystectomy. Growing interest in minimally invasive surgery has increased the number of patients undergoing lap surgery. Post-op discomfort is transient and improves over time, but immediate post-op pain relief could decrease the post-op narcotic analgesic requirement and side effects like nausea, vomiting, delay in bowel function, etc. For this pain control, many different methods have been described, like tap block, intra-incisional infiltration of local anesthetic, and the study which we have described here, like the intraperitoneal instillation of drugs. The aims and objective of the study, primary outcome, is to compare the effectiveness of adding hydrocortisone or dexamethasone to bupivacaine plain on duration of post-op analgesia, to assess the post-op pain with VASCOR, to measure the hemodynamic changes and the total analgesic consumption. The study was conducted among indoor patients admitted in a tertiary care hospital after obtaining approval from Institutional Ethical Committee. Study design is observational type, and these are the inclusion and exclusion criteria. Patients were randomly divided into two groups, BD containing dexamethasone 8 mg plus bupivacaine 20 ml and BH containing hydrocortisone 100 mg plus bupivacaine 20 ml. Sample size were 12 cases in each group, total 24 sample size. After pre-op evaluation of patients a day before the OT and informed return consent was taken, on the day of OT, patients were pre-medicated with glycopyrrolate and ondansetron. In operation theatre, baseline vitals were noted and induction was done with injection fentanyl 1 to 2 microgram per kg, propofol 2 to 2.5 mg per kg, and scoline 1 to 1.5 mg per kg. After intubation, patients were maintained on 50/50 N2O2 with isoflurane and injection vecuronium in loading and maintenance dose. After completion of surgery prior to extubation, scope was kept in situ and study solution was given intraperitoneally before the removal of trocar in frenulum inwards position in hepatodiaphragmatic space on gallbladder bed near and above the hepatoduodenal ligament. Post-op assessment was done, VAS score, vitals, total duration of analgesia and requirement of rescue analgesia was noted, which was given when VAS score was more than equal to 3. After collecting data and statistically analyzing, we have obtained the following result. According to the study, patients' age and duration of surgery were not statistically significant in both groups. 10 out of 12 patients were female in dexamethasone group and 11 out of 12 patients were female in hydrocortisone group. VAS score compared between two groups showed no statistical significance at 0.5, 1 and 2 hours post-op, but they were significant at 4, 6, 12 and 24 hours post-surgery. And they were significantly lower in dexamethasone group compared to hydrocortisone group. Heart rate and mean arterial pressure in subjects of both the groups were not statistically significant within 24 hours post-op. Rescue analgesia, which is the tramadol requirement in dexamethasone group, was 5.2 plus 1 to 1.13 hours compared to 3.79 plus or minus 1.05 hours in hydrocortisone group. Tramadol consumption was lower in dexona group compared to hydrocort group. So both these parameters were statistically significant. Pain is a personal and subjective experience with considerable interpersonal variability. Various methods have been described, as I said above. Sabzi, Sarvastani, and Mehdi Mohammadi concluded studies which showed the installation of bupivacaine plus hydrocortisone post-op VAS score at 0 hours was not significant, but they were significant at 6, 12, and 24 hours. Result corresponded with our study. Similar study was conducted by Ashwin Kankotia and Digant Patel. Studies by Mahesh Sharma and Hatem Sultan were also similar, and Al-Shifa Zahra compared effects of bupivacaine with methyl or dexona. Results showed VAS score was significant at 4, 6, 12, 24 hours. And first call for analgesia in dexona group was 4.8 plus or minus 1 hour with supported results of our study. Hence, we conclude that dexona is a better regimen than hydrocortisone for reducing post-op pain relief after lap cholecystectomy. Thank you.
Maitri, what is the mechanism of the steroid analgesia? Because why you considered for prolonged duration of action of prolonged analgesia only you considered this dexamethasone and hydrocort? Any other mechanism for this? What are the other uses of steroid?
Steroids can be used in a lot of different conditions, like in allergic conditions. You can use to treat skin infections like psoriasis, etc. Both of these steroids can be used with different routes for as an anti-inflammatory, basically. So, ma'am, we actually studied this because there were different studies which compared drugs like Maxalt with bupivacaine, Maxalt with hydrocortisone, but there wasn't a study which compared two steroids. So that's why I took this study which compared dexona and hydrocortisone, and both are steroids. So it shows a better acting strategy, primary outcome of it. And when we found that dexona is a much better regimen as compared to hydrocortisone.
Okay, any reason for that? You were in your results you were mentioning that initial first hours there is no difference. Yes, whether it is because of the analgesic you have already given, because yes, during surgery you have given analgesic.
Fentanyl. Yes, ma'am. We administered fentanyl, and
the difference was seen only later parts of the study.
Ma'am. Yes, ma'am. And the average duration of surgeries was around 2 hours
which was similar in both the groups. That's why probably at 0.5 to 1 to 2 hours, there wasn't a statistical difference between the VAS scores. And after that, we can see that Dexona provided a better analgesia up until 5 hours as compared to hydrocortisone, which provided up until 3.8 to 4 hours.
You can see IV also, we can compare and see whether analgesia requirement, any difference is there. This you have done peritoneal infiltration. So you can see IV also, if that mechanism, steroids causing analgesia, if you can see, we compare with IV also. Sir, you can ask.
Which receptors this drug act while peritoneal instillation? Hello. On which receptors your drug will act while instillation? Okay.
Okay. Maitreyi? Okay.
Next.
Hello, Maitreyi. Have you heard the question?
I'm sorry, I cannot listen.
Sir is asking on which receptors your drug will act.
The steroids.
Which receptors? Okay, time is up, so we will proceed to the next presentation.
Yes.
Next presenter is Dr. Malla.
I want to share the screen, ma'am. Good morning. Myself, Dr. Malla Alekhya from Kamilani Academy of Medical Sciences, LB Nagar, Hyderabad, and my abstract number is 886. Today I have done a study with the title of to evaluate efficacy of erector spinae block in the patients undergoing modified radical mastectomies. So as we all know, and the erector spinae block is a newer technique of analgesia to the chest wall, providing an effective visceral as well as somatic analgesia after carcinoma of the breast surgeries. And this erector spinae plane block, it sufficiently blocks the unilateral multidermatomal sensation from T1 to L3, providing both the visceral and somatic analgesia. And the main objective of the current investigation is to compare the analgesic efficacy of this block to no block intervention in patients undergoing the MRM surgeries. So my main aim is to study the post-op analgesia after the ultrasound guided erector spinae block with a 0.25% bupivacaine, and approval from the ethics committee and informed consent has been taken. And we have included ASA of 1, 2, 3, and then adults, female patients less than 70 years of age. Exclusion criteria, the patients who are allergic to the study drugs, psychiatric illness, and the coagulation disorders. If there is any infection at the site of intervention, we have excluded them also. Coming to the procedure, after adequate pre-oxygenation and pre-medication, patient was induced with fentanyl 2 mics per kg and propofol 2 mg per kg, and then intubated. And ultrasound guided erector spinae block was performed using a 40 ml of 0.25% bupivacaine after a hydrodissection in the lateral position after induction. And we have assessed for the pain severity using the VAS scores after the full recovery. And we have even assessed the dose of tramadol that is required for the 24 hours. So the results, and this erector spinae block, it significantly reduced the 24-hour opioid consumption compared with the non-block groups, with a mean of 114 mg of tramadol usage in the erector spinae group and 171 mg in the control group over the 24 hours. And this erector spinae block, it has significantly reduced the pain scores at rest or movement at various time points postoperatively compared with the non-block group, and it also reduced the rate of post-op nausea and vomiting. And here the rescue analgesia is given with the tramadol 1 mg per kg. Here is a tabular form of how much of dose of tramadol is consumed over the 24 hours. We have done a case series in 5 patients showing an erector spinae and the control group. Here is a visual and tabular form of the visual analog score, which we have measured for around 12 hours. Finally, to conclude, erector spinae block, it improved the analgesic efficacy in the breast surgery patient compared with the non-block care. And it also reduced the intra-op opioid consumption, and it alleviates the acute post-op pain with an opioid-sparing analgesic technique in patients undergoing the breast surgeries. And it also improved the post-surgical analgesia. Here are the references attached. Thank you.
Hi, Malla.
Yes, ma'am. Good morning.
Yeah, good morning. See, you were telling less post-operative nausea, vomiting in the erector spinae group patients. Whether it is because of the less tramadol you have given,
yes,
only half the dose of tramadol you are given. Tramadol is known to cause post-operative nausea, vomiting. No, whether that whether it is because of tramadol.
It's because of the tramadol, ma'am. Because in the control,
the other group is getting very high dose of tramadol.
Yes, ma'am. The requirement is more in the other group.
Okay. All yeah, ultrasound guided you have done.
Yes.
Okay. Whether any other blocks are there for breast surgeries?
Yes, ma'am. We have pectoral blocks, ma'am. Where we have also used, but comparatively comparing the pectoral and the erector spinae block, more efficacy is for erector spinae, ma'am. And pectoral block is a outdated one. So where most of the people are using the erector spinae one, which is a novel technique.
Okay. Sir, any questions?
Yes.
Good morning, sir.
Good morning. Have you come across any type of complications while doing erector spinae block?
Not exactly, sir. The only difficulty we faced it, the needle visualization through ultrasound guidance, sir. And the technique, it has taken a more duration. Other than that, we don't have any other complications, sir.
What's the likely complications by doing this procedure?
Sir? Because it is at the thoracic level, chances of puncturing the pleura are high, but we haven't faced anything, sir.
How many patients you kept in your study group?
5, sir. We have done a case series in 5 patients.
Only 5.
Yes, sir.
Whether you blinded the study?
Yes, ma'am.
Because otherwise there is bias, no? See, block patients means you are definite that they will improve.
Yes, ma'am. It's randomized. We have blinded the study, ma'am.
How did you do blinding?
It's done by the third person, ma'am. We have done a computer generalized randomization chart in this 5 patients.
Okay, somebody else, third person assess the
Yes,
patient.
it's done by the third person, ma'am.
Okay, madam. Thank you.
Thank you.
Yeah.
Our next candidate is Dr. Malvika.
A study on comparison. Hello everyone, I'm Dr. Malvika Gupta and I'll be presenting a study on comparison of suprascapular block, anterior approach and interscalene block in adult patients undergoing arthroscopic shoulder surgery. As we all know, interscalene brachial plexus block is the gold standard analgesic technique for shoulder surgery, but it causes hemidiaphragmatic paresis. Suprascapular nerve block via anterior approach is a potential alternative where suprascapular nerve is selectively blocked under the inferior belly of omohyoid muscle within the supraclavicular fossa. We aimed to compare the analgesic efficacy of ultrasound-guided suprascapular block with interscalene block and incidence of hemidiaphragmatic paresis. Primary outcome was duration of analgesia, and secondary outcomes included NRS pain scores, morphine consumption, incidence of hemidiaphragmatic paresis, and sensory dermatomes blocked. We included ASA class 1 and 2 patients of 18 to 65 years, and patients with pre-existing respiratory dysfunction were excluded. This was a randomized comparative study, and a sample size of 30 patients in each group was calculated to achieve a power of 80% and to limit type 1 error to 5%. All blocks were performed by a single experienced anesthesiologist holding a fellowship in regional anesthesia. Routine PSC was done, and on the day of surgery, patients were shifted to a dedicated block room where a baseline ultrasound of the diaphragm was performed and hemidiaphragmatic excursion measured during quiet breathing and sniff maneuver. Baseline pulmonary function tests, including forced vital capacity, forced expiratory volume in 1 second, and peak expiratory flow rate, were measured. All patients received patient information sheet and participant informed consent form. Patients were explained about the nerve block procedure, grading of pain using NRS, and the use of PCA pump in post-op period. For the interscreen group, using an in-plane technique, the needle tip was adjusted between C5 and C6 nerve roots and the drug was injected. For the suprascapular group, the ultrasound probe was placed transversely over the supraclavicular fossa, brachial plexus identified posterolateral to the subclavian artery, and superior trunk was identified by following C5, C6 roots to their convergence point. More distally, the suprascapular nerve could be identified originating from the superior trunk, and 10 ml of the drug was injected around the suprascapular nerve. 60 minutes after the block procedure, assessment of sensory blockade, diaphragmatic excursion, and pulmonary function tests were performed. Then the patients were shifted to OT, where standard GA was administered and the surgery was performed. After completion of surgery, anesthesia was reversed and the patients were shifted to post-anesthesia care unit, where rescue analgesia was provided using IV PCA morphine pump with 1 mg bolus and 10-minute lockout interval. In results, the duration of regional analgesia was similar in both the groups. 24-hour morphine consumption was less than 1 milligram in both the groups. The post-op NRS pain scores remained less than 3 in both groups at all time points. The percentage reduction in diaphragmatic excursion on quiet and sniff maneuver on the surgical side was significantly higher in the interscalene group as compared to the suprascapular nerve group. This was accompanied by a corresponding increase in the diaphragmatic excursion on the non-surgical side, which was significantly higher in the interscalene group as compared to the suprascapular group. The decrease in post-block FVC and FEV1 values was significantly higher with interscalene group as compared to suprascapular group, and the incidence of complete and partial hemidiaphragmatic paresis was significantly higher in the interscalene group. This graph shows the sensory dermatomal distribution in both the groups. In conclusion, suprascapular nerve block is an effective regional analgesic technique for arthroscopic outpatient shoulder surgeries, and it may be preferred for patients with pre-existing decreased respiratory reserve. These are my references. Thank you.
Yeah, good study, Malavika.
Good morning, ma'am. Thank you, ma'am.
Yeah. Only thing is your primary objective was just to compare the duration of action. Means
duration of analgesia, yes, ma'am.
Yeah, whether your results, whether you are highlighting mainly on diaphragmatic secondary objective. Primary objective is achieved, correct now? Primary objective, both are comparable. So you can make that this thing, diaphragmatic paralysis or diaphragmatic, that is a primary objective, and you can do another study, correct now? That is your secondary objective. Primary objective, you compared the duration of analgesia. Both are good. Both are good. For shoulder surgeries, both are good according to your primary objective. But secondary objective, the other one is causes less PFT disturbances and correct? Correct?
Yes, ma'am.
Yeah. So you should think about that.
Right, ma'am.
Taking that as a primary
that can be done.
Yeah.
That can be done.
Yeah. Otherwise, nice presentation.
Thank you.
Sir.
Can you use this as a sole anesthesia procedure or sole supraclavicular block without giving general anesthesia? Can you proceed?
So all the literature which does not support giving only the block as a sole anesthetic technique, so they always recommend giving general anesthesia with supplementary regional anesthesia. So the patient will be highly uncomfortable. The position for the shoulder surgeries which they use is the beach chair position, sir. So the patient is very uncomfortable in that position if we only give the block. So we never used this technique as a sole technique.
So diagnostic arthroscopy, whether you proceed.
Sir, for diagnostic arthroscopy,
Whether you proceed for a suprascapular block.
sir, if it is only diagnostic arthroscopy, then maybe we can give it.
Okay.
Is there any complication for the other one? Suprascapular, any other complication is there?
Ma'am, we did not face any complication. The only thing was that this block was very close to the pleura. But since we were doing it under ultrasound guidance, we could always see the pleura. So we were much above that. So we did not really. The only thing was in the technique difficulty, since it was a new thing. So that is the only thing. Otherwise, there were no complications associated.
Okay, no more questions. You can move.
Madam. Our next presenter is Dr. Manoj Kumar.
Good morning, everyone. Myself, Dr. Manoj Kumar, PG Resident Department of Anesthesia from BGMC. Here I am going to present a paper on topic by efficacy of syndrome, intravenous syndrome, intervention of post-operative shivering, and lower segment cesarean under spinal anesthesia. Spinal anesthesia widely used safe anesthetic technique in abdominal and lower limb surgeries for both the elective and emergency operative procedure. And post-anesthetic shivering is a leading cause of discomfort for patients after spinal anesthesia. Shivering is involuntary and oscillatory mechanical activities, skeletal muscle after increased O2 consumption. It is classified as a thermoregulatory shivering and non-thermoregulatory shivering. The complications of shivering are increased metabolic rate, increased O2 consumption, CO2 production, and interference monitoring. First treatment consists of warming the patient, and in severe cases treated with medications like fentanyl, tramadol, ketamine, etc. Here in this study we use the etc. And the aims and objective of the study were to observe the effectiveness of prevention of post-operative shivering under spinal anesthesia, and to compare the hemodynamic variables and shivering score between the two groups, and to compare the complication between the two groups. Group A were receiving injection on 8 mg 4 ml IV, and Group B receiving normal saline 4 ml IV. And after ethical committee approval, 60 patients of ASC grade 1 and grade 2 posted for elective LSES were divided into two groups randomly by computer generated random check. Pre-operative evaluation cleared the day, and the necessary investigation advice on the day of surgery. Patients procedure were well explained to the patient, and informed written consent were taken. And all patients were covered with one layer of surgical traps and from chest, thigh, and claves during the surgery, and post-operatively patients were covered with one cotton blanket. On arrival to OT, IV access were established with 18-gauge cannula. Before performing spinal anesthesia, all patients were received 10 ml per kg injection ringer lactate as loading dose, and 10 ml per kg per hour as infusion. Aseptic antiseptic precautions were followed, and spinal subarachnoid anesthesia were given at the level of L3, L4, or L4, L5. And a volume of 2 to 2.5 ml of injection dopioic and 0.5% hyperbaric solution here was given via 23-gauge spinal needle. And the parameters observed are ECG, temperature, systolic and diastolic blood pressure, and saturation. All parameters are recorded every 15 minutes intraoperatively and every hourly post-operatively till 6 hours. Shivering was graded as following: grade 0, no shivering; grade 1, piloerection or peripheral vesicle, no visible shivering; grade 2, muscular activity in one group of muscle; grade 3, muscular activity more than one group of muscle; grade 4 as shivering in the whole body. The results were obtained and shown in tabular column and graph represents as below. And this prospective and randomized double-blind study demonstrates statistically significant difference in incidence of shivering between the two groups. Group A, the incidence of shivering was only 10%, those who received normal center, and Group B has shown 50% of incidence of shivering, those who received normal center. And grade 0 shivering, that is no shivering, was seen in 27% of Group A and 15% of Group B. Grade 1 shivering was seen in 2 patients of Group B and 7 patients of Group B. Grade 2 shivering was seen in 1 patient of Group A and 5 patients of Group B. And grade 3 shivering was seen in 0 patients of Group A and 3 patients of Group B. And no patients developed grade 4 shivering. Incidence of nausea seen in 5 patients of Group B and no patients in Group A. And hypotension was seen in 2 patients in Group A and 3 patients in Group B. So we found that group A showed significant decrease in incidence and compared to the group B, and the grading of shivering also decrease in group A. So here we conclude that from our study that intravenous amantana given at the dose of 8 mg in under patients of elective LSCS, lower incidence of post spinal anesthesia induced shivering with no significant adverse effect to mother and fetus. Thank you.
Hi, Manoj.
Good morning, ma'am.
Good morning. So you didn't give any antiemetic for the second group? Only ondansetron for the first group and no antiemetic for the second group?
Metoclopramide was given to second group, ma'am.
Metoclopramide was given to second group. Okay.
Yes, ma'am.
Okay. So two different antiemetics given to. Whether you should have balanced that with both groups. One group ondansetron and metoclopramide, and other group metoclopramide alone. So we don't know because when you want to compare two things,
yes, ma'am,
something should be common in both groups.
Yes,
you have not given metoclopramide this group and that group, so whether we can compare. Another thing is, what is any mechanism of action for ondansetron for this anti-shivering?
It will act on the 5HT receptor over the CNS, ma'am. By that way, it will reduce the shivering.
Okay. What are the other drugs used for postoperative shivering?
Ma'am, fentanyl we can give, tramadol we can give, ma'am. Ketamine is also proven to reduce the shivering.
Okay.
Yes, ma'am.
Commonly used pethidine, low dose pethidine also sometimes we use for.
Yes, ma'am. Pethidine is also using.
What are the problems of postoperative shivering?
Patient will usually in shivering there will be an increase in requirement of O2, ma'am, which will make the patient more uncomfortable, ma'am, and by the involuntary movements also. There will be a 400% increase in requirement of O2, ma'am. So patient will be anxious and O2 requirement will be increased.
Okay. Yes, sir.
Good morning, sir.
Good morning. Why there is a shivering in such patients?
Sir, why?
Shivering occurred.
Sir, whenever the body temperature is in this cases, spinal cases, after given spinal anesthesia, there will be vasodilation in the periphery. So to compensate that, body does distribute the core body temperature to evenly. So so that the CNS temperature will be reduced, will be coming down. So that will be compensated by the shivering mechanism. There is two compensating mechanisms. One is shivering, and one is non-thermogenic.
So that the OT temperature also, no?
OT temperature was kept at a standard temperature for 20 to 20 degrees.
It's also one of the cause shivering.
Sir?
One of the cause for shivering.
That is also will be one of the cause for shivering. Cold ambient temperature is also a cause.
Okay, so we will proceed for the next presenter.
Yeah.
Dr. Meenakshi Devi.
Meenakshi, and the title for my paper presentation is Effect of Subhypnotic Doses of Propofol and Midazolam for Nausea and Vomiting During Spinal Anesthesia for Caesarean Section. Introduction. Spinal anesthesia is one of the most widely accepted method of choice for Caesarean section due to its safety and speed. However, there are a few disturbing side effects associated with this technique, including intra-op nausea and vomiting. They have multiple etiologies, which include hypotension, vagal hyperactivity, visceral pain, IV opioid supplementation, and neurotonic agents. Recently, it has been shown that low doses of propofol can reduce intra-op nausea and vomiting during spinal anesthesia for Caesarean section more efficiently than ondansetron and metoclopramide. Benzodiazepines have been reported to have some benefits with regard to nausea and vomiting by reducing the anxiety via lowering the dopaminergic input to the chemoreceptor trigger zone. Aims and objectives. The goal of this study is to evaluate the efficiency and safety of propofol and midazolam compared to each other as well as placebo in preventing the intra-op nausea and vomiting during spinal anesthesia. The effects of these agents on hemodynamics of the patients during cesarean delivery. After delivery, most of the patients require sedation, which could be provided with midazolam or propofol.
This randomized double-blind and placebo-controlled clinical trial was performed at Government General Hospital, Siddhartha Medical College. It was performed after obtaining approval from Institutional Ethics Committee and informed consent. 90 patients of ASA physical status 2, aged 20 to 30 years, undergoing spinal anesthesia for elective section were grouped under 3 groups. Group 1 received placebo, that is saline. Group 2 received propofol 20 mg bolus, and midazolam group 3 1 mg bolus. Interrupt nausea and vomiting after delivery were recorded by an anesthesiologist who was blinded to the study. RL was administered IV to the patients before induction of spinal anesthesia, and a level of T4 to T5 was achieved. PP monitoring was done at regular intervals. A decline of more than 20% from baseline pressure or systolic BP of less than 90 mmHg was managed with mephentermine, and patients were randomly allocated to placebo, propofol, and midazolam groups. Medications were used intravenously at subhypnotic doses instantly upon umbilical cord clamping. Nausea and vomiting were evaluated by means of Belleville scoring score, and an antiemetic was administered in case of 1 or more emetic episodes. Sedation was assessed just after delivery and postoperatively for 6 hours using the modified Ramsay sedation scoring. Statistical analysis. Sample size calculation was done using a two-sided significant level of 0.05 and a power of 80% with 40% accuracy. P was calculated as 0.5 for the propofol and midazolam groups and 0.9 for placebo group. Analyzed by analysis of variance for quantitative variables and chi-square test. P-value of less than 0.05 was considered statistically significant. These were my results. And the total incidence of both nausea and vomiting and the use of rescue treatment was significantly lower with propofol and midazolam compared to the placebo group. Discussion. High incidence of interrupt nausea and vomiting during spinal anesthesia during cesarean section was confirmed in our study, similar to the previous studies. The parturients who received low doses of propofol or midazolam after delivery experienced less nausea and vomiting compared to the parturients who received saline. No significant respiratory depressant effects were observed. Numazaki et al. Showed that low doses of propofol reduces interrupt nausea and vomiting during cesarean section under spinal anesthesia. In a study, our overall incidence of nausea and vomiting and antiemetic usage was lower in both propofol and midazolam groups. Conclusion. Subhypnotic doses of midazolam or propofol are effective in the prevention of nausea and vomiting during and after cesarean section with spinal anesthesia and does not significantly influence the hemodynamics of the patients. Thank you.
Good morning, Meenakshi. So whether any patient had hypnosis after this, because it varies now, even if you are giving a fixed dose, sometimes that how many milligram you gave? Propofol 20 milligram.
Propofol bolus 20 milligrams.
20 milligram. Any patient became drowsy or something because there is a danger of aspiration, no? All these section patients.
2 patients were drowsy, ma'am, but not to the level of they were able to converse, ma'am, not that drowsy.
So you were telling that patient blinded to the study gave because he doesn't know for what you are giving, and you are asking him to give third person to give this propofol and midas. Yes, especially one midas. 20 milligram propofol won't cause. Sometimes it's one midas.
After that, infusion was also started, ma'am.
Infusion
propofol
of what?
Infusion of propofol infusion after 20 mg bolus. 1 mg per kg.
Okay.
Infusion per hour.
Okay, but you have to be careful about the reflexes. Otherwise, or section patients, there is a danger without protecting airway when you start propofol. If the other person is not aware of this, there is a danger. Okay. Anyway, you have mentioned in your heading, title it proper, means subhypnotic doses. It is not that hypnotic doses, that I noted. What about ondansetron you didn't give for any of these patients? Only if they have 1 or more episodes of vomiting.
Yes, ma'am.
Otherwise, you didn't give for any other patient. For all patients, you didn't give.
No, ma'am.
Okay. For, how much was the difference for the propofol and midas? Any difference is there? Antiemetic dose in the postoperative period, I am asking. Whether between propofol and midas, any difference?
Midazolam, there was better control of nausea and vomiting, ma'am, than
propofol.
In our study, what we observed.
Okay, though propofol is considered as it has antiemetic properties, you are telling midas is, whether any literature, any similar evidence is there?
Actually, the other study which I found was propofol was better, but in my study I got midazolam.
You got midas. No, so you have to continue your study. Larger numbers you have to take and see.
Yes, sir.
Okay, and this you have to be very careful whether conscious level of hypnosis, hypnotic dose, you have to be careful. Sir. Sir got disconnected. Okay. Next person.
Next person is Dr. Minu.
Greetings all. Title of this study, the effect of dexmedetomidine on hemodynamic response and agitation score in modified electroconvulsive therapy, a prospective double-blind randomized controlled trial. Introduction. Mental disorders are highly prevalent in all regions of the world and represent a significant source of disability and social burden worldwide. ECT is well-known treatment for psychiatric patients like depression, OCD, bipolar disorder, schizophrenia, unresponsive to pharmacotherapy. The typical cardiovascular response to ECT consists of sympathetic response in terms of tachycardia and hypertension lasting 5 minutes or more. Dexmed is as an alpha-2 adrenergic agonist with a sedative, sympatholytic, and analgesic effect. It attenuates the stress response to hemodynamic changes. Emergent agitation occasionally seen in some patients after ECT. Dexmed is effective in management of this emergent agitation following ECT. Aim of the study is to assess effectiveness of injection Dexmed 1 microgram per kg IV in ECT in terms of attenuation of stress response, motor seizure duration, recovery time, sedation, and agitation. Primary objective of the study is to assess hemodynamic parameters of patients in terms of heart rate and mean arterial pressure. Secondary objective is to monitor post-ECT agitation in terms of RASS score, to assess motor seizure duration, recovery time in terms of time to spontaneous breathing, time to respond to verbal commands. After approval from the IRB and written informed consent from all the patients and relatives, study was carried out in Psychiatric Department, Sati Hospital, Bhavnagar. After thorough pre-anesthetic checkup, 60 patients of either sex between the age of 18 to 60 years undergoing ECT for various psychiatric disorder with ASA grade 1-2 were included. Patient excluded were those who refused to give consent, known sensitivity to general anesthetic drugs and Dexmed, pregnancy, lactation, past history of MI, congestive cardiac failure, and respiratory illness like asthma and COPD. NBM status was confirmed. Serial number was given by computer generated randomization. Multipara monitors were attached. Basal parameters noted. Patients were pre-medicated with injection of ondansetron and glycopyrrolate. Group N include patients receive normal saline 100 ml IV over 10 minutes, and Group D will have patients receive Dexmed 1 microgram per kg diluted to total volume 100 ml IV over 10 minutes. Oxygen was supplemented. During the infusion of the study, the patient was monitored for pulse rate, systolic BP, diastolic BP, mean arterial pressure, SpO2 at 1 minute, 5 minutes, and 10 minutes of infusion. As the volume of the study was over, induction was done with injection thiopentone. After loss of the eyelash reflex, the succinylcholine was given, and ventilation was assisted with bag and mask, and oral soft white block was placed. ECT stimulus was delivered, and motor seizure duration was noted. Above mentioned parameters were again noted at 1 minute, 5 minutes, and 10 minutes of the electrical stimulus. Recovery of the patient was assessed with the ability of the patient to breathe spontaneously, to open eyes, to shift to post-anesthetic care unit. After shifting to PSA, patient was monitored for next 50 minutes for vital parameters and recovery. RASS score was used to assess the recovery at 0, 15, 30, and 45 and 60 minutes. Patient was watched for adverse effects like hypertension, tachycardia, arrhythmia, dry mouth, nausea, and vomiting. Observation and results of the study. Both the groups were comparable in terms of the demographic data. Hemodynamic parameters in terms of the heart rate, mean arterial pressure were significantly reduced in Group D as compared to Group N. Patients were calm and sedated with prolonged RASS score in Group D as compared to Group N at 0 and 15 minutes. Discussion of the study will include ECT is associated with generalized autonomic nervous system activated, leading to sudden surge of catecholamine. Dexmed as a pre-medication blunt the hypodynamic response and improve the intra-procedural parameters to ECT. In present study, heart rate as systolic, diastolic BP, mean arterial pressure in both the groups were comparable from the baseline till 5 minute infusion. After 5 minute infusion, these parameters significantly decreased in Group D as compared to Group N. In post-ictal period, patients' recovery in terms of the RASS score was prolonged in Group D as compared to Group N. Seizure duration and time taken for spontaneous breathing were comparable in both the groups, while time taken for eye opening and shifting of patient to recovery room was prolonged in Group D. Complications was not encountered during the study. Study carried out in 2007 by Z. Bezek et al. Found that Dexmed administered before induction of the anesthesia is useful in preventing the acute hypodynamic response after ECT without altering seizure duration and recovery time, which is comparable to the present study. Conclusion of the study that dexmedetomidine is a good choice as a pre-medication before ECT procedure and can be given in high-risk patients with minimal complications. Thank you.
Yeah, good morning, Meenu. It is just to see the hemodynamic response or hyperdynamic, something you said? Meenu.
Good morning, ma'am.
Yeah, good morning. It is to see the hemodynamic response, to compare the hemodynamic response when you give dexmed pre-medication in ECT.
Yes, ma'am. Yes, ma'am. Dexmedetomidine attenuates the hyperdynamic response created by the ECT, stimulus teaser created by ECT. Then it attenuates the tachycardia and hypertension
All those
caused by
things.
ECT.
Okay, following ECT was less with the dexmed. Whether
Yes,
we
ma'am.
can use dexmed for induction then instead of thiopentone 2 agents?
No, ma'am. We cannot use the induction agent, ma'am. That is for pre-medication and after pre-medication.
Pre-medication only. Okay. Sir.
You are infusing dexmed over 10 minutes.
Yes, ma'am. Yes,
To go for ECT, or you have to in the hello.
Hello, yes, sir.
How many only you wait only for 10 minutes for dexmed infusion and then you start your procedure?
We wait. I have waited for on the till the infusion ends. And after 2 minutes, I am start the induction agent, and after that EC infusion.
After that you start your procedure.
Yes, sir.
Do you think within 10
Sorry,
100%?
sir.
Do you think within 10 minutes your dexmedetomidine action will come, or you have to give more time?
Infusion. My infusion finished mostly in 10 minutes. In all the patients. After 10 minutes, we take the patients on ECT table and start induction agent. Till that patient is sedated in my result. Okay, thank you, sir. Our next person is Dr. Meghna.
Good morning, everyone. My name is Dr. Meghna from MS Ramaya College. My topic is comparison of effects of melatonin with alprazolam on preoperative anxiety in adult patients undergoing laparoscopic cholecystectomy under general anesthesia. Coming to the introduction, preoperative anxiety is often experienced by patients and correlates with unfavorable outcomes. Allaying it is the main goal of premedication, for which benzodiazepines are the most commonly used. Melatonin has a specific property of producing anxiolysis with no impairment of cognitive function. This study aims at evaluating the efficacy of oral melatonin and alprazolam on preoperative anxiety and sedation and postoperative pain. Primary objective being to compare the effects of melatonin and alprazolam on anxiety, sedation, and orientation. Secondary being the comparison of effects on postoperative analgesia. Inclusion criteria, patients 20 to 70 years of age belonging to ASA 1 and 2. Exclusion criteria, patients on steroids, pregnant women, conversion to open cholecystectomy, and patients with allergy to drugs. Materials and methods, as mentioned, patients undergoing lap chole under GA satisfying the criteria will be included. It is a prospective randomized comparative study done over a period of 2 years after ethical committee clearance and written consent. Based on previous literature, sample size was calculated and we included 45 patients in 3 groups, which is a total of 135 patients belonging to ASA 1 and 2, posted for laparoscopic cholecystectomy, generated by computer random numbers. Pre-medication, Group M received oral melatonin, 3 mg 2 tablets. Group A received oral alprazolam, 0.25 mg 2 tablets, 120 minutes before induction. Group C was a control group. Methodology, all patients were subjected to pre-anesthetic evaluation and relevant investigations done. They were explained about the anesthetic technique. On the previous day, a written informed consent was taken. This shows the diagram of the VAS score and the Ramsay sedation scores. After arrival of the patient in the operation theatre, a peripheral IV line was secured and baseline vitals were noted. Maintenance IV fluids were started and all patients were induced with general anesthesia protocol with endotracheal intubation. Intraoperative vitals were noted throughout the surgery and paracetamol was given half an hour before closure. The patients were reversed uneventfully and shifted to wards with postoperative analgesia orders and VAS-P was seen up to 24 hours. If more than 4, rescue analgesia was given. Statistical methods for continuous measurements, mean with standard deviation were used. And for categorical measurements, numbers were used in percentage. Chi-square test and fissure extract test were also used. Coming to the results, VAS-A with comparable demographic parameters, the preoperative anxiety at baseline was comparable between 3 groups, whereas after 120 minutes, the group M had lesser anxiety compared to other 2 groups and was statistically significant. Ramsay sedation score as well as the orientation score was comparable between 3 groups at baseline and after 120 minutes. Coming to VASP, at 0 hour and 1 hour postoperatively, group M had lesser VASP and was statistically significant compared to other 2 groups. However, clinically not much of difference was seen. Rescue analgesia consumption was comparable between 3 groups as well as the postoperative side effects. Coming to discussion, preoperative anxiety has detrimental effects as we have discussed. Hence, we studied about pre-medication with alprazolam and melatonin to alleviate this. We found that oral melatonin, when used as a pre-medicant, is an effective alternative to alprazolam without impairment of cognition. Previous studies done by Arvind Kare et al., Tushar Patil and Madhuri Eskurdi, as well as Krishna Pokharel, comparing similar drugs using similar scores, also found similar results. Limitation: few patients experienced post-operative side effects like nausea, irritability, as already mentioned. Future scope: further studies need to be conducted, including comparison with other drugs, as well as a larger sample size to prove the efficacy of melatonin over benzodiazepines. We conclude that melatonin, when used as a pre-medicant, is an effective alternative to alprazolam for better anxiolysis and analgesia without impairment of cognition. Here are the references. Thank you all.
Yeah, good morning, Meghna. Well presented. Only thing is melatonin, what is the mechanism of action you said? Melatonin for anti-anxiety? Meghna, are you here? Meghna, good morning. Yeah, well presented, Meghna. Yeah, what is the mechanism of action of melatonin for anti-anxiety? Yeah.
It acts on MT1, MT2 receptors as well as NMDA receptors and produces anxiolysis and analgesia without impairment of cognitive and psychomotor functions compared to benzodiazepines, which are associated with sedation and bit of psychomotor dysfunction in patients.
Okay, and another thing is when you give drugs like this, 2 drugs, whether it is pharmacologically equivalent, the melatonin dose and alprazolam dose, whatever, whether any study is there from where you got this this thing, melatonin this much to be given.
One of my parent thesis article had done by Arvind Kare et al. In 2017, they had used similar drug dosages for comparison between two same drugs as my study. But pharmacological equivalence could not be assessed. Further studies need to be done, and also larger sample sizes need to be included in order to prove the efficacy of melatonin over alprazolam with respect to anxiolysis and analgesia. Okay. Pharmacological equivalence was not appropriate in our
not appropriate. And whether you have given it in OT or pre-op in the ward, only these 2 drugs were given.
I have given in the pre-operative room, ma'am. 120 minutes before.
120 minutes before you.
To be shifted earlier to the pre-operative room, and we have given in the pre-operative.
Okay, but Ramsay sedation score and all were equal according to the results. All the things, only statistical significance you saw with VAS score. Yeah.
Yes, and pain. VAS for anxiety,
VAS
and VAS for pain.
Okay. Clinical significance you didn't see also.
No, ma'am. Clinically and clinical features wise, as well as the patients asking for rescue analgesia were comparable between group A and group M, but the consumption of rescue analgesia was higher in group C, that is the control group.
Okay, whether we can practice this now, that is the question. When you do research, you have to see also whether we can practice.
Yes, ma'am. It is safe to practice considering that no significant hemodynamic alterations intraoperatively were there, and considering the fact that post-operative side effects were also minimal and not much of irritability or deep sedation was seen with either of the drugs, ma'am.
Sir.
Okay.
Next presenter is Dr. Mehul.
Our paper on comparison of ketamine propofol versus ketamine dexmedetomidine in sedation and analgesia in patient undergoing upper limb surgery under supraclavicular plexus block. Sedation and regional anesthesia has been shown to increase patient acceptance to the regional anesthetic technique, subsequently patient satisfaction. Drawback like pain with the puncture site, fear of needle, recall of the procedure may lead to anxiety and uncooperation in the patient despite of satisfactory effect of regional anesthesia. This factor may lead to importance of use of supplementary sedation and analgesia that offer the anxiolysis, analgesia, and amnesia to the patient. Benefit of regional anesthesia to the patient are staying away during the surgery, post-op analgesia, early family contact to the anesthetist are cardiovascular and respiratory stability, preservation of protective airway reflexes. Aim of our study is to compare the efficacy of ketamine dexmedetomidine versus ketamine propofol combination in patient undergoing upper limb surgery under supraclavicular brachial plexus block for sedative effect and pain or needle prick while giving the block. A prospective randomized double-blinded controlled trial was conducted after obtaining the patient's consent, ethical committee approval, and CTRI approval. Inclusion criteria were patient of ASA 1 to 3 physical status, ages of 18 to 70, BMI 18 to 40 kg, either sex of patient, patient posted for elective and emergency surgery. Exclusion criteria were patient with history of hypersensitivity to local anesthetic agent, allergy to study drug, uncontrolled hypertension, cardiac, respiratory, and neurological disease, pregnant or breastfeeding female. Failure or unsatisfactory action of group were excluded from the study. Participants were randomly allocated in group KP and group KD, 35 in age. In operating room, ECG, pulse oximetry, APP were attached. Sedation was started 10 minutes before placement of block. Group KP received loading dose of ketamine 0.5 mg per kg and propofol 1 mg per kg over 10 minutes, followed by maintenance dose of ketamine 0.3 mg per kg per minute and propofol 10 microgram per kg per minute. Group KD received loading dose of ketamine 0.5 mg per kg and dexmedetomidine 0.5 microgram per kg over 10 minutes, followed by maintenance dose of ketamine 0.3 mg per kg per minute and dexmedetomidine 0.3 microgram per kg per hour. Supraclavicular brachial plexus block was given by USG or PNS guide. Interoperatively, hemodynamics, transient score, and side effects were recorded. Statistically, analysis were done by using independent sample t-test to compare the continuous outcome, and the descriptive statistic was used to depict the baseline profile of the study participants. Chi-square test was used to compare the categorical outcome, observation, and the result. And the baseline profile of the participant were similar across the group. Significantly higher proportion of patients in group KP, 42.9% patient experienced pain on needle break compared to group KD, 5.7% patient. Side effects were higher in group KD, 28.6% patient experienced nausea in group KD, while in group KP, 5.7% patient experienced nausea. The RSS score was consistently higher in group KD compared to group KP. Similar study conducted by Mona Muhammad in 2017, they observed that RSS score and the incidence of nausea was higher in group KD, while in our study we also noted the same. Amarjit Kumar conducted a study in 2017, they observed that the RSS scores were higher in dexmedetomidine group, and we also noted the same. In this study, the heart rate was lower side in dexmedetomidine group, while in our study there was no significant difference noted between the group. The scope of the study to reduce the procedural cost, we use RSS for sedation monitoring, but using this we can give more effective sedation. Limitation of study, we have small samples, by using larger samples we can get better results. We concluded that group KD was better in terms of less pain on needle prick, better sedation than group KP, but group KD had a higher incidence of nausea than group KP. Thank you.
ಮತ್ತೆ ಮಾಡೋಣ ಮಾಡ್ಲಾ ನಾನು ಮಾಡ್ಲಾ ಕಾಲ್ ಮೊನ್ನೆ ಅದೇ ಇಲ್ಲ I will attend this full.
Hello, Mehul. Good morning. Do you face any complications like sedation, more sedation in any of your patients?
Yes, sir. Sedation was higher in in dexmedetomidine group compared to ketamine propofol, sir. But sedation score was not more than 5 in each sedation score. Only 3 to 4 in dexmedetomidine group and 3 to 4 in propofol group.
There are more chances of nausea in your dexmedetomidine group. Why?
Yes, sir. In propofol group, propofol also has an antiemetic action, but in dexmedetomidine, ketamine and dexmedetomidine did not have any antiemetic action. So we noted the dexmedetomidine group has a higher incidence of nausea, sir.
Mehul, this was given only during the initial period when you are giving the block, only to reduce the block, reduce
Yes,
the
ma'am,
inconvenience. Yeah.
Loading dose was given 10 minutes prior to the block, and the maintenance dose of infusion continued throughout the procedure, ma'am.
Throughout the procedure.
Yes, ma'am.
Okay. Whether it affected post-op analgesia, duration of analgesia, whether you checked that also?
Yes, ma'am. Duration of analgesia was longer in dexmedetomidine group compared to propofol group.
This ketofol is common now, no? Where you can see what are the advantages of ketamine propofol together?
Ma'am, ketamine also reduce the hypertension and bradycardia associated with propofol group, and they reduces the requirement of each drug while using the combination.
Many places ketofol is recommended induction agent now. Ketofol is compared to other ketamine and propofol alone also.
Yes, ma'am.
So, yeah. Okay. That's all, ma'am. Next person.
Okay, so next person is Dr. Mekala Rani.
Dr. Rani, and tramadol for control of shivering under spinal anesthesia. Shivering is involuntary oscillatory muscular activity, physiological response to core hypothermia and attempt to raise the metabolic heat. Prolonged impairment of thermoregulatory autonomic control under anesthesia, along with cold environment of the operating room and cold infusion periods, contribute to fall in the core temperature.
Sound is not clear, madam.
Transfusion reactions, drug interactions, pre-existing high-grade fever, and infusion of contaminated IV fluid. Perioperative hypothermia, most common cause of shivering. In a shivering patient, oxygen consumption may increase to 200 to 500% along with a linear increase in the carbon dioxide production. It also increases intraocular and intracranial pressure and may contribute to increased wound pain, delayed wound healing, and delayed discharge from the post-anesthetic care. Various therapies to prevent the shivering include opioids, ketamine, propofol, granicytine, doxapam, physostigmine, clonidine, and nevaform. Tramadol hydrochloride is a mu opioid receptor agonistic drug, has a modulatory effect on the central monoaminergic pathways, and thus inhibits the neuronal uptake of noradrenaline, serotonin, and encourages the hydroxytryptamine secretion, which resets the body temperature regulation center. It has gained a reputation in many clinical trials for the control of shivering. Butorphanol, an easily available opioid, acts through kappa and mu receptor agonistic modulation. Aims and objectives. The study is to compare the effectiveness of butorphanol and tramadol in control of postprandial shivering has the following objectives: duration of onset of cessation of shivering and hemodynamic variations. Methodology. After obtaining approval from Institution Ethical Committee and informed consent, it is a prospective randomized double-blind control study. Study population is 40. They divided into two groups. Group T, IV bolus of 550 mg of tramadol. Group B, IV bolus of 1 mg of butorphanol. Period of study 12 months. Inclusion criteria. All the patients belong to ASA physical status 1 and 2 scheduled for urological and general surgical procedures under spinal anesthesia who develop shivering during intra-postoperative period during the age group of 18 to 60 years. Exclusion criteria. Patients with hyperthyroidism, morbid obesity more than 40 kg per meter square, fever more than 37 degrees, compromised cardiorespiratory function. Procedure. Informed consent was taken from the patient. Patient kept nearby for 6 hours before surgery. In all cases, standard monitors were attached and baseline parameters recorded. In IV fluids infused by room temperature and ambient temperature of operating room maintained at 22 to 28 degrees. Spinal anesthesia were performed with 25 or 26 gauge squinty spinal needle in sitting position, 60 L through L4 interspaced with high-way bupivacaine and dose of 2.4 to 3.2 ml to achieve desirable levels. After induction of spinal anesthesia, patients were observed for occurrence of shivering until post-operative period. The intensity was graded into 0 non-shivering, 1 shivering in face and head, 2 visible tremors involving the more than one group of muscles, 3 gross muscular activity involving the entire body weight shaking. Only the grade 2 and grade 3 cases during perioperative phase were given treatment on an intentional basis. At the onset of shivering, all the patients given oxygen via face mask at 5 liters per minute and 1 ml of studied drug as per group allocation. Shivering control was defined as complete when post-treatment. The shivering score declined to 0. The time taken for cessation of triggers and hemodynamic changes was recorded at regular 5 minutes interval up to 20 minutes. Recurrence of shivering, if any, noted, treated with pethidine in a dose of 0.5 mg per kg. Results. Demographic data and duration of surgery were found to have no statistical difference between the two groups. In first minute after administration of drug, there was significant relief in abolition of shivering with butorphanol than tramadol. 6 patients in tramadol had relief, whereas 14 patients in butorphanol had relief in first minute. There was recurrence of shivering noted in the one patient of tramadol after 20 minutes. A drop in the systolic BP, an increase in the diastolic BP, and increase in the heart rate was observed in both the groups during onset of shivering. There was no nausea and vomiting in patient with during intraoperative period. Grade 1 sedation was observed in butorphanol treated with treated and no sedation with the tramadol. It is a mean heart rate, different interval levels, mean systolic blood pressure, diastolic blood pressure. Discussion. Shivering presents a common perioperative problem causing hypertension and tachycardia and increased metabolic demands and interfere with intraoperative monitoring of ECG, BP, and oxygen saturation. In our study, butorphanol was quicker compared to tramadol in suppressing shivering, whereas in study conducted by Jain, the time taken for complete abolition of shivering in both groups were almost all the time. Butorphanol was quicker than Petrin in abolishing shivering successfully. Relapse is more with Petrin than butorphanol. Conclusion. Butorphanol is superior to tramadol for the management of postoperative shivering due to high rates of success, earlier onset of action, and lesser recurrences, comparable safety. These are the references, and thank you.
Michelle, good morning.
Good morning, ma'am. Actually, that was not my presentation. The person before me is presented. Mine will be next, ma'am.
Okay. I don't, anyway, the name they mentioned was Michelle. That is what, okay, sorry.
Yes.
Hello, madam. Who is
Yes.
Okay. See, you were telling that consent is taken for all patients, but you are taking only patients with shivering. That means for all patients you take consent, or once the shivering happened, you will go and take. My doubt I am asking. So this patients who are taken in this study only after when they start shivering. But how will you take the consent then before the procedure? For all spinal patients, you. Your
hello, ma'am.
Yeah. No, thing is that my question is, these patients were taken for your study only once they start shivering.
Yes,
whether you have taken the consent for all patients, all spinal patients, and or after once they start shivering, you have to go back and take consent.
No, ma'am. For all the patients, I take consent, ma'am.
All the patients
for spinal anesthesia.
Spinal anesthesia. Okay. And whether the dose of second dose of another drug you were mentioning about pethidine given, that is more for tramadol group.
Tramadol group, ma'am.
Because you see patients most of the time after giving the first dose of anti-shivering agent also, no? Again they so this
after tramadol injection, after 20 minutes again the shivering occur in tramadol group, ma'am. With butorphanol there is no not occur, ma'am.
Okay. Butorphanol is freely available? Butorphanol,
no,
whether it is freely available in your college?
In our hospital,
after you started the study, it is available?
No,
like,
ma'am.
No, it is available.
It's available, ma'am.
Okay. What are the other complications of shivering?
Increase for shivering, there is a delay in the wound healing. There is a pain and a delay in the discharge, ma'am, from the post anesthesia care unit.
What about oxygen consumption demand? So you have to be very careful in cardiac patients and all. When they shiver, you have to be very. Other than that, patient discomfort is there. But in cardiac patients and patients with hemodynamic compromise and all, you have to be really careful. Always supplement oxygen and as early as possible control shivering and take all the precautions for maintaining the temperature also, along with other measures. Maintain the OT temperature, warm fluids, all those things you can give. Okay, sir.
How butorphanol acts as an anti-shivering agent?
Normally, it acts on the kappa receptor and a partial agonist at partial agonist at mu receptor. It depresses the temperature. It acts on the temperature regulation center, sir. Hello, sir.
Yes, sir. So our next presenter is Dr. Michelle.
I'm Dr. Michelle Raphael. I will be presenting my paper, Comparative Efficacy of Palonosetron Dexamethasone Combination, palonosetron or dexamethasone alone for prevention of postoperative nausea and vomiting in patients undergoing laparoscopic surgeries. PONV can be as high as 50 to 70% when no prophylaxis is used, and despite the availability of multiple antiemetic drugs, PONV continues to be a problem associated with laparoscopic surgeries. Palonosetron is a second-generation 5-HT3 receptor antagonist with greater affinity and potent binding tendency as compared to the first-generation drugs, and it has a half-life of 40 hours. Dexamethasone is a corticosteroid which exhibits antiemetic action. The aim of the study was to assess comparative efficacy of palonosetron dexamethasone combination therapy in preventing postoperative nausea and vomiting with palonosetron and dexamethasone alone. Objectives were incidence and severity of nausea in first 24 hours of postoperative period and incidence of vomiting in first 24 hours of postoperative period. It was a prospective observational study with 39 participants in 3 groups. Inclusion and exclusion criteria were as mentioned in this slide. Observer 1 was the anesthesiology resident who observed and recorded study parameters and was blinded to the study. Observer 2 was the consultant anesthesiologist who administered the study drugs intravenously. After obtaining informed consent, the study was conducted. Induction and maintenance of general anesthesia was as per standard of care and uniform in all patients. Study drugs were administered after intubation as per the discretion of the observer 2. Groups and dosages of study drugs. Group P, patients who were administered palonosetron 0.075 milligrams IV. Group T, patients who were given dexamethasone 8 milligrams IV. And Group C, patients who received both palonosetron and dexamethasone. Patients were interviewed in the postoperative period and were asked to grade the severity of nausea as per the VAS scale. Rescue antiemetic IV metoclopramide was employed whenever needed. Coming to the results, the first table shows us patient characteristics, and the second table shows us duration of anesthesia across the 3 groups. In table 3, we see the incidence of nausea in group 3 at the various post-op intervals. Maximum incidence is in group D, and at 4 hours post-op interval, maximum incidence is in group D, and the difference in incidence is statistically significant. In table 4, we see the mean VAS scores for severity of nausea, and we see the difference in mean VAS scores for severity of nausea amongst the 3 groups is statistically significant at 1 hour and 4 hour post-op interval. These 2 post-op intervals are further analyzed using Pitay's post-hoc test, and we see the mean difference between the mean VAS scores for severity of nausea is statistically significant for group B versus P and group D versus C at 1 hour and 4 hour post-op. However, it is not statistically significant for group P versus C. In this table, we see the incidence of vomiting is maximum in group B and least in group C, and the difference in incidence is statistically significant. Coming to discussions, the severity and incidence of nausea is maximum in group B in the early postoperative period. There was no statistically significant difference between severity of nausea between group B and C. Maximum incidence of vomiting was in group D and least in group C. In adult patients undergoing laparoscopic surgeries, intravenous palonosetron 0.075 milligrams is more effective than intravenous dexamethasone at reducing severity of nausea in early postoperative period. Palonosetron is more effective than dexamethasone at reducing incidence of vomiting in the postoperative period. However, addition of dexamethasone to palonosetron does not confer any additional advantage compared to palonosetron alone regarding reduction of postoperative nausea and vomiting. These were the conclusions. These are my references. Thank you.
Yeah, good morning, Michelle. So your conclusion is palonosetron dexamethasone combination is of not much use.
No, ma'am. My conclusion is that palonosetron is more effective in preventing reducing the severity of post-op nausea and vomiting in adult patients. However, the addition, we were trying to see if the addition of dexamethasone is conferring any additional property. And we found that the addition of dexamethasone is not really adding value to palonosetron's antiemetic and anti-nauseatic properties.
But it present PONV guidelines, what is the role of dexamethasone? Postoperative nausea vomiting guidelines.
Yes.
Yeah, how is it placed?
It is being used across multiple centers, especially for ENT surgeries and surgeries where the GI tract can be stimulated either via blood or any irritant in the GI tract or any external sources, like in our laparoscopic surgeries when there will be irritation of the peritoneum and the 5-HT3 receptors peripherally present in the GI tract, they can be stimulated. So hence we use dexamethasone also in our study.
Okay, it is described in the first hour of surgery. Dexamethasone, better if you are giving, better to give.
Yes, ma'am.
Yeah, better.
Yeah, ma'am.
To
We have
start.
given in the induction only. Induction for both at induction time, both dexamethasone or palonosetron as per the consultant's discretion. But it is uniformly given at induction for all patients.
Okay, sir.
Okay, so we'll move on to the next presenter, Dr. Mohammed. Sorry, Miss Noor Jahan.
A very good day to one and all. Myself, Dr. Nurjahan, PGT RIMS Anesthesiology Department. I'm going to present an e-paper on the tighter comparison between butorphanol and nalbuphine during balance anesthesia in patients undergoing elective upper abdominal surgery. The co-author PG Guide Affiliation Institution Conference Registration Number CT are listed in the slide. Next, move to the introduction. Perioperative administration of opioids attenuate intubation response and provide good intraoperative and postoperative analgesia. Butorphanol and nalbuphine are commonly used as preoperative analgesic. Both are equianalytic, but nalbuphine doesn't increase cardiac work. And objective are to determine the stress response, intraoperative hemodynamic stability, time to fast rescue analgesia, and side effect, and to compare the recovery profile in terms of emergence time, extubation time, time to reach Ramsay sedation scale of 2. Materials and method. Study design, study settings, population, randomization, blinding, inclusion and exclusion criteria are listed in the above in the slides. The following parameters are monitored and recorded. Results and observation. Intraoperative hemodynamic stability, no statistical significance difference were seen. Sympathetic response of intubation was suppressed by both the drugs equally. Comparing the mean of time to reach Ramsay sedation scale of 2 shows that there is no statistically significant difference. Emergence time between the two groups is found with p-value less than 0.61, which is not significant. These regions and observations are shown as pie chart and bar chart in the following 2 slides. These are the bar chart. Next, move to the discussion. In our study, no significant difference were found in intraoperative hemodynamic stability. Nalbuphine group had better recovery profile in regards to emergence times, extubation times, longer duration of analgesic potency, less postoperative nausea and vomiting as compared to butorphanol group. Our study was found to be similar with study of Dulara SC et al. Conclusion. Our study found that IV nalbuphine had better recovery profile, long analgesic property with lesser side effect under this guided balance anesthesia. These are the references. Thank you.
Good morning, Noor Jahan. See, my only that your objective, so many objectives were there. You should have one primary objective and others you should take a secondary objective. So many things you were seeing in your objective. Whether what is your primary? Only one objective. If you what you were looking for. And you should differentiate between the aim and objectives also. So everything together you have written, and so many objectives were there. Better have one primary objective and others take it as secondary objectives. Okay. What was your primary objective? Whether you attained that objective at the end of conclusion, means at the end of the study?
Ma'am, to determine, primary objective is to determine the stress response, intraoperative hemodynamic stability, time to reach the Ramsay sedation scan of 2, and time side effect and time to reach.
That many you Which was better, nalbuphine, or you attained your primary objective?
Ma'am, nalbuphine is better as compared to butorphanol.
What dose of nalbuphine? Dose?
Nalbuphine 0.1 milligram per kg body weight, ma'am.
Okay, it is available in your hospital. Nalbuphine is available in your hospital, freely available. Whether we
I'm available, but it's not commonly used here.
Not commonly used. For a study purpose, you have.
Yes, we are using.
Any nausea, vomiting? Anything? Have you experienced any patients with the other side effects?
Ma'am, in nalbuphine we got one patient developing nausea in nalbuphine, but butorphanol, though we got.
Okay, sir. Any more questions?
Okay. What is the level of sedations in your patients? Hello.
Sir?
Yeah, you marked the level of sedations. Level of sedation post-operatively.
No.
Nurjahan, sir is asking, what was the level of sedation in your patients? Grades of sedation have you marked?
Ramsay sedation score of 2.
So what level, what grades were there in both the groups?
Grade 2.
In both the groups, same? Okay, so we'll be moving on to the next presenter, Dr. Mitali.
Hello everyone, I am Dr. Mitali Patel to present a paper on topic to study the analgesic effect of epidural ropivacaine for post-operative pain relief for major orthopedic surgeries. Regional anesthesia is acceptable as a reliable post-operative analgesia. Epidural anesthesia is a time-tested technique for anesthesia as well as analgesia. Ropivacaine is a long-active amide local anesthetic, is an optically active pure as enantiomer of ropivacaine. It has good hemodynamic stability with acceptable level of cardiotoxicity and neurotoxicity. Purpose of this study to investigate the use of epidural infusion of variable concentration of ropivacaine to provide post-operative analgesia following major orthopedic surgeries. To assess and study the analgesic efficacy of ropivacaine for post-operative epidural analgesia in terms of quality, duration of action, and side effects. 50% of age group 18 to 60 are with ASA group 1 and 2 undergoing elective orthopedic surgery were divided into two groups. One group A received 0.25% and ropivacaine epidurally. Another group B received 0.5% ropivacaine epidurally. Patients were monitored for onset, duration, and quality of analgesia, cardiovascular stability, and side effect any. With inclusion criteria, patient of age group 18 to 70 years of either sex with ASA grade 1 and 2 undergoing major lower limb orthopedic surgeries. Exclusion criteria include unwilling patient, emergency surgery, known case of hypertensive reaction to local anesthetic, coagulation disorder, and local side effects, history of drug or alcohol abuse, and with ASA grade 3 and above. Yes, a detailed FPH checkup was done in all patients with include a detailed history and thorough physical examination. On arrival to operating room, 18 gauge IV line was secure and RS solution was started. Monitor connected and baseline value of heart rate and NIBP oxygen saturation were noted before procedure. Before commencement and patient were inserted a method of surgery and method assessment. Epidural top-up in each group was given after 45 minutes of administration of subarachnoid block. Vitals monitored in post of anesthesia care unit and involved before and after an epidural top up for 12 hours. SQ analgesia given at numerical rating scale level between 3 and 4. Occurrence of adverse effect of including bradycardia, hypotension, hypoxia, shivering, as well as nausea and vomiting was also recorded. Qualitative data were analyzed by applying chi-square test, paired t-test, and paired t-test. P-value less than 0.05 was considered significant. Now, both groups were comparable in age, weight, height, age, grade, and gender, mean arterial pressure, and heart rate. Table 1S table suggests there was a significant difference noted in duration of motor blockade and duration of epidural analgesia, and no difference was noted in duration of surgery. The comparison quality of post-operative epidural analgesia between two groups are given in table 2. Patient in group B has pain relief for 7 hours. Patient in group A has pain relief for 6 hours. The epidural infusion was associated with significant difference and stable blood pressure and heart rate in study group B as compared to study group A. The regression of sensory block was prolonged in group B. The speed of neural block is proportional to concentration of local anesthesia solution. We aim to compare the duration of blockade and analgesia in epidural as well as the incidence of complication between different concentration of ropiacine in patients who underwent lower limb orthopedic surgeries. The of motor blockade assessed by modified Broomer score was significantly increased in group B as compared to group A. We didn't note any significant difference between the group regarding hemodynamic variables, heart rate, and oxygen saturation. In both group A and B have good analgesia and muscle relaxation without any significant hemodynamic disturbance inoperatively and post-operatively. There was a complaint of shivering only in few patients. That too was not significant, as both 0.25% and 0.5% concentration of ropiacine were significant and effective for intrathecal or intraoperative, along with epidural use for post-operative analgesia. Conclusion: epidural injection of ropiacine in 0.5% dose decreased post-operative pain with reduced CNS toxicity in motor blockade as compared to 0.25% group in patient undergoing orthopedic surgeries. Its reference is given below. Thank you.
So, Mitali, you have given epidural alone for both the, means not spinal, only epidural you compared. 0.5% and 0.25, correct now, Mitali? Mitali, good morning. Mitali, mute.
Unmute,
yourself.
ma'am, please. Please unmute.
Mitali, unmute yourself. I think.
Yes, ma'am.
Yeah, now I can hear you. You have compared only put epidurals for different concentration of ropivacaine you tried.
Yes, yes, ma'am.
For post-op analgesia also.
Oh, yes, ma'am.
Okay. So, what are the advantages of giving higher concentration in the post-operative period?
Ma'am, the pain, post-op pain is much more less, and patient remains stable. Means even after post-op, patient complaint of pain is much less.
So for my doubt is for orthopedic patients, whether the movement will get affected. That is better. No, only analgesia is better. If you, if higher concentration, if motor block is there, whether it will affect the movement of joints.
Yes, ma'am.
Whether higher concentration when you use, whether it will affect the, it will cause motor block also.
Yes, ma'am.
So that also you have to assess that is whether that is good or not when you give higher concentration. And whether in between I saw in your slide it can be given intrathecal ropivacaine is acceptable. Whether
yes, ma'am, acceptable.
Sir, any questions?
Yes. You have given single shot epidural or you have kept epidural catheter?
Sir, we have kept epidural catheter for that 24 hours. Then we removed.
Okay.
In between, after 6 to 10 hours, we give if patient complain of pain, then we give the dose. The other no, sir.
Which one? Which is your rescue analgesic? You will give ropivacaine or you will give another drug?
No, sir. We'll give that tramadol.
How?
Sir, that 1 ml take 50 milligram in diluted dose, and then we give slowly for post-op.
Okay.
Okay, so we'll be moving on to the next presenter, Dr. Mohammed.
Good evening, respected teachers. Myself, Dr. Muhammad Abdul Salman. I will be presenting a paper on comparative study between transdermal buprenorphine and pain relief after adult cardiac surgery. It is a prospective, randomized, single-blinded controlled study. Introduction: pain after cardiac surgery is caused by multiple factors, hence various narcotic and non-narcotic medication has been employed. This study has been conducted on CABG and valvular surgery. The primary objective is to analyze the pain using visual analog score and requirement of rescue analysis. The objective is to analyze level of sedation, incidence of postoperative cognitive dysfunction, nausea, vomiting, respiratory distress, and pruritus. According to the method, after gaining approval from this institute with informed consent, 88 patients were selected out of 88 patients were divided into two groups, Group F and Group B. Group F had 44 patients and fentanyl patch of 25 micrograms per hour was supplied 6 hours before surgery. In Group B, buprenorphine 44 patients, buprenorphine of 10 micrograms per hour was applied 6 hours before surgery. Inclusion criteria: adult patients 18 to 70, ASA 1 to 3, BMI less than 28. Exclusion criteria: BMI more than 28, ASA grade 4, allergic to the study drugs and chronic analgesic medications, pregnant lady, bradycardia, and systemic diseases. Coming to the results, visual analog score compared to studying between buprenorphine and fentanyl. Fentanyl had more pain compared to buprenorphine. And then coming to the time for first rescue analysis, here also fentanyl patients with fentanyl required earlier rescue analysis compared to buprenorphine. And then coming to the total number of doses given, also patients with fentanyl required more doses of rescue analysis compared to buprenorphine. Coming to the sedation score, patients with buprenorphine had more sedation compared to. Coming to cognitive dysfunction, patients with buprenorphine had more cognitive dysfunction compared to fentanyl. Coming to adverse effects, patients with nausea, vomiting, respiratory distress have been consistently more in buprenorphine compared to fentanyl, whereas pruritus was more in fentanyl compared to buprenorphine. To the discussion, visual analog score, here it was insignificant, where Thakur et al. And Atkinson et al. Found it significant. Lisa, here I had significant finding. Similar was found in Thakur et al. And Atkinson et al. Where sedation is concerned, here I found it significant between 8 to 48 hours, whereas Thakur et al. Found it insignificant. And Philip et al. Also found it significant, but it was with fentanyl butorphanol. Coming to cognitive dysfunction, here I found significant, but nothing much studies have been done. But I found Shiba et al. One study, morphine versus fentanyl. Fentanyl had less sedation compared to morphine. Compared to adverse effects, pruritus, I found significant in this study, and whereas Kaur et al. Also found significant. Respiratory distress, it was significant in this current study, whereas it was contrast in Kaur et al. And Atkinson et al. Nausea, vomiting also was significant in this study. Atkinson, Thakur et al., Pandit et al. Also found the same, but Arora et al. What was opposite. Well, coming to conclusion, buprenorphine fentanyl application or patients with fentanyl showed higher need of rescue analgesia, and tramadol was adequate enough to provide pain relief as a rescue analgesia. Buprenorphine was associated with more sedation, cognitive dysfunction, respiratory depression, nausea, vomiting, whereas fentanyl was associated with pruritus. These are the remaining. These are the references, sir. Thank you.
Mohammed, good morning. Did you meet your objective? What was your objective of the study?
Good morning, ma'am.
Yeah, good morning. What was the objective of your study? Did you meet the objective? Did you
assess the need of, to assess the pain score by visual analog score and the need of rescue analgesia, ma'am.
Analgesia between
fentanyl and buprenorphine, ma'am.
Yeah, which is better for analgesia? So, which is better for analgesia?
Buprenorphine is better than fentanyl, ma'am, in terms of analgesia, ma'am. And
duration, how much was it? Transdermal, no?
Yes, ma'am, transdermal patch.
How number of hours compared to fentanyl? Duration, how much was it?
I didn't understand.
Duration, how much was it? Buprenorphine, duration of analgesia.
Ma'am, the
comparative?
fentanyl patch has a duration of 3 days, ma'am, for 72 hours, whereas buprenorphine has 7 days, ma'am. So we had considered 72 hours to compare the efficacy, ma'am.
Okay. Buprenorphine had longer duration.
Yes, ma'am.
Okay. Side effects were more for buprenorphine.
Yes, ma'am.
So what is your conclusion? What end result, whether we can do this practice?
Ma'am, in terms of pain, in terms of keeping pain in mind for us pain relief, buprenorphine is better than fentanyl. But in terms of side effects like cognitive dysfunction and all, buprenorphine is not good than fentanyl.
Okay.
Yes, ma'am.
So, final, whether we can use this, we have to still do studies or
yes,
see.
ma'am. We need some more studies in terms of cognitive dysfunction because nothing much has been studied on cognitive dysfunction, ma'am.
Okay, these are CABG patients, no? What you did studies
Ma'am,
were?
CABG and valve replacement surgeries, ma'am.
Valve replacement. Whether any other form of analgesia was given
No,
for
ma'am,
this
no.
patient? Only this transdermal,
Yes,
either fentanyl or
buprenorphine, ma'am. Yes, ma'am.
buprenorphine.
Yes, ma'am.
What about the postoperative PONV? You compared PONV in these patients, postoperative vomiting,
nausea,
nausea,
vomiting,
that is
ma'am.
also a complication.
Yes, ma'am. It's the secondary object. Yes, ma'am. It is
secondary objective was that. Which,
yes, ma'am.
Okay, sir.
Good morning, sir. Hello, good morning.
When you extubate your patient after CABG?
Once the patient.
When do you extubate your patient?
Ma'am, once sir, once the patient was awake, if he met the criteria of extubation, he was extubated, sir. On an average, patient was extubated about 6 to 12 hours post surgery, sir.
6 to 12 hours. So your study will start after 6 to 12 hours, no?
We had considered at the time of extubation, sir, as 0 hours.
Okay, you have not mentioned that thing.
Yes, sir.
Okay.
Yes, sir.
Is your patients have a urinary retention complaint or not? Or your patients had a catheter, urinary catheter in all your patients?
Yes, sir. Patients were all catheterized. Yes, sir. Bladder were catheterized, sir.
Okay. Okay.
Yes, sir.
Okay. So our next presenter is Dr. Monisha J.
Hello everyone, this is a paper presentation on short study and comparison of modified malapity classification with apparatus in predicting difficult laryngoscopic intubation. Introduction: the reported incidence of difficult laryngoscopic rectal intubation is between 1.3% to 13% patient undergoing surgery. Identifying a patient with difficult airway is important in planning anesthetic management so that endotracheal intubation can be achieved safely. So, aim and objective of the study was to compare modified malapity score and upper lip test predicted difficult intubation. The materials and methods. A prospective descriptive validation study was carried on 104 patients at Padamala Medical College Hospital. The inclusion criteria include patient scheduled for elective surgery requiring intubation under general anesthesia, age between 18 and 16 years of age, 5 6, ASA physical status class 1 and class 2. Exclusion criteria include patient refusal to take part in the study, patient with edentless neck contracture, cervical spine pathology, emergency cases, pregnant patient, malformed or deformed airways. Sample size was calculated with the following formula. For a allowable error of 2%, calculated sample size was 1.04. 104. Materials and methods. Day before the surgery, anesthesiologist visit the patient and thoroughly evaluate all the systems and particularly the airways. The demographic details and airway pathology are active. Infection, dentition status, as well as snoring was recorded. Patient airway was evaluated by modified malapity test upper lip test operatively. The modified malapity test classification was assistant patients in sitting position, head in neutral position, mouth fully open, and tongue maximally protruded without phonation, while observer looking into pharyngeal structures, hard palate, soft palate, uvula, and facial pillars, and graded according from grade 1 to grade 4. While upper lip test was graded from class 1 to class 3 based on ability of the patient to lower incisors that can bite upper lip. Upper lip bite test class 3 and class 3 and modified malapity test class 3 and class 4 considered to be a potentially difficult intubation. After pre-medication induction, laryngoscopy was performed in sitting position. Glottic was graded according to the Comac-Lee hand classification. Difficult intubation was assigned to a patient with Comac-Lee hand class 3 and class 4. In results, no relationship was found between the demographic details of the study population Comac-Lee hand. The largest age group population belonged to 40 years in the study. That was 30%, and 51% of the patient belonged to male category, and 67% of the patient had normal BMI. Distribution of study, a population according to modified malabody test, grade 1 and grade 2 considered difficult intubation. 79 patients belong to that category. Grade 3 and grade 4 considered difficult intubation. 25 patients belong to that category. The distribution of study population according to upper lip bite test, grade 1 and grade 2 considered easy intubation. 90 patients belong to that category, while the rest of the 14 patients belong to the grade 3 difficult intubation category. Comac-Lehan distribution, grade 1 and grade 2 considered easy intubation. 86 patients belong to the category. Grade 3 and grade 4 considered difficult intubation. 18 patients belong to the category. While comparing modified malabody test with Comac-Lehan, 21 patients belong to the grade 1 category of modified malabody test, always easy intubation. 58 patients of grade 2 category, 14 were difficult intubation. 25 patients of grade 3 category, 4 patients were difficult intubation. There were no patients in grade 4 category. While upper lip bite test was Comac-Lehan, 52 patients belong to the grade 1 upper lip bite test grade 1. 2 patients were difficult intubation, while 13 patients in upper lip bite test 2, grade 4 were difficult intubation, while 14 patients in grade 3 category, 12 were difficult intubation. An incidence of difficult intubation in the study was found to be 17.3%, that is 18 patients or 104 patients with difficult intubation. On comparison of test group modified malabody test with the Comac-Lehan, the test group had a sensitivity of 22.2%, specificity of 75.6%, and the diagnostic accuracy of 66.35%, p value of 1. On comparison of our test group upper lip bite test with Comac-Lehan, the test group has a sensitivity of 66.7% and specificity of 97.7%, negative predictive value of 93.3%, and a good agreement of p value of less than 0.001. This shows these tests can be good predictors for easy intubation. An ideal test should be highly sensitive and then specific with high positive predictive value to predict difficult intubation correctly and avoid false positives. Moderate sensitivity value for upper lip bite test in study may be attributed to the smaller sample size and low incidence of upper lip bite test in class 3 and class 4. In conclusion, upper lip bite test is better test at predicting difficult intubation, and both tests are good predictors of easy intubation. Predictors of easy intubation. Limitations of the study. The emergency patients and were not included study, so this the study cannot be generalized, and the sample size is small and has an allowable error of 2%. These are my references. Thank you.
Madam, sir, the candidate is not available online. So we will go to the next presenter directly because question answers will not be possible.
Okay, okay.
So next presenter is Monisha J.
Good evening, faculties. My study is about the comparison of ketoprofen patch with intramuscular diclofenac injection for postoperative pain relief in patients undergoing below-knee surgeries. The aim is to compare the effectiveness of ketoprofen transdermal patch with intramuscular diclofenac sodium for postoperative pain relief in patients undergoing below-knee orthopedic surgeries. It is a postoperative pain management. It has an important role for anesthesiologists. Transdermal, it is a non-invasive route of drug administration, alternative to oral route and parenteral injection. It has the better bioavailability, bypassing first-pass hepatic metabolism. The topical NSAIDs, it has the advantage of reduced risk of gastric and peptic ulcers and dyspepsia. There is a prospective randomized single-blinded study. Inclusion criteria: age group between 18 to 60 years, both sexes, ASA 1 and 2, below-knee orthopedic surgeries, weight more than 45 kgs. Exclusion criteria: pregnant woman, history of drug allergy to NSAIDs, acute and chronic kidney disease, acid peptic disease, peripheral neuropathy, history of pain due to other cause. There's a study population. It's randomly divided into 2 groups, a computer program and sealed envelope. Group K, it is a ketoprofen 20 mg transdermal patch, and group D, it is a diclofenac 75 mg intramuscular sodium injection. Patients were fasted overnight, 18 gauge IV line secured, baseline vitals recorded, monitored with non-invasive blood pressure, pulse oximetry, and electrocardiogram. Technique of subarachnoid block was standardized. After 1 hour of subarachnoid block, all patients received either ketoprofen patch or intramuscular injection. Group D received a dummy plaster after 1 hour for the purpose of blinding. Time of administration of patch or IM injection was noted. Patient was followed up in postoperative recovery room and in postoperative ward for 24 hours. Visual analog scale score is recorded every 2 hours, and if the score is more than 3, injection tramadol 100 mg IV is administered as rescue analgesic. The primary outcome is a postoperative visual analog scale pain score and rescue analgesic requirement and initiation time. Secondary patient characteristics: age, weight, height, BMI, ASA status, hemodynamic parameters, patient satisfaction score, and complication profile. That is a statistical analysis. We are using the comparison was studied using chi-square test or Fisher's exact test. It is a demographic variables. There is a mean visual analog scale score comparisons between group K and group D. Mean duration of pain relief between group K and group D. Results, both groups are comparable in terms of age, weight, height, and duration of surgery. 17 patients of group K needed a single dose of rescue analgesic, whereas all 30 patients of group D needed rescue analgesic, with 2 patients among them needed 2 injections of rescue analgesic. Initiation of rescue analgesic was earlier in group D than group K, which was statistically significant, P less than 0.05. Mean patient satisfaction score is better than group K. Conclusion. We conclude that the ketoprofen patch is found to be superior in duration and quality of anesthesia than IM diclofenac injection in elective below-knee orthopedic surgeries. So, NSAIDs patches can be used as an effective replacement to injectable NSAIDs for post-operative pain management. These are the references. Thank you.
Yeah, Monisha. Good morning, Monisha.
I think Madam Monisha is not online. So we will proceed to the last presenter, Dr. Monashri.
Good evening, everyone. I'm Dr. Monashri from Sapagidi College, Bangalore, Karnataka. I've done the study under the guidance of Dr. Shayavati. Today, I'm going to present a comparative study using fentanyl and magnesium sulfate as adjuvant with hyperbaric bupivacaine in spinal anesthesia for lower limb surgery. The randomized double-blind study at Tertiary Care Center. Aims and objectives of the study is to assess the efficacy of intrathecal fentanyl and magnesium sulfate as adjuvant with hyperbaric bupivacaine in spinal anesthesia for lower limb surgery, to note the time of onset and duration of the sensory blockade, and to evaluate the duration of post-operative pain relief. Methodology. It contains 40 patients, 20 in each group. The study has 2 groups. The group 1 has the group 1 patients will receive the adjuvant 0.1 ml of magnesium sulfate with 2.5 ml of bupivacaine. Group 2 patients receives fentanyl 25 mics with 2.5 ml of hyperbaric bupivacaine. Each patient will be reassured and explained in detail about the procedure in the pre-anesthetic checkup. All patients will be confirmed physically fit and advised overnight fasting, and they will be given tablet alprazolam 0.5 mg and tablet pantoprazole 40 mg. Patients will be monitored with non-invasive blood pressure, pulse oximeter, and ECG. They'll be given crystalloids of 10 ml per kg body weight. This is to preload them. In sitting position under aseptic precaution, so spinal anesthesia will be given using 25 gauge queen case needle at the level of L3-4 or L4-L5 intervertebral space with 2.5 ml of 0.5% hyperbaric bupivacaine with 0.1 ml of 50% magnesium sulfate to group 1. And 0.5% hyperbaric bupivacaine with 2.5 ml with 25 mics of fentanyl to the group 2 patients. Total will be made to 3 ml, and the onset of sensory block will be assessed, and the maximum height of sensory block will be assessed, and duration of sensory block will be assessed, and duration of analgesia will be assessed. the intraoperatively they'll be also monitored with for systolic blood pressure, heart rate, and pulse oximetry, and it will be recorded every 2 minutes, 4 minutes, 6 minutes, 8 minutes, 10th minute, 30th minute, and 150th minute. We also observe for the various side effects like nausea, vomiting, pruritus, shivering, and vomiting. Coming to the results, table 1 shows age and sex distribution among the two groups, but it concludes that there is no significant difference between the demographic parameters of age and sex between two groups. Table 2 depicts the maximum level of sensory block achieved among the two groups. The maximum patient of group 2, that is who have received hyperbaric bupivacaine 2.5 ml with 25 mics of fentanyl, had a maximum sensory block until T4 dermatome. Table 3 demonstrates the onset of sensory block in the study population. The mean onset of time of sensory block was observed to be 4 minutes 45 seconds in group 1 patients, 1 minute 62 seconds in group 2 patients. The mean time to reach the maximum sensory block level, that is T4, is 10 minutes 40 seconds in group 1, 5 minutes 65 seconds in group 2. It is found that the difference between the group 1 and 2 was statistically highly significant. The duration of sensory block was 136 minutes in group 1 and 180 minutes in group 2, which was statistically significant. The duration of analgesia was significantly higher in group 2, that is 238 minutes and 164 minutes in group 1. So I'd like to conclude the study with that addition of fentanyl as adjuvant to hyperbaric bupivacaine significantly fast the onset of sensory block, prolongs the duration of sensory block, and it's a better post-op analgesia compared to magnesium sulfate as an adjuvant to hyperbaric bupivacaine in spinal anesthesia. Hence, it is suggested that fentanyl is a good and useful adjuvant for spinal anesthesia. These are the references. Thank you.
Good morning, Monashi.
Good morning.
Good morning.
Good morning, ma'am. Good morning, sir.
She's there. She's there. She can.
Yes, madam. Yeah.
Yeah. See whether whether these two doses are equivalent, therapeutically equivalent, magnesium sulfate, whatever you have taken, and fentanyl. That you have to see before starting. You cannot just take to whether in the references what you have taken also the same dose is compared.
Oh, yes, ma'am.
Whether it is compared, and another thing is whether it is used means it is safe to give this magnesium. So fentanyl we are using preservative free, but morphine and fentanyl opiates, but magnesium sulfate intrathecally. Whether before giving you should whether
that's what ma'am
license is there to give whether it can be used intrathecally, not
yes,
just whether it tell me.
There are some studies which they have taken magnesium as intrathecal adjuvant. But as a sole agent, it is not equivalent to fentanyl, ma'am. Like it won't prolong the duration of sensory block and analgesia also. So fentanyl is a very good adjuvant comparing to magnesium sulfate in spinal anesthesia, ma'am.
Okay, what is the additional advantage of giving? And this was for which group of patients? Orthopedic patients.
Low limb surgeries, ma'am. Both orthopedic and surgery patients. That is for fasciotomist debridement patients.
Other than this long duration fentanyl, whether it has any advantage when you use fentanyl, especially abdominal procedures, lower abdominal procedures, what they say is long, other than long duration fentanyl, visceral pain, it will reduce the visceral pain.
Yes, ma'am. It is a
more control over visceral pain.
Yes, ma'am.
Than the duration of analgesia. Okay.
Okay, ma'am.
Okay, sir.
Good morning, sir.
Average duration of post-op analgesia in Maxwell.
Post-op analgesia duration in Maxwell is around 160 minutes, sir. With the fentanyl group, it is 230 minutes. So it is almost 1 hour less comparing to the fentanyl group.
Okay. So all our presentations are finished. Now Dr. Monish is online. So madam, would you like to question him?
Okay. He did that keto profen and diclofenac, no, Monish?
Monish,
Monish, he did that difficult airway.
Yes, ma'am.
Upper
Yes,
lip
ma'am.
bite test and the other test. Upper
Yes,
lip bite test and Mallampati you compared.
Yes, ma'am. Yes, ma'am. Yeah.
Okay. What was your result? It was whether it was correlating with your Cormac-Lehane? Which one was correlating?
Upper lip bite test was a better in predicting difficult intimation when compared to modified Mallampati test, ma'am.
Okay, upper lip bite test is whether we can do that in our practice, whether we can practice the same now, because we are following Mallampati now. Frequently we are doing Mallampati alone.
Yes, ma'am. Yeah.
Whether we can
Upper lip-
practice that now. What do you say?
Modified Mallampati test is usually used, ma'am. Upper lip bite test is a relatively new test which can be used. From my study, I found that upper lip bite test is better in predicting difficult intubation. But there are certain instances where the patient may not understand what exactly we want. So the upper lip bite test, they may not do it properly, even though they can do it well.
Not reproducible. Some patients may not follow. Okay.
Yes, ma'am.
Okay.
Yes,
That
ma'am.
I have also seen.
Yes, ma'am.
Okay. But the prediction wise, your study wise, this is more correlating.
Yes, ma'am. Yes, ma'am. Yeah.
Okay. Sir, any questions for him? How did you blinding of the study and all? It was who was assessing this? Cormac-Lehane, somebody else was assessing the Cormac-Lehane. Not the person who did the, how did you blind this? Blinding, how did you do?
Ma'am, I pre-assessed the patient myself and also did the intubation myself. So I did,
Whether some bias can happen like that, no? So you are thinking that this is better and like that you can, if somebody else did scopy means it would have been better.
Yes.
Okay. Sir?
hello, ma'am.
Yes, sir is not there.
Yes, sir is not there. So now Monisha is available online. So Monisha can tell what was her topic, and then
Monisha,
yes.
you compared, Monisha, good morning. You compared ketoprofen and diclofenac, no? Same study. Moni.
Unmute yourself, Moni.
Unmute, ma'am.
I am unmuted.
Morning, ma'am.
Good morning. You studied that ketoprofen and diclofenac.
Yes, ma'am.
Diclofenac was given IV and ketoprofen IM. Diclofenac IM and ketoprofen IV.
As patch, ma'am.
Patch you have given. So whether it is dependable, one drug in some other route and the other drug in like that. And whether the equivalent doses, whether you have given, whether you have proper, what is that, studies like this, previous studies to compare. Yeah.
For that only, I have used a dummy plaster for diclofenac IM injections, ma'am.
Okay, because IM injections are usually painful and it causes discomfort to the patient. Very less we are giving IM injections nowadays. Okay. The duration of action, any difference was there? Ketoprofen? Duration of action. Duration of action.
Yes, ma'am. Actually, tramadol we used as a rescue analgesics, ma'am. In ketoprofen patch and diclofenac injection, the comparatively tramadol usage is more in diclofenac sodium injection patients, ma'am.
Okay. Yes, sir. Any questions for her?
Okay. Hello. Monashri has to unmute herself.
Ma'am, I have finished the discussion, ma'am.
Okay. So thank you all.
Thank you, ma'am.
Thank you. We have finished the session of the 22 presentations. Madam, I am available on other laptop, so I am not visible. Thank you, Bindu Madam and Dr. Ashutosh for spending your time and guiding the participants.
Thank you, IASCON, for giving this great opportunity. Thank you.
Thank you, madam.
Thank you, Dr. Ashutosh also. Yeah, thank you, madam.
Thank you, participants. And I'll thank Dr. Anjani also for helping me coordinating the session. Thank you all. થઈ જતા હોય તો સેશન બંધ કર હા મેં ચેતના ગોહિલ @yahoo.com. Thank you, Dr. Ashutosh. And we are concluding the session. Leave.
Off the music, please. Please off the music. Aftab, please off the music.
Sister, nitrous suppression రోజు తెగిస్తాను సెంట్రల్ ప్రెషర్
Hello. Hello.
Good morning, ma'am.
Good morning.
Welcome to IASCON paper presentation, Dr. Saraswati ma'am and Dr. Prithvi ma'am. Good morning.
Morning.
Yeah, good morning. I'm Dr. Saraswati here from Bangalore.
Yeah, good morning, ma'am. I'm Dr. Preeti from Mangalore.
Yes. Shall we start the session by 11?
Yes, ma'am. I'm done.
Yeah.
Dr. Preeti, there are around 15 papers.
Yes.
In 2 hours.
Yes, ma'am.
That means each paper.
5 minutes for the presentation and 5 minutes for questions is what sir told me.
Then no, that cannot be. No, 8 plus 2 they said. But even then 15 means 150 minutes.
Yeah.
150 minutes, 2 hours. 6
Yeah.
more.
Yeah.
Yeah. Altogether, I for each. paper.
Yes, ma'am.
5 minutes and 6 minutes and 2 minutes for discussion.
Okay.
Because it's 2 hours, no?
Yeah, see, I think Dr. Alok has said question answer is only for 2 minutes. All right.
Yeah, for 2
Yes.
minutes for presentation.
Yes.
Because it's only 2 hours allotted time, 11 a.m. to 2 p.m. Yes, no?
Yes, ma'am.
Yeah, there are. We'll take it up 6 plus 2. Okay.
Oh, yeah.
Okay, I'm here. Okay. What is it? We were talking. Monica. Yeah, Monica, have you joined? And Bindu Gupta. Okay. On Zoom, I cannot find you. Okay, but I cannot see you online. So, what's your name online? Yeah. Can you see us? Can you see Dr. Saraswati Devi and Dr. Prithvi Jain?
Hello, everyone.
Hello, sir.
I am Dr. Rashesh Diwan, the organizing chairperson for IASCON 2021. I welcome you all on behalf of the Governing Council of Indian Society of Anesthesiologists and the organizing team of IASCON 2021. We all know we have passed through a very difficult phase in the life, and now gradually we are trying to overcome the situation. Many of us suffered the pandemic, and of course, many of us also worked for the pandemic, for the community, and we were praised all over the country and all over the world. It was a great learning time for all of us. However, we missed the last year completely for the academics. But now we are beginning, and we are beginning with a very mega academic fiesta under the banner of Indian Society of Anesthesiologists. This is the biggest ever hybrid conference and happening for the next 5 days. I am sure you will enjoy the most. We have made a humble attempt to accommodate as many presentations as possible. And in view of the overwhelming response for the presentations, we extended the conference on the pre-CME day. This is the today. We are starting today at 8 o'clock, and we have plenty of e-papers accommodated for 1 day. Once again, I thank you all for the participation in IASCON 2021 and wish you good luck. Stay safe. Long live ISA.
Good morning, ma'am. First presentation would be of Monica Ruttulaja. She's Mulani. She's second.
Dr. Monica.
Good morning, all. Myself, Bindu Monica from Ashram Medical College, Anesthesia Second Year PG. My topic is regarding induced hypertension for FES, a comparative study of dexmedetomidine versus esmolol. Functional endoscopic sinus surgery is becoming a widely performed operation. However, major complications have been reported for FES under general anesthesia resulting from impaired visibility due to excessive bleeding. Controlled hypertension is a technique used to limit intraoperative blood loss to provide best possible field for surgery. Esmolol is an ultra short acting adrenergic antagonist that reduces heart rate and blood pressure. It has rapid onset of action. Dexmedetomidine is a potent, highly selective alpha-adrenergic agonist. It has sedative, analgesic, and anesthetic-sparing effect and sympatholytic properties. My study was designed to compare efficacy and safety of dexmedetomidine or esmolol as hypotensive agent in FES with attention on amount of blood loss, quality of surgical field. This is a prospective randomized single-blinded study done in Ashram Medical College from December 2020 to September 2021. 40 ASA physical status 1 and 2 patients aging 20 to 50 years are scheduled for elective FES surgery. Patients included in this study were randomly assigned according to computer-generated randomization to receive either dexmedetomidine or esmolol.
मेरे में एक सरस्वती देवी
In
है
both
और एक
groups,
प्रीति
infusion
है,
rate was
दो
titrated to
chest,
maintain mean arterial
एक
pressure
बुद्धू
within
और एक
45
पटना.
to 65 mm Hg. Same surgeon performed all operations to ensure consistency in the estimation of surgical field. He was blinded to the hypotensive agent used. Average category scale for assessment of intraoperative surgical field. 0 indicates no bleeding, 1 indicates light bleeding, no suctioning of blood required. 2 indicates light bleeding, occasional suctioning required. 3 indicates light bleeding, frequent suctioning required. 4 indicates moderate bleeding, frequent suctioning required. 5 indicates severe bleeding, constant suctioning required. Bleeding appears faster than can be removed by suction. Surgical field severely threatened. The total blood loss was measured from the suction apparatus, monitored, including invasive blood pressure measurement, heart rate, ABG, plasma cortisol levels, and surgical field score. Hemodynamics and ABGs were recorded preoperatively, post-induction, intraoperatively, and after stoppage of hypotensive agents were recorded. Intraoperative fentanyl consumption and requirements for additional hypotensive agent were recorded. Patients of study groups are comparable with respect to demographic data and operative data. Induction propofol dose was significantly lower in dex group than esmolol group. Mean arterial pressure with no intergroup significant differences after induction or during hypotensive period. Heart rate decreased significantly relative to baseline after administration of loading dose in both groups. Mean intraoperative fentanyl consumption in dexmedetomidine group was significantly less than esmolol group. This indicates the demographic and operative data. Discussion. Induced hypotension has been widely advocated to control bleeding during FES to improve quality of surgical field. Both drugs were effective in achieving MAP of 55 to 65 mm Hg and lowering heart rate, ensuring good surgical field and providing dry surgical field during FES. In current study, the induction dose of propofol was significantly lower in dexmedetomidine group than esmolol group. Esmolol administration in the present study was associated with significant decrease in mean arterial pressure and heart rate compared to baseline values. Esmolol lowers arterial blood pressure through a decrease in cardiac output secondary to negative chronotropic and inotropic effects of beta-adrenergic antagonism. Optimal anesthetic techniques aims to be related to bradycardia with associated hypotension. Several studies have found that perioperative use of dexmedetomidine was associated with significant decrease in consumption of inhalational agent, fentanyl, and analgesic in dose-dependent manner. Dexmedetomidine has sedative and analgesic sparing effect via central actions in locus coeruleus and in dorsal horn of spinal cord. Conclusion. This study demonstrated that dexmedetomidine or esmolol with severe fluid are safe agents for controlled hypotension, and both are effective in providing ideal surgical field during FES. Compared with esmolol, dexmedetomidine offers advantage of inherent analgesic, sedative, and anesthetic sparing effect. These are my references, and thank you.
Okay, Dr. Monica. This is hello. Hello.
Good
Dr.
morning.
Monica. Dr. Monica.
Good morning, ma'am.
Good morning. Can you hear me? Hello.
Yes, ma'am.
Can you hear me?
Yes, ma'am. I'm able to hear, ma'am.
Yeah. Monica, you are very fast in your presentation, one. And second,
ma'am.
what is that you are trying to say that Fessler dexmedetomidine, it has been used since a long time. Is there anything extra point would you like to add, or you just want to say that FES, how much blood loss you expect?
Mainly, it is my major surgery, and dexmedetomidine provides best surgical field for the surgeon, ma'am. By giving dexmedetomidine, we can provide the best surgical field.
But FESLA, how much do you expect blood loss?
It may be around 300 to 500 ml, ma'am.
Oh, 500 ml, up to 500, you expect a blood loss in FES? One. Second one is, ABG, do you do for FES surgeries?
In some patients we do, ma'am. Not in every patient.
Patients, ma, which patients you do ABG for FES? How
certain
many
patients in any respiratory conditions
have done ABG in FES? Then what? How many milligrams you have
conducted study on 40.
How many people you have done ABG? For what you have done ABG?
What was the advantage of doing the ABG? What was the indication?
In certain COPD patients, respiratory complicated patients, or any suspected respiratory failure patients.
But did you not exclude them from your study?
In some patients, they may be chronic smoker. No, ma'am. In that patients, I took.
What were you trying to? What was your aim in doing the ABG? What were you trying to learn?
Dr. Monica, when you are presenting, you have the inclusion criteria and exclusion criteria? And
yes, ma'am.
And ABG patients means, are you taking even COPD patients? We take. But do we do ABG regularly? And FES is not a big surgery to lose so much of blood. No? Okay, anyway.
Yes, ma'am.
But how many milligrams of, how many micrograms of dexmedetomidine you use?
1 microgram I have given, ma'am. Loading dose. 1
microgram per
kg, ma'am.
That you have to tell them everything. 1 microgram per kilogram.
Yes, ma'am. Maintenance 0.2 to 0.4 microgram per kg.
And you also use esmolol.
Yes, ma'am.
You compared it with esmolol.
Yes, ma'am. No major differences between esmolol and dexmedetomidine, but only minimal changes. That analgesic effect is more with dexmedetomidine compared to esmolol. And post-operative analgesia is more with the dexmedetomidine.
And you also used fentanyl. No?
No, ma'am.
You have also used fentanyl.
Fentanyl during induction analgesic effect.
Even for dexmedetomidine group, you have used fentanyl?
Yes, ma'am.
Then how do you say that you give credit to dexmedetomidine? Tell me. When you are using one, using fentanyl also along with it.
In both the groups,
both the groups you had fentanyl. Anyway, you are very fast in presenting, and there are 2 crowded slides for a limited time. To go through along with you also, it becomes little difficult. I think Dr. Preeti will give her remarks.
Yeah. Okay. This was a good study, but some things we found unnecessary, like the ABG and all, which I do not see any indication. We have done similar studies. What was the disadvantage with esmolol that you decided that something better is required?
no disadvantage, ma'am, major, but only analgesic effect, and this effect is some advantages with dexmedetomidine, ma'am. That's it.
Okay. All right. All right. Okay. Yeah, I think we'll wind up now. Otherwise, we're going to run short of time. Ma'am, is that okay?
Yes, ma'am. Yes.
Okay. Yes. Dr. Alok, shall we move on to the next candidate?
Thank you, ma'am.
Thank you. Thank you.
Yes. Yes, ma'am. Aftab?
Yes, proceed with the next candidate.
Good morning, respected panelists. Myself, Dr. Mrinalini Kulkarni, second year resident, BJMC Ahmedabad, presenting a paper on the topic comparison of induction time and characteristics between sevoflurane with or without nitrous oxide in pediatric patients under the guidance of Dr. Smita, our engineer ma'am, professor, and Dr. Labdi Lakani, senior resident, BJMC College, Ahmedabad. Inhalation induction is often preferred in young infants and older children. Of all the volatile anesthetic agents available, advantages of sevoflurane include it causes no upper airway irritation, it has low blood solubility, rapid induction and recovery, high concentrations are well tolerated in children, and low incidence of PONV. Disadvantages include it causes occasional transient agitation during extubation. Nitrous oxide is a weak anesthetic and excellent analgesic agent. It decreases the MAC of sevoflurane in a linear additive manner. It contributes to a smoother and marginally quicker induction. Considering the advantages of addition of nitrous oxide to sevoflurane, this study has been planned to evaluate the concentrating and second class effects of nitrous oxide, which is useful in anesthetizing children. This is a prospective randomized interventional single-blind comparative study designed to evaluate induction time and characteristics between sevoflurane with or without nitrous oxide in pediatric patients. Primary outcome is IGEL insertion condition. Secondary outcome is induction time, hemodynamic parameters, any complications. After obtaining approval from Institutional Ethics Committee and CTRI registration, this prospective randomized interventional comparative study was conducted. Inclusion criteria being age 1 to 12 years of either gender weighing 7 to 25 kg. Exclusion criteria being anticipated difficult airway, restricted mouth opening, history of regurgitation, any pathology of oropharynx, neuromuscular disorder and neurological symptoms. As per induction agent used, patients were randomly divided into two groups, with group 1 having oxygen 6 liters plus sevoflurane 6%, group 2 being O2 3 liters plus N2O 3 liters plus sevoflurane 6%. At every 5 seconds, patients were observed for loss of consciousness in position of eyeball. Once central eyeball position was achieved, airway was secured using IGEL. The parameters observed were induction time, insertion condition, hemodynamic parameters, and complications. Sample size was calculated using ClinCalc software, which turned out to be 74 patients. The condition insertion was graded on a 3-point scale as per the mouth opening, jaw relaxation, ease of insertion, gagging, swallowing, head rolling, movement. In our study, we found out that there was statistically significant difference with respect to induction time and time to conjugate gaze, both of them being low in group 2 as compared to group 1. Whereas manipulation for insertion and excitatory movements were greater in group 1 as compared to group 2. No statistically significant difference was found in both the groups with respect to condition of insertion, perioperative changes in heart rate, systolic and diastolic blood pressure, and complications. Esmaili et al. Found out that time to loss of eyelash reflex and excitatory movements were significantly lesser for the nitrous group as compared to the sevoflurane alone group. Yehuda F. Khan et al. Found that movement during LMA insertion were greater in sevoflurane alone group as compared to the sevoflurane and nitrous oxide group. Louis J. Goldman et al. Found that there were no complications in both the groups of children. Aithwaite et al. Found out that induction of anesthesia with sevoflurane was significantly slower compared with propofol. J. E. Hall et al. However, found that similar excitatory movements were seen in sevoflurane and sevoflurane plus nitrous oxide group. Hence, we can say that sevoflurane alone or in combination with nitrous oxide can be used for inhalational induction for SLD insertion in pediatric patients. Advantages of nitrous oxide include faster induction, lesser manipulation for proper SLD placement, and lesser excitatory movements. So, in the end, we can conclude that combination of nitrous oxide and sevoflurane is better than sevoflurane alone for anesthetizing pediatric patients. Thank you.
Good presentation.
Thank you, ma'am.
Yes, ma'am.
Yeah, carry on.
Okay, so what is second gas effect? Could you tell me about that?
Yes, ma'am. During induction of general anesthesia, when a large volume of nitrous oxide is inhaled by the patient, then the gaseous uptake occurs from the pulmonary capillaries into the alveoli, resulting in increased concentration of nitrous oxide in the alveoli. That is known as second gas effect.
Is that it? Okay. How does nitrous decrease the MAC of sevoflurane?
Ma'am, nitrous decreases the MAC of sevoflurane because its concentration increases in the pulmonary alveoli and it has its own anesthetic and analgesic
You
properties.
mentioned linear and additive manner. So I wanted to know about that. Yes. What did you mean by linear and additive manner? You specified that.
Yes, ma'am. That means that in a proportionate manner, like if we increase the concentration of N2O from 2 to 3 liters, so like in the same way, the MAC of sevoflurane will also be reduced in proportion to that.
Okay, all right. Ma'am, anything else you have to ask?
No. Ultimately, she said this with nitrous oxide. You could have done with air also. No,
Yes.
oxygen and air. No?
Yes.
Anyway, it's done. Okay.
Thank you, ma'am.
Okay.
Good presentation. Thank you. Could we have the next speaker?
Good morning, everyone. This is my paper presentation titled "The Use of Nasal Cannula as a Pre-Oxygenation Adjunct, a Randomized Crossover Study." The study hypothesis was that the use of oxygen via nasal cannula as an adjunct to pre-oxygenation improves the efficacy of pre-oxygenation. The aim of the study was to measure the changes in end-tidal oxygen when nasal cannula was used as an adjunct to pre-oxygenation. The primary objective was to assess the end-tidal oxygen after pre-oxygenation while using nasal cannula as an adjunct for 3 minutes, tight volume breaths, and 8 vital capacity breaths over 1 minute. The secondary objective was to compare the end-tidal oxygen between 3 minutes tidal volume pre-oxygenation and 8 vital capacity breaths over 1 minute, and also to assess the comfort of the subject using nasal cannula. The inclusion criteria was healthy volunteers and people in the age group between 20 to 50 years. Exclusion criteria was people with known respiratory cardiac diseases, pregnant women, and people with facial trauma or facial deformities. We used a randomized crossover study comparing the effects of the 6 methods of pre-oxygenation efficacy while used a Latin spiral method as a sampling technique, and consent was taken from the participants of the study. Two methods of pre-oxygenation were 3-minute high volume breaths and 8 vital capacity breaths over 1 minute, while oxygen was being supplied by a nasal cannula at 0 liters per minute, 5 liters per minute, and 10 liters per minute. The 6 methods of pre-oxygenation on study are as follows: 3-minute high volume breaths with 0, 5, and 10 liters per minute of nasal cannula oxygen, and 8 vital capacity breaths over 1 minute with 0, 5, and 10 liters of oxygen flow through the nasal cannula. The comfort of the participants was assessed using the Likert scale. The sample size was calculated using the equation for repeated measures ANOVA. It came up to 27. The end-tidal oxygen after 3-minute tidal volume breaths while using 0, 5, and 10 liter minute nasal cannula is shown in this table, and you can see that the mean end-tidal oxygen with 10 liters of nasal cannula oxygen is higher compared to the other two. The end-tidal oxygen after 8 vital capacity breaths using 0, 5, and 10 liters per minute of nasal cannula oxygen is shown in this picture. And you can see that 10 liters of flow gives a higher end-tidal oxygen compared to 0 and 5. And comparing 3-minute tidal volume breaths and 8 vital capacity breaths, it was shown that in all three groups, the mean end-tidal oxygen was higher in the 3-minute tidal volume breaths group. And it was shown to be statistically significant. Patient's comfort was shown to be lesser with 10 liters per minute flow and 5 liters per minute flow compared with 0 liters per minute flow. The limitations of the study was that it was done on healthy volunteers, and only the effectiveness was determined, and end-tidal oxygen compared to partial pressure of arterial oxygen as an indicator of the efficacy of pre-oxygenation is inferior. Conclusion was that the administration of oxygen by nasal cannula during pre-oxygenation improves the efficacy of pre-oxygenation in healthy volunteers, and tidal volume breathing over 3 minutes results in higher end-tidal oxygen concentration compared to 8 vital capacity breaths over 1 minute. These are my references.
Okay, Dr. Joel, how many minutes you give nasal cannula oxygenation?
Ma'am, during the entire duration of the pre-oxygenation.
During entire means how many minutes you give pre-oxygenation?
For the 3-minute tidal volume breaths, 3 minutes, ma'am, and for the 8 vital capacity breaths for 1 minute.
Continuously 10 liters you give, and the patient is comfortable with the 10 liters oxygen? No.
They are uncomfortable. In that Likert scale, that patients who are undergone that procedure had a higher discomfort.
Yeah, how many liters they are comfortable with?
5 liters they tolerated.
5 liters. 5 liters of nasal oxygen, and the cannula is kept where?
Nostrils.
Nostrils only, not beyond
yes.
that.
No.
Do you check anything nasal passages or URI?
Patency. Patency is checked.
Patency.
Yes.
And with 5 liters of oxygen, and the patient is comfortable, is able to maintain pre-oxygenation.
Yes.
Yes, no, that means you are not using extra oxygen through the face mask.
No, ma'am. Face mask for all three procedures we had 10 liters, ma'am. So a nasal cannula over that 0, 5, and 10 liters.
So you have used both, huh?
Yeah, ma'am.
Then then why do you choose this technique?
Our concept is we want to show if we are going to change over to apneic oxygenation while intubation, we won't have to need extra time while putting the nasal cannula on. We can pre-oxygenate directly and go ahead with intubation.
No, I think it is in difficult airway. Are you speaking about? Not
Yes,
able
yes.
to understand what type of cases? See, you use
Sorry, ma'am.
pre-oxygenation with mask.
Yes, ma'am.
That is suffice for apneic endoscopic laryngoscopy and then put in a tube. That is the regular conventional technique.
Yes, ma'am.
On top of it, you are giving 5 liters, 10 liters of oxygen. For what you are doing, that 5 liters or 10 liters of extra oxygenation for the patient.
Okay. When we use the nasal cannula without any flows, there was a leak, and so the end-tidal oxygen was decreased. So to counteract that, we thought we'll pre-oxygenate with nasal oxygen flows also.
Leaking where? It's leaking into the patient only, no?
No, ma'am. There's one study with 0 liters flow through nasal cannula also,
Okay.
which showed lesser end-tidal oxygen. So if you pre-oxygenate with the nasal cannula in situ, the efficiency of pre-oxygenation is decreased.
Okay.
And by the time we transfer to apneic oxygenation after induction, the pre-oxygenation goals might not be attained. So we thought we'll start the flow during the pre-oxygenation period only to reduce the leak.
You have done. Tell me, what type of cases you had done?
Only healthy volunteers only, ma'am. Actually, that's one limitation.
Volunteers and ASA, one sort of like that.
Yes,
In that,
ma'am.
what is that pre-oxygenation? Definitely, see, according to the difficult airway guidelines, the nasal cannula is sufficient to give good oxygenation. So you are adding on to it conventional techniques of again pre-oxygenation. Oxygen is a supporter of combustion. Why do you want to give so much of oxygen to a patient? That is the question. So either one of these techniques you should follow, okay. But both the techniques you follow, and you say that end-tidal is increased by oxygen through nasal cannula and in a healthy volunteer, and you have not told about the Malambati classification also here. No?
We only pre-oxygenate. We didn't induce. It's only healthy.
Induce at all. But then
No.
apneic techniques you are talking about when you are talking.
Like, yeah. No, we didn't do the apneic oxygenation part. We just later on, if required.
What later on? I think you need to be little more. This requires little more clarification. Okay. Okay, it's a good technique. Either you follow pre-oxygenation, that is a good. Now, according to the difficult airway guidelines, you can give pre-oxygenation through the nasal cannula continuously, and then take up for apneic also. See, for lasers and all, we do like that only. But you don't add both pre-oxygenation, regular conventional, and this.
Okay.
Your cost effectiveness is not there, and plus this theater pollution also will be more with more amount of oxygen, which we don't allow when cauteries and other things are used.
Ma'am.
Okay, ma, Dr. Preeti.
Yes, ma'am. Yeah, I think that's okay. Yeah.
Okay.
Okay. Yes.
Ma'am, the speaker.
Okay. Ma'am, the next presentation will be Dr. Nalini Sojita.
Effect of pretreatment on induction of anesthesia with etomidate, a comparison between dexmedetomidine and midazolam fentanyl combination. Etomidate is a imidazole derivative widely used as an intravenous anesthetic agent. Due to its rapid onset of action and stable cardiovascular profile, it is widely used in hemodynamically unstable patients. Pain on injection and myoclonus are two well-known side effects of etomidate. Myoclonus can lead to regurgitation and aspiration in non-fasting patients and can raise intraocular pressure in open globe injury patients. Aim of our study was to compare the incidence and severity of etomidate-induced myoclonus after pretreatment in form of dexmedetomidine and midazolam fentanyl combination, and their role in attenuating the hemodynamic stress response to laryngoscopy and intubation. A prospective comparative observational study was conducted on 100 ASA class 1 and 2 adult patients aged 18 to 60 years of either sex undergoing elective surgical procedures under general anesthesia. Group D received injection dexmedetomidine 1 microgram per kg over 10 minutes, and Group FM received midazolam 0.02 milligram per kg plus fentanyl 2 microgram per kg. After 5 minutes, patients were induced with injection etomidate 0.3 milligram per kg. Patients were observed for 2 minutes for myoclonus, which was graded as grade 0, 1, 2, and 3. Hemodynamic parameters were observed at various time intervals like before pretreatment, after induction, during intubation, and at 3, 5, and 10 minutes after intubation. Anesthesia was then maintained with conventional methods. Statistical analysis were done using SPSS version 16. In FM group, 13 patients developed myoclonus, out of which 9 patients had grade 1 and 4 patients had grade 2 myoclonus. In D group, 20 patients developed myoclonus, out of which 16 patients had grade 1, 3 patients had grade 2, and 1 patient had grade 3 myoclonus. The incidence and severity of myoclonus was less in FM group, though not statistically significant. Attenuation of heart rate was better in D group, and attenuation of blood pressure was better in and statistically significant in FM group after induction. This is a graph showing intensity and severity of myoclonus, and these are the graphs showing pulse rate and mean arterial pressure at various time intervals. We observed that the attenuation of myoclonus was comparable in both the groups. In our study, immediately after pre-treatment, mean pulse rate decreased in both the groups, and the difference between them was highly significant. Pulse rate decreased more in dexmedetomidine group, but the difference was not statistically significant at other time intervals. The fall in mean systolic blood pressure after induction of anesthesia was more in FM group and was statistically significant. The fall in mean diastolic blood pressure at induction and during intubation was more in FM group and was statistically significant. The fall in mean arterial blood pressure after induction was more in FM group and was statistically significant. As Day in 2014 observed that etomidate-induced myoclonus was significantly decreased in patients pre-treated with dexmedetomidine compared to midazolam, and the fall in blood pressure and heart rate from the baseline was more in dexmedetomidine group. Ilke Isitimase observed that myoclonus incidence was 85% in no pre-treatment group, 40% in fentanyl, 70% in midazolam, and 30% in fentanyl midazolam group. And the fall in mean arterial and mean heart rate after induction was significantly lower in FM group compared to no pre-treatment group. Thus, it was concluded that both dexmedetomidine and midazolam fentanyl combination was effective in attenuating the etomidate-induced myoclonus, and the difference between them was not statistically significant. Both the groups led to fall attenuation of various hemodynamic parameters, but except a significant decrease in mean pulse rate immediately after pre-treatment in D group and significant decrease in mean blood pressure in FM group after induction. These are my references. Thank you.
Good. Anything, Dr. Preeti?
This looks like a good study of yours. What is the cause of myoclonus after etomidate? Your
unmute people, please.
Please unmute yourself. Hello.
Dr. Naveen.
Dr. Naveen. Please unmute yourself.
Hello.
Yes.
Ma'am, cortical disinhibition and earlier depression of inhibitory circuits due to etomidate in neuronal.
Okay. Yeah. So, but your study was not totally conclusive, though you said.
Ma'am, earlier studies was done on different doses of dexmedetomidine and either with midazolam or fentanyl, but there was no study comparing the fentanyl and midazolam combination.
How did you arrive at the comparative dose for these two?
Ma'am, we searched the previous studies, and in that dexmedetomidine 1 microgram per kg was effective. So we took that dose in dexmedetomidine group, and fentanyl group 2 microgram was effective. So we compared fentanyl midazolam combination and dexmedetomidine group.
Okay, right, all right, good study.
Good study, Nalin. Dexmedetomidine, of course, is 1 microgram, and fentanyl you had given 2 microgram. 2 kilogram body weight. That is ideal. Okay, but you said there is a little hypotension in that group.
Ma'am, we also studied attenuation of hemodynamic parameters through laryngoscopy. So there were some varied results in both the groups. Heart rate was more decreased in dexmedetomidine group, whereas the blood pressure and all that was decreased in fentanyl and midazolam group.
Yes, I think how fast, how quickly you have given also is a question that I just wanted to add.
Ma'am, dexmedetomidine we infused over 10 minutes. And fentanyl and midazolam, we give it IV state slowly, means over 2 minutes.
Over 2 minutes.
Yes, ma'am.
So that I think probably that is also one thing I think you can slowly, if you give fentanyl, I think blood pressure dropping also I think you can avoid.
Yes, ma'am.
Because that also counts, but all are healthy volunteers, healthy people only.
Yes, ma'am. We
fentanyl
studied on class 1 and 2.
in a short period of time may produce. Otherwise, it is not a big thing. It's a good study. And you have presented well also. I think we are able to follow it.
Yes.
Thank you, ma'am. The next presentation will be by Dr.
The topic for presentation is comparative study of the effectiveness of single dose of dexmedetomidine versus fentanyl in interrupting hemodynamic stress response to laryngoscopic intubation. And my guide, Dr. Sarah Abraham, Dr. Miriam Maman. Introduction: the main responsibility of anesthesiologist is provision of patent airway, which is important for providing intact functional respiration. Laryngoscopy intubation associated with sympathetically made circle response, associated with increase in pulse rate and blood pressure. Dexmedetomidine, a drug which is used in a study in alpha-2 agonist for attenuating stress response to various noxious stimuli. Fentanyl is a short-acting synthetic opioid attenuating the hemodynamic stress response by acting on opioid receptor, medium mu receptor. Aim is to compare and evaluate the effectiveness of single dose of dexmedetomidine versus fentanyl in attenuating stress response to laryngoscopy and endotracheal intubation. Objective to study the effective single dose of dexmedetomidine versus fentanyl attenuating the hemodynamic stress response to laryngoscopy and intubation in patients undergoing surgery under general anesthesia. In spite of the numerous drugs to blunt the hemodynamic stress response, the search for a better drug minimal adverse effects still continues. The study was an observational study with two groups of patients under elective surgery under general anesthesia. Study conducted at the Department of Anesthesia, Pushpuri Institute of Medical Science, Tiruvalla, the Tertiary Care Hospital, Pathanthira District, Kerala. Study population was patient undergoing elective surgeries and general anesthesia at Pushpagiri Institute of Medical Science. Ethical clearance was obtained from Institutional Ethics Committee. Inclusion criteria ASA 1 and 2. Patient between age group of 80 to 60 years of either sex. Exclusion criteria affecting lactating mother. Hemodynamically compromised patient, emergency cases, patients in alpha and beta blocker, patients sensitive allergy to study medication. A consecutive sampling used to select the study population. Sampling size obtained was 31. Patients belonging to ASA grade 1 and 2 scheduled for elective surgery and general anesthesia approach prior to study and written for consent obtained. Pre-anesthetic evaluation is done on day before surgery. Pre-medication given. IV access obtained. Patient randomly allocated into group F drug fentanyl given, group D dexmedetomidine given. Vital data like heart rate, blood pressure, ECG, and pulse oxygen pressure. After shifting the patient to operating room, pre-medication in the form of injection, midazolam injection, or dancetrone was given to all patients. Patient group D received dexmedetomidine 1 microgram per kg IV, and group F received fentanyl 2 microgram per kg IV. 10 minutes before induction of anesthesia. 10 minutes after the administration of study drugs. Parameters like heart rate, systolic BP, diastolic BP, pressure, and saturation were recorded. All the patients of group D and F induced with injection per 2.5 mg per kg IV and injection successfully put in 1.5 mg per kg IV. All the patients were intubated with cuff endotracheal tube of appropriate size. The outcome measurements are the hemodynamic stress parameters like heart rate, systolic pressure, diastolic blood pressure, mean arterial pressure, RTO measured after shifting the patient to the table before giving the study drug, 10 minutes after study drug, every 1 minute up to 10 minutes after intubation. Data analyzed in hemodynamic stress response parameters present as mean, standard deviation, median, range for two groups. These values are compared at each time interval between two groups using man-Whitney U test. Difference from baseline to 10 minutes over the time interval for each group will be tested for statistical significance using Friedman's and OS test. Result obtained was dexmedetomidine significantly attenuate the sympathetic response to laryngoscopy and endotracheal intubation with lesser increase in heart rate and blood pressure, systolic blood pressure, diastolic blood pressure, and mean arterial pressure compared to fentanyl. In a study, it was found that dexmedetomidine significantly attenuate the sympathetic response to laryngoscopy and intubation terms of heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressure in comparison with fentanyl. Limitation was that we don't measure plasma catecholamine levels. Features measuring the plasma catecholamine levels during induction time, we can assess the stress response better. Conclude dexmedetomidine in a dose of 1 microgram per kg IV intravenously 10 minutes before laryngoscopy and endotracheal intubation brought better and consistent attenuation of stress response to laryngoscopy and endotracheal intubation compared to fentanyl. And reference were obtained from this following.
Unfortunately, there was nothing new in the study. It is well known that dexmed is better than fentanyl in attenuating response. So I was still hoping you will have some extra point which you have found in this. Okay.
Exactly, Dr. Preeti. I think there's nothing extra in it. It has been presented in the past decade. The same thing. And whenever you are presenting, bring out some new points. That to your postgraduates and the same thing repeatedly doing. I don't think anything you arrive at. Please get some new points or compare with something else, at least.
Maybe different doses or something you could have compared. I don't know. There was nothing new in this at all. Your presentation was okay. You were fast, but it was okay. But nothing new in the study at all.
Okay, ma'am.
Yeah. Okay. Next speaker, please.
Next speaker.
Yes, ma'am.
Good afternoon, everybody. I'm Dr. Naresh, going to present my e-research paper on the topic of effect of topical aerosolized ropivacaine on the response to extubation in adult patient requiring general anesthesia for elective surgical procedure, a prospective randomized double-blind placebo-controlled study under the guidance of Dr. Anjali Sargakar, ma'am. Endotracheal intubation has become mainstay of anesthesia due to its reason like maintenance of patency of airway and prevention of pulmonary aspiration. Both intubation and extubation can cause stimulation of sympathetic nervous system, resulting in hemodynamic changes. Evidence where for intervention aiming to achieve the hemodynamic stability at extubation is currently very limited. To study the effect of airway topicalization with 0.75% ropivacaine before intubation on hemodynamic response to extubation and cough occurring at extubation. This is prospective double-blind randomized placebo-controlled study held in tertiary care hospital with the span of 16 months. Hypothesizing that the topical ropivacaine 0.75% when administered as an aerosol before intubation would reduce the hemodynamic responses and cough occurring at extubation. The ethical committee approval was taken, CTRI has been done, and total 45 is minimum sample for each group. Written informed consent is taken. Is randomization done with the computerized generated allocation plan. Drug were prepared by an anesthetic who is not blinded to randomization and administered by the anesthetic who is blinded to the assignment with including the patient of either sex between 18 to 60 years of age, ASA grade 1 and 2, and elective surgery under general anesthesia requiring oro-endotracheal intubation by excluding the mentioned criteria. All patients receive pre-medication, pre-oxygenation has been done and induced with propofol 2.5 mg per kg and IV rocuronium as a relaxant. Laryngoscopy was performed and airway topicalization done using laryngotracheal mucosal atomization devices with 6 ml of either 0.75% ropivacaine or normal saline 0.9%. Atomization done under the glottis, over the glottis, and in the epiglottis and the base of the tongue, as mentioned in the figure. Anesthesia is maintained with nitrous oxide, oxygen, and sevoflurane. Rocuronium intermittently given for muscle relaxation. The primary outcome variables are measured as systolic blood pressure, diastolic blood pressure, heart rate at 0 to 5 minutes, and cuff reflexes, bucking, and laryngoscopy for 10 minutes. Statistical analysis has been done. In for the anesthetic blinded to study, record the mentioned parameter at various interval. Cuff reflexes grading as 0 as no cuff, 1 single cuff, 2 more than 1 episode of cuff, unsustained cuff, that is, and 3 is more than 5 bouts of cuff. These are the results, baseline characteristics. This is a comparison chart of systolic blood pressure where significance is shown. This is the mean arterial blood pressure at different time period, and this is chart showing the comparison response to cuff at different timing. This is graphical representation of that. The baseline characteristics, age, gender, BMI, ASA grade were comparable in the two groups. The mean systolic blood pressure, mean heart rate, and mean arterial pressure immediately after extubation was significantly lower in intervention group as compared to the control. The cuff reflexes at different time period 0 to 5 minutes after extubation was significantly lower, although the mean diastolic blood pressure and intubation extubation was lower. The tracheal extubation is associated with variable hemodynamic changes where various methods are used to reduce that. Ropivacaine, due to its long-acting nature, attenuates extubation responses, thus reduces the cuff. The results are similar in various findings done by various scientists like Fangpi et al., Sanganolu, and Das et al. Thus, topical aerosolized ropivacaine was safe and effective than placebo in achieving hemodynamic stability and reducing the cuff reflex at extubation in a patient undergoing elective surgical procedure. These are my reference. Thank you.
Okay, doctor, it's a new presentation, ropivacaine aerosol. But how long the surgery lasted? That you have.
Hello, ma'am. Can I audible?
Yeah, you are audible.
Yes, ma'am. The surgery criteria is included that the surgery should not be last for more than 3 hours. Less than 3 hours surgeries are included in the study.
Less than 3 hours.
Yeah, ma'am. Yes.
And then what about post-operative problems with the ropivacaine aerosol? Anything you have followed it up or anything you had seen? See, 3 hours.
After 3 hours, the patient is watching PSU for further for next 12 hours. and there is no significant cough and sore throat is not found in those patients. Those were topicalized with ropivacaine.
And how long did it last? The effect of the ropivacaine?
Effect of ropivacaine lasts for 4 to 6 hours.
4 to 6 hours. Okay.
Yes,
so
ma'am.
it's a bit risky because
Have
you
you
have
recorded?
for that long.
Yes, ma'am.
Have you recorded and have you noticed and then you had not presented about it? You have done surgery post-operatively when you are given a ropivacaine and it lasted before 3 hours, and you should also have a slide of post-operative, no, peri-operative also. It's our responsibility, no, doctor?
Yes, ma'am. I had not mentioned slide, but a patient is watched in PSU for 12 hours after the extubation.
Where postgraduates, you would have gone for the next case. You wait the patient and seen. No, it's a good study, but still I tell you, it will be very complete when you look after 2 to 3 hours, minimum 6 hours after surgery. Whether there is any regurgitation or whether there is attenuation of reflexes.
Yes, ma'am.
Otherwise, it's a good study. How did you arrive at the dose?
Ma'am, the dose previously, the Thangarmer was studied about this, that 0.25% they used, and they haven't got any significant result in that study. Later on, the Hank et al. Studied on 0.75% in thyroid procedures. They found significant result for the hemodynamic stables. So we are go with the 0.75% for the all patients under general anesthesia going surgeries, elective surgeries.
Yes, good.
Okay.
We have the next candidate.
Thank you.
The next candidate is Dr. Naveen Kumar. Naveen Kumar. Yes.
Hello everyone, my name is Dr. Navdeep and my topic for presentation is comparison of efficacy of Dexmed versus clonidine as an adjuvant to bupivacaine, ultrasound guided supraclavicular brachial passage block. Various adjuvants are used along with local anesthetic to increase their efficacy and duration. Clonidine is a partial alpha-2 adrenergic agonist and Dexmed is a 8 times more potent alpha-2 selectivity than clonidine. The aim of our study was to compare the efficacy of clonidine and Dexmed as an adjuvant to bupivacaine in supraclavicular brachial passage block in upper extremity surgery for duration of sensory and motor block and also for the duration of analgesia. After approval from the Institutional Ethical Committee, a double-blind, randomized prospective clinical study was carried out for a duration of 2 years and a sample size of 100 patients was included, 15 in each group. Patients were divided into 2 groups. Group C received bupivacaine 0.5%, 30 ml plus clonidine 1 microgram per kilogram, dilated to 1 ml, and Group D received bupivacaine 0.5%, 30 ml plus Dexmed 1 microgram per kilogram, dilated to 1 ml. Inclusion criteria and exclusion criteria was followed as shown accordingly. On arrival in the OT, IV access was established and all standard monitors were attached. Ultrasound guided supraclavicular brachial passage was given, and the 31 ml of a solution containing local anesthetic combined with clonidine or Dexmed was injected. Sensory block was assessed and motor block was assessed according to modified Bromard scale. The duration of analgesia was assessed by assessing the duration of as according to visual analog scale. A VAS of 5 at the VAS of 5 local and rescue analgesia was given in the form of paracetamol 1 gram IV. The duration of sensory block was defined as the time interval between the end of local anesthetic admission and complete resolution of anesthesia of all nerves. Statistical analysis was done with the software SPSS version 22. The results showed that the sensory and motor block durations were significantly prolonged in Group D compared to Group C, and the duration of analgesia also was significantly longer in Dexmed group than in the clonidine group. Various studies have been done to compare the efficacy of clonidine and Dexmed. There has been an increasing use of adjuvants. Studies like Abusdera, Memis et al., Esmagul et al., Bajwa et al. Showed similar data as our study showed. The mechanism by which alpha-2 adrenergic agonists produce analgesia and sedation is not fully understood and likely to be multifactorial. Peripherally, alpha-2 adrenoceptor agonists produce analgesia by reducing release of norepinephrine and causing alpha-2 receptor-independent inhibitory effect of nerve action potentials. Centrally, alpha-2 adrenoceptor agonists produce analgesia and sedation by inhibition of substance P release in nociceptive pathway and the level of dorsal root neuron and by activation of alpha-2 adrenoceptor in locus ceruleus. The major limitation of the study was that the sample size was small and therefore power of the study is less. A large sample size will establish further conclusive evidence. Therefore, to conclude, the addition of dexmed to the bupivacaine brachioplexus block by supraclavicular approach results in prolonged duration of sensory and motor block and also the duration of analgesia when compared to clonidine. Thank you. These are my references.
Yeah, thank you. What did you say your dose was of the local anesthetic?
Percent bupivacaine.
How much? Sorry, you were muted.
Ma'am, 30 ml of 0.5% bupivacaine.
With the ultrasound guide block, you're using 30 ml.
Yes, ma'am, we compared that only.
You don't in your hospital, you all don't use a little lesser volume if it's ultrasound guided?
No, ma'am, the volume we usually use is 30 ml only for the blocks.
Okay, all right. Yeah. So, and then that 1 ml extra was dexmed and clonidine. What are the differences between dexmed and clonidine?
Ma'am, dexmed and clonidine, basically the alpha-2 selectivity of dexmedetomidine is 8 times more potent. So it has the more analgesic effects, and now that's what we concluded in the study also.
Duration wise?
Duration wise, ma'am, the duration was significantly longer with the dexmed group for both sensory block, motor block, and the duration of analgesia. Like for in motor block was around 222 minutes in clonidine, but it was regimen prolonged in this group.
In the dexmed group.
In the dexmed group, yes, ma'am.
All right. Okay.
Similarly, for the duration of analgesia also, dexmed was comparatively far better than clonidine.
Okay. Your surgeons didn't mind that your motor block was prolonged?
No, ma'am, surgeons didn't mind as long as the patient was having adequate analgesia and comfortable.
Okay.
They didn't mind the duration of the motor block.
Okay, all right. Yes. Madam, anything to add, ma'am?
Ma'am, you're not audible. Ma'am, I cannot hear you.
Herself by mistake.
Hello.
Yes, ma'am.
Yes, ma'am.
Yeah, I think when you are doing ultrasound guide blocks, why don't you take a less volume of solution? I think try that. Why you have a fixed volume? Whether ultrasound or not is 30 ml we are using when ultrasound. I think you have to reduce the volume burn. Plus, have you seen any rebound hypertension in clonidine group?
No, ma'am, no rebound hypertension was noted. We noted some hypertension in patients, but there was no rebound hypertension noted in any group.
No. Post-operatively, have you followed it up, and then have you seen any hypertensive episode?
We didn't see significant hypertension, any significant hypertension post-operatively. We did follow the patients to compare the duration of analgesia, but we didn't see any significant hypertension.
Follow it up.
Yes. Also, we had ASA 1 and 2 patients only in the study. So
how long follow it up?
Yes, ma'am.
How long do you follow up?
You have followed it up.
Till the duration of analgesia, ma'am, till the complete resolution of analgesia, till the patient required rescue analgesia, ma'am, we followed till that duration.
Usually, how many hours it is till the next?
Till around 7 to 8 hours, ma'am.
Anyway, nothing more to add.
Yes. Yes. Thank you.
Thank you, ma'am.
Dr. Navdeep.
From Bharati Vidyapeeth Medical College and Hospital, Sangli. My study is on evaluation of efficacy of Tremdol and Pethidine for control of perioperative shivering in the patient undergoing elective surgical surgery under spinal anesthesia. Under spinal anesthesia, the shivering is mainly due to heat loss because of venodilatation. It has decremental effects on interference monitoring of vitals, an increase in O2 consumption, and increase in CO2 production. Shivering causes increase in wound pain, delayed in wound healing, and delayed in discharge from post-anesthetic care unit. The aim is to evaluate the efficacy of Tremdal and Pethidine for control of perioperative shivering in the patient undergoing elective surgery under spinal anesthesia. Objectives are to compare the side effects of and adverse effects of both the study drugs. Ours is an observational study, and we have included the patient who had shivering in perioperative period. We have excluded the patient who refused to give consent. Sample size is 30. After IEC approval, written informed consent is taken, and we have induced with spinal anesthesia, and we have draped the patient with surgical drapes except the area operated. All the cases were evaluated for shivering, and if occurs, it was graded by Crossley and Mahajan. Patient who developed shivering of grade 1 or more were included in the study and divided into two groups: group Pethidine, group Tremdal, 15 each. The drug was given to all the patient observed for 15 minutes, and if not subsided, repeat dose of drug was given and observed for 15 minutes. If not subsided, treatment was considered not effective. Side effects were observed. If sedation occurred, it was assessed by Innova sedation score. Innova sedation score 1 is alert, 0 or 6 is unresponsive. Crossley and Mahajan scale is for shivering, 0 is no shivering, 4 is violent shivering. Statistical analysis was done by statistician using suitable statistical software. Age, sex, weight, ASA, and shivering rate were not significant. Onset of disappearance of shivering at 2 minutes and 5 minutes was significant. Side effects of nausea were more in Tremdal and less in Pethidine. Recurrence of shivering was more in Pethidine and less in Tremdal. Demographic data was not significant. The disappearance of shivering was significantly more shorter in Tremdal group. Shivering disappeared in all the patients of group D and P by 15 minutes. Complication of nausea occurred in 5 patients in Pethidine group and 8 patients in Tremdal group. As we have discussed about the mechanism of shivering, the side effect, adverse effect, shivering can happen in normothermic patient also. Therefore, we might go for pharmacological agents. Pethidine has an action on kappa receptors. Tremdal has an action of inhibiting the reuptake of norepinephrine and serotonin, and mainly acts on mu opioid receptors and minimum effect on kappa and delta receptors. Tremdal at low doses has less side effect than Pethidine, and it is higher advantage than Pethidine. We observed that shivering disappeared for 10 patients in group D and 0 in group B at 2 minutes, 13 patients in group D and 11 patients in group B at 5 minutes, 15 patients no one had shivering. Our study results showed that two groups were similar in regard to hemodynamic response, but Tremdal reduced the occurrence of perioperative shivering more significantly than Pethidine. The study showed that Tremdal is more effective for early control of shivering, and its effect on recurrence of shivering is less than Pethidine. These are the references. Thank you.
Yes, Dr. Naveen. Unfortunately, this is also a study, very tried and tested method. No, there is nothing new in your study.
I cannot start my video. I don't know. They said that host has stopped it. I'm so sorry.
Yeah, that's all right.
Yeah, yes, ma'am.
Okay, yeah. So there is nothing new in your study, unfortunately. No, this is
Actually, we have done this study because many previous studies some have showed that Tremdal is better, some have showed that Pethidine is better. So I just wanted to know which one is really better, but it came out as Tremdal.
But even in the end, in your own conclusion, all you have mentioned is Tramadol is cheaper and more easily available.
And it is better in controlling of shivering.
The effects look the same according to your study. Other than recurrence, I did not see any other positive point.
Actually, nausea was a bit more in Tramadol than Pethidine group, but yeah, because and one more thing is Pethidine, like reoccurrence was more in Pethidine. That is why I thought that Tramadol was a better drug for control of shivering.
What are the newer drugs we use for prevention of shivering?
Newer drugs, as of now in my hospital, we use only these two, and I mean mainly Tramadol. I wanted to try it out with Pethidine, but I found Tramadol.
Okay. In other places, what may be available or suggested newly? Are you aware?
I am not aware. No.
See, the whole point of this is to learn something new. You are still stuck in 2017 was your study. You removed that very fast, but I saw one study in 2017. So that is what, 6 years now, 5 years back. Huh?
I didn't know
There are
that.
newer studies, yeah. Okay. Yeah. Ma'am? Ma'am, you're on mute, I think. Yeah.
Yeah.
I think all are, earlier studies only.
Yes.
In a virtual conference like that, we expect little more newer things in 2021. And plus, both are tramadol and pethidine. Have you seen any myoclonus or any point you have not added? I think you won't have seen, obviously. But at least you should mention, no, pethidine, myoclonus, and urinary retention. Anything?
Yeah, actually, in such numbers, I didn't see anything such mention.
See in your study, it's not. Definitely, it is not. But you should have mentioned about it. Any
Yeah.
myoclonus have you seen in pethidine group of? No.
No, ma'am, I didn't see. So I have not mentioned at all.
You have not mentioned at all. You should say everything, no, possible as what tramadol causes, what pethidine, why we are not using pethidine now, why we don't, what is the pethidine metabolism, and what are the byproducts of pethidine?
Okay, I will mention it.
Pethidine or meperidine, have you known?
Yes, ma'am. The byproduct after it,
Is it cause?
after it get metabolized.
How long it acts, pethidine? How long tramadol acts?
Yeah, it is 4 to 5 hours duration of action.
Which one? Spinal, pethidine, tramadol.
Tramadol.
Pethidine?
Pethidine is 3.5 to 4.5, I guess.
Okay. Pethidine, how many hours? Okay, see, you should know it's a opioid and the side effects and hours it acts. And the we are now with pethidine not much used now because of the
poor drugs.
Products also causes problems. Okay, doctor, you should know about it as a postgraduate student. Next. Thank you.
Next.
Myself, Dr. Naveen Kumar Gayatri. I am going to present a paper presentation on comparison of dexmet and clonidine as an adjuvant to bupivacaine in PNS cadet supraclavicular access block in upper limb surgeries. Introduction. Regional anesthesia in the tomographic access block is the most common type of technique used for upper limb surgeries. It produces rapid and reliable anesthesia for upper limb surgeries from injection of local anesthesia. It has many advantages like post-operative pain relief, shortening of patient's recovery time. Various adjuvants like opioids and alpha agonists are added to local anesthetics to prolong the duration and the faster the onset of sensory and motor block and increase the quality of various type of peripheral nerve blocks in local infiltration also. This present study was conducted in upper limb surgeries to evaluate and compare the effect of addition of clonidine and dexmet in bupivacaine as an adjuvant in PNS cadet supraclavicular block. Method. The study was conducted after obtaining approval from the Institutional Ethical Committee and Scientific Committee in the Department of Anesthesia in the Tertiary Healthcare Hospital, Latur, for the period of 18 months. After explaining the details and merits and demerits of the study to the patient and his relative in their own language, written informed consent was taken. Then we have taken 80 patients for fulfilling our inclusion criteria, and the method was closed. Under the PNS guided supraclavicular brachioplexus block, we divide the patients in two groups, Group C and Group D. Group C contained 40 patients with injection clonidine, 1 microgram per kg, adding adjuvant to bupivacaine, and Group D contains 40 patients with injection dexmedetomidine with 1 microgram per kg, adding adjuvant to bupivacaine in supraclavicular block. Sampling method was randomized method. The statistical analysis was student t-test and chi-square test. Patient selections age between 25 to 55, ASA grade 1 and 2, patients undergoing upper limb surgery, and patients who are ready for consent. Exclusion criteria: patient refusal, non-allergy to local anesthetics, inpatient at local site, ASA grading 3, 4, and 5, bleeding disorders, severe CNS, and renal hepatic failures. The result of my study was the duration of sensory and motor block and the duration of analgesia was significantly prolonged in Group D, that is dexmedetomidine, as compared to Group C, that's clonidine. P-value was 0.001. There was a rapid onset of sensory and motor block in Group D as compared to Group C. Duration of better in Group D as compared to Group C. But there was no significant hemodynamical variation in both groups. In demographic data, we get the age, weight, and height are insignificant in both groups. In motor and sensory blockage, group D was better than group C. And in the comparison for duration of analgesia, group D gives more duration of analgesia compared to group C. In discussion, the duration of sensory and motor block and the duration of analgesia are significantly prolonged in group D as compared to group C. There was a rapid onset of sensory and motor blockage in group D, but there is no significant hemodynamic variation. In our study, the demographic data as regard to age, weight, height, sex, ASA physical status, and duration of surgery were compared, and the differences between the parameters between two groups were statistically not significant. In our study, Dexmet group shows longer mean duration of analgesia, earlier onset than group C. Future studies may be undertaken to find out if there is hemodynamic response could be further attended with the lower dose of dexmedetomidine as an adjuvant with the local anesthesia and supraglottic brachypexy block. Conclusion: Dexmedetomidine, when added to local anesthesia in supraglottic brachypexy block, enhance the duration of sensory and motor block and also the duration of anesthesia.
What were the doses of clonidine and dexmed in your study?
Madam, 1 microgram per kg.
And clonidine?
1 microgram per kg, ma'am. Both same.
Both. Okay. Yeah. What are the newer recommendations for dexmed? You said in your last line you have mentioned reducing
lower doses, madam.
Yes. So what are the lower doses tried?
0.5 microgram per kg we tried, ma'am. But we found 1 microgram per kg better for patient. Means motor block and sensory block is prolonged in 1 microgram per kg compared to 0.5 microgram. So it's better for us also.
Okay. What is the disadvantage with clonidine that you might have noted?
Prolonged duration of anesthesia is there. So there may be problem. Most of the time surgeons complain that patients are complaining that they can't move their hand for longer times. So
Yes.
there is a problem.
Okay. All right. Ma'am, anything else to ask?
It's not ultrasound guided, no?
Actually, ma'am, we don't have ultrasound guided ultrasound machine.
Okay, how many ml you use?
Ma'am, total 39 ml, ma'am. 39 ml bupivacaine 0.25% and 1 ml either dexmed or clonidine.
So 40 ml ultimately.
Total 40 ml.
40 ml of
Total 40 ml, ma'am.
solution.
Yeah.
Quite fair amount, 40 ml solution. Okay, good.
Thank you.
Next.
Okay, Dr. Priti, just hold it for a minute.
Yes.
Senas, where is the coordinator?
Yes, sir.
Senas, just give me a minute. Before you start the next presentation, I just want to have a minute with you. Thank you so much, Dr. Saraswati Devi and Priti Jain. I am Dr. Rashesh Diwan, the organizing chairperson of the IASCON 2021. Shana, kindly mute other people. Yeah, I am Dr. Rashesh Diwan, the organizing chairperson for IASCON 21. And I welcome you all on behalf of the Governing Council of Indian Society of Anesthesiology and the organizing team of 21 IASCON. Thank you so much for joining, and let me tell you, this is the biggest ever hybrid conference happening in the world. And because we missed the academics last year, this time we have almost the double scientific content in the conference days than any of the last 10 IASCONs. And I was amazed to see so much response from postgraduate students that we have almost 9-10 times abstracts. We sorted out 2100 plus abstracts and accommodate. So we had to extend the conference on the 5th day. We started today at 8 o'clock and 11 halls. This is something unique and history sitting happening for first time in the IASCON. And that's all because of the wonderful cooperation and involvement of all of you, particularly the students who are participating and the faculties and chairpersons like Dr. Saraswati Devi and Dr. Priti Jain, and the wonderful time taken by the Senas Master and other coordinators. We have been doing this very successfully. I'm sure it is a more or less virtual and there may be some technical hitch, and because it is first time even the vendors are doing, the meeting and more people are doing wonderful job, but there may be some lacunae in transmitting things. Please bear with that. I take the responsibility for that, but things are happening very well since morning 8 o'clock. Thank you so much for joining, and thank you so much for giving me 2 minutes.
Thank
Shanaz,
you.
you can carry on. Thank you.
We really appreciate that you are sticking to the time so correctly. I did not anticipate you correctly on time, sir.
I mean, we are making an humble attempt to be in time, but
Yes,
otherwise, more it will depend on you people that you take care of the timing. Thank you. Thank you so much. Thank you, Dr. Saraswati Devi.
Thank you, sir.
So much.
So the
Congratulations and best of luck.
Thank you so much. You can continue with the program.
yes. Thank you so much, sir. So let's go ahead with next presentation, which will be by Dr. Nilima.
Good morning. Good morning, everyone. Today I'm going to present paper on comparison of phenylephrine and norepinephrine for treatment of postspinal hypertension in parturients with fetal compromise. Vasopressors are the mainstay of management of postspinal hypertension in obstetric patients, and at present, phenylephrine is the vasopressor of choice. Recently, norepinephrine has been studied in healthy pregnant patients undergoing elective cesarean sections and is expected to maintain blood pressure with less tendency to decrease heart rate. However, no studies available in parturients with fetal compromise. Our aim was to study and compare the effects of phenylephrine and norepinephrine IV boluses for treatment of hypertension in parturients with fetal compromise undergoing emergency section under spinal anesthesia. Primary objective was to compare the fetal acid-base status. Secondary objectives were to study and compare neonatal Apgar scores, hemodynamic changes, vasopressor requirements, and any maternal complication related to the use of vasopressor drugs. The study was a randomized double-blind study at Department of Anesthesiology and Critical Care, UCMS and GTB Hospital from November 2018 to April 2020. 100 patients were randomly divided into 2 groups of 50 each. Phenylephrine group received IV phenylephrine 100 microgram bolus, whereas norepinephrine group received norepinephrine 8 microgram bolus. On postspinal hypotension, which was defined as systolic blood pressure less than 100 mmHg. Umbilical, arterial, and venous blood samples of the fetus were obtained for blood gas analysis, and Apgar scores were recorded at 1 and 5 minutes after birth. Patients included were healthy females with singleton pregnancy undergoing emergency sections for potential fetal compromise under spinal anesthesia, with non-reassuring fetal heart rate status, meconium-stained liquor with fetal heart rate abnormality, cord prolapse, intrauterine growth restriction, oligohydramnios, antepartum hemorrhage, dystocia, post-maturity or prematurity. We did not include patients with maternal complications like preeclampsia, cardiovascular or cerebrovascular disease, multiple gestation or known fetal abnormality, patients with contraindications for spinal anesthesia, or history suggestive of mesenteric or peripheral vascular thrombosis. Statistical analysis was done using unpaired t-test, Mann-Whitney used test, and chi-square test. In the results, patient characteristics were comparable between the 2 groups. Our main parameter was umbilical cord blood gas parameters, and umbilical cord pH was comparable in both the groups, and other neonatal parameters were also not statistically different. Hemodynamic parameters were also comparable in both the groups. Changes in mean systolic blood pressure, diastolic blood pressure, and heart rate after vasopressor administration was also statistically comparable. In both phenylephrine and norepinephrine were equally effective in treating spinal hypotension in the present study. The potency ratio of phenylephrine and norepinephrine in a study done by Nganki in 2017 came out to be 1:13. And there were studies by Vallejo, Nganki et al. And Mota M et al. In elective cesarean section, which showed similar results by both phenylephrine and norepinephrine. Norepinephrine has been reported to maintain a heart rate at a higher level. However, we could not find any such trend in our study. Umbilical, arterial, and venous blood gas parameters were also comparable, and Apgar scores at 1 and 5 minutes and incidence of NICU admission also did not differ in both groups in the present study. Our limitation was we were unable to measure umbilical cord blood lactate levels due to logistic problems, and as we have used both vasopressor boluses, these results were not applicable for prophylactic infusions. To conclude, both phenylephrine 100 microgram and norepinephrine 8 microgram, when administered as IV boluses for treatment of postspinal hypertension in parturients undergoing emergency sections for fetal compromise, are equally effective and safe. They result in comparable maternal and neonatal outcome and can be recommended for treatment of postspinal hypotension in this patient population. These are my references. Thank you.
Yeah. Nilima, can you unmute yourself?
Yes, ma'am. Am I audible?
Yes.
Yeah. Question for you. When did you inject intravenous bolus at what time?
Ma'am, whenever the patient developed hypotension, we were studying blood pressure values of every patient for every minute during the procedure, during the operation, until delivery of baby. Because we need to correct hypotension. If it persists for 2 minutes or more, then it could be deleterious to the fetus, and this was our primary measure to study effects of neonatal outcome.
Which is the recommended vasopressor in pregnancy?
Ma'am, phenylephrine.
What is the difference of action between phenylephrine and mefentramin or ephedrine?
Ma'am, ephedrine was used earlier. It is not used as a drug of choice because it led to tachyphylaxis, and it also led to rebound hypertension because it has a longer duration of action. Mefentramin is also a mixed alpha and beta agonist, and ma'am, it is also in our setting, mefentramin is more commonly used than phenylephrine because phenylephrine is not actually commonly available.
Yes.
So mefentramin is commonly used, but ma'am, according to literature, phenylephrine is considered.
So it can be used definitely, but
Yes,
it didn't really make sense unless you wanted to compare the two drugs. So I just wanted to know that whether you are aware for obstetrics, actually mefentramin and ephedrine shows beneficial effects. But then you also mentioned that the fetal blood gas values, because of logistics problems, you couldn't get, right?
Ma'am, the lactate levels, ma'am.
Lactate levels, sorry. Yeah, the lactate levels you were not able to get.
Yes,
we may have known better with that.
Yes, ma'am.
Okay.
One question. You said hypotension. After minutes of hypotension, every 2 minutes you are checking.
Ma'am, every single minute we were checking because if hypotension persisted for 2 minutes, it would be deleterious to the fetus.
Monitoring or doing manual monitoring or
Sorry, ma'am.
intraarterial?
Sorry, ma'am.
Hypotension is non-invasive monitoring.
Yes, ma'am, non-invasive monitoring.
Invasive
Ma'am,
monitoring.
because ma'am, our patients, we studied the population group with those pregnant patients who were having fetal distress. So we were not having time in the initial period also to calculate 3 baseline blood pressure values and take a mean value of that. So we started with the first initial baseline blood pressure value and then took systolic blood pressure. Whenever it went down below 100, then we considered it as a hypotensive episode and gave the drug.
Parameter. For every patient, you take it as 100, or when do you
Yes,
consider
ma'am.
as a hypotension?
For every patient, ma'am, because all the patients, they came in emergency
Hello?
conditions with fetal compromise.
Hypotension below for each patient have depends on the original blood pressure you go.
Ma'am, because all the pre-eclamptic or hypertensive patients were already excluded from the study. So the patients who were having normal baseline blood pressure values ranging from 100 to 130 systolic, they were included in the study. Hello?
Hello, yes.
Hello.
Okay, okay. Ma'am?
Yes, ma'am. The next person would be Dr. Neeraj Reddu.
Next speaker. To hear the audio somehow.
Good morning to all. Myself, Dr. Neeraj Reddu, anesthesiologist resident, Pandit P.D. Sharma, PGIMS, Rohtak. Today is my topic for evaluation of the analgesic effect for lidocaine patch 5% in post-herpetic neuralgia. Herpes zoster is a very common, painful, and debilitating condition caused by reactivation of the varicella zoster virus from a latent infection of the sensory ganglion. Herpes zoster is clinically characterized by maculopapular or vesicular rashes, usually accompanied by pain, unilateral and restricted to dermatomes. PHN defined as pain persists for more than 90 days after the onset of the herpes zoster rashes. Various modalities of the chronic pain management like NSAIDs, opioids, and local injectables have been used according to WHO analgesic ladder for pain relief. Lidocaine is also used in various forms in pain management. Lidocaine patch 5% acts in two forms, pharmacological action through diffusion and protective action of hydrogel plaster itself. In this study, visual analog scale is used for pain assessment of PHN. This is a prospective and observational study. Inclusion criteria. Patient of age group 18 to 80 years suffering from the chronic pain due to post-herpetic neuralgia, having VAS scale more than 4 for at least 3 months without satisfactory pain relief from conservative treatment. Anticonvulsant, antidepressant opioids like presenting pain clinic OPD were included in the study. Exclusion criteria. Patient with any history of severe medical illness, allergic to lidocaine or other local anesthetic, pregnant and lactating females, and any other motor neuron diseases, psychiatric disorder, and fever. Analgesia technique. After obtained written and informed consent, lidocaine patch 5% was applied on all painful area of appropriate size for a minimum period of 12 hours, and the patch was removed for next 12 hours. And continued this process till VAS had declined to 4 or up to a maximum of 4 weeks of total duration of study with continuation of oral analgesic medication. Observation. Evaluation of pain by using VAS at day 1 and week 1, 2, 3 and 4. Total number of patch used per 4 weeks. Side effects if any. Results. The observation were subjected to statistical analysis. In our study, mean was at day 1 and first, second, third, fourth week is significant with p-value 0.001. In our study, total number of patch used in 1, 2, 3 and 4 week is also statistically significant with p-value is 0.001. No local and systemic side effects are seen in any patients. All patients are satisfied with treatment. Conclusion. The study conducting on 24 patients, 11 male and 30 females, with VAS score maximum 10 after treatment with the lidocaine patch 5% according to standard protocol for 4 weeks. At the end of study of 4 weeks, VAS declined to 4 or less with no side effects and with good patient satisfactory score. Results of our study provide evidence for beneficial pain relieving effect of lidocaine patch in treatment of PHN. Results are similar to study done previously by Srinivas et al. And Martini et al. With p-value 0.001. And these are the statistical graphical presentation for the VAS and total number of patches used. And these are the references from where we took the help. Thank you.
Doctor, I just wanted Dr. Neeraj. Your name is Neeraj,
Yes,
no?
ma'am. Yes, ma'am.
Yeah.
Good morning, ma'am. Good afternoon, ma'am.
Hello.
Hello, I'm audible, ma'am?
Yeah,
Yes,
yeah.
you're audible. Yeah.
The patient is already on gabapentin or pregabalin group of drugs.
Yes,
Post-herpetic neuralgia. It's a neuropathic pain.
Yes, ma'am.
What type of pain is it?
Ma'am, basically, we include the post-herpetic neuralgia patient, basically neuropathic pain. And most of the patients sometimes already have used pregabalin, gabapentin or carbamazepine, and some they had left because of the not relief. They had not relief from these medications of the pains. Both of the patients are there.
Okay, post-herpetic neuralgia, these drugs, the patients now you had put on the patch, are they on these drugs or not?
Ma'am, which patients already they continue with their patients with the lidocaine patch and also continue with the oral analgesic medications which they had already taken. But with the duration of the studies, we observed that the total amount of the drugs which they already used oral analgesic, they had decreased in amounts.
How much they have decreased and what was the previous dose? Were the patients or put on tricyclic antidepressants also along with pregabalin?
Which are already taken but they continue, and some of the patients they totally stopped this treatment or basically oral analgesics totally stopped. And only lidocaine patch for 5%, they have the significantly reduced the pain in the VAS score.
Lidocaine patch, you put it on the place where the pain is generated, or do you put it somewhere else?
No, ma'am, it's generally it's basically placed on the maximum painful area where the rashes are spotted, specifically dermatomes. We put the patch on that location, not on any other locations. It's the
Do you
basically
get
local
significant
section.
results in it?
Yes, ma'am.
Do you find significant results in it? VAS score has come down with lidocaine patch drastically.
Yes, ma'am. We found that the lidocaine patch is very effective in the reducing the VAS score in all patients.
You said for 4 weeks or 30 days you had put. After
Yes,
how many days you had found the beneficial?
Almost in all patients, ma'am, 1 week is significantly reducing the pain. Like in starting at day 1, the VAS is 8, 7, 8, 9, and at the end of the first week, the VAS significantly reduced by 2 points or 3 points.
So how many milligrams of lidocaine patch you had put? 5 milligrams.
Yes, ma'am. 5%.
5 milligrams every?
Sorry, ma'am. Ma'am, is the lidocaine patch 5%? Its total dose is, it has the 2 patches, 10 into 12, 14 centimeter, and total dose is 325 mg in each patch. Total dose is 700 mg, and we use it by cutting the according to maximum painful area, not the applied full patch on the same area.
So you are putting maximum dose of 700 milligrams per day.
Ma'am, per week की है ये. We can divide it into patches in portions.
Okay. How many references do you have with this?
Ma'am, one Indian reference, Dr. Srinivasan.
From?
Dr. Srinivas.
Srinivasan from which place? The Indian reference?
Yes, ma'am. Indian reference from south side, and exactly state is right now.
You have very few references in this post-herpetic
Shown
neurology.
only 2, no?
मैम एक्चुअली लिटरेचर्स में मैम आर्टिकल्स में हमने 4 to 5 स्टडीज इसमें स्टडीज किया है, बट in this studies we have only 2 reference, basically just from where we compare these studies.
Neuralgia getting relieved with lidocaine patch.
Yes, ma'am.
I think very, 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 very few references you may get. It is not the choice. It's not the treatment of choice anyway. For that, you have 2 references. That 2 references, you should be thorough with it. Okay. What is the other reference? One is Dr. Srinivasan. Other one is?
Ma'am, one is of Argov et al. Is Argov ka hai, ma'am, in 2004. One is of Leonardo Bianchi in 2020. One is of Binder is 2009. And one is of Martini in 2008.
Okay. These 4 references, they are good results. They are not found good results.
Ma'am, they found the good results in the post-herpetic measures, and Dr. Martini suggests concluded from his study that it is an add-on therapy, and Dr. Srinivasan concluded that it is acted as in a first-line therapy in post-herpetic neuralgia, lidocaine patch 5%.
Okay. Okay. Anyway, anyway, let's try and then see. Okay. Good.
Thank you, ma'am.
Okay. Thank you, Nilima. Next candidate will be Dr. Nivedita.
Morning all, my yield paper presentation topic is about efficacy and safety of using air versus 2% lidocaine for inflating endotracheal tube cuff and its pressure effect of the incidence of post-operative cough and sore throat. Introduction. Coughing, sore throat and hoarseness are the most common post-operative complication after emergence from general anesthesia, which are very distressing and unpleasant and becomes more upsetting than the surgery itself. Post-operative sore throat, being the most undesirable symptom, occurs in more than 50% of surgical patients. Aims and objective: to compare the endotracheal tube cuff pressure inflated with air or lignocaine during anesthesia and evaluate clinical symptoms such as coughing and post-operative sore throat following tracheal extubation. Materials and method: it's a comparative prospective study which includes 100 patients. Patients were divided into two groups, A air group and L, that is lignocaine group. Endotracheal tube cuff was inflated with air or 2% lignocaine to the volume that prevented air leak during cuff pressure manometer. Inclusion criteria: patient with age group 18 to 65 years were included, which with the American Society of Anesthesiologists class 1 and 2, Mullumpati classification 1 being posted for surgeries under general anesthesia. Exclusion criteria included laryngeal diseases, tracheostomized patients, ASA class 3-4, difficult intubation and failed extubation patients were excluded. In A group, endotracheal tube cuff was filled with air to prevent air leak during positive pressure ventilation guided with cuff manometer, while in the L group, endotracheal tube cuff was filled with 2% lignocaine. Care was taken to ensure that starting cuff pressure was approximately 20 cm of water, adequate enough to prevent leak around the cuff during positive pressure ventilation. Volume and cuff pressure of air and lignocaine injected in the cuff was noted at the start and the end of the surgery. Total duration of anesthesia was also noted. Immediately after extubation, an independent observer guided from the study group recorded the presence or absence of coughing. Similarly, in the post-operative care unit, occurrence of coughing and post-operative sore throat at the first hour and 24 hours were recorded. Coughing and post-operative sore throat was recorded as present or absent. Results: cuff pressure and volume achieved in the end of the surgery were much higher in the air group as compared to the lignocaine group, the P value of less than 0.05. Incidence of coughing and post-operative sore throat in the first and 24 hours post-operatively was significantly higher in the air group compared to lignocaine group. Impact of duration of anesthesia on the rise in the cuff pressure was significantly higher in the air group, and its effect on the cuff-induced laryngotracheal mobility was significantly increased in both the air and lignocaine group. So this is a bar chart where the red bar denotes the lignocaine group and the blue denotes the air group. The coughing is significantly reduced in lignocaine group. And similarly, the sore throat is significantly reduced in the red bar, which is lignocaine group. Discussion: endotracheal tube cuff pressure is an indirect measure of pressure exerted by cuff over tracheal mucosa that is not monitored routinely. The critical function of endotracheal tube cuff is to provide adequate seal to airway during positive pressure ventilation to prevent aspiration due to underinflation. Long duration of cuff inflation can result in mucosal ischemia and further complications such as coughing, post-operative sore throat, tracheal ulceration, stenosis, and even tracheoesophageal fistula. Lignocaine inserted in the intracuff acts as a reservoir of local anesthetic, which being a liquid not only prevents the diffusion of nitrous intracuff but also permits through the semi-permeable membrane of polyvinyl chloride to provide a soothing effect of tracheal mucosa and helps in reducing the pressure-induced necrosis and cough reflex. Conclusion: this study showed the significant use of 2% lignocaine in the prevention of rise of cuff pressure and incidence of coughing and post-operative sore throat. Duration of anesthesia has a significant effect in the incidence of post-operative tracheolaryngeal morbidity. These are my references. Thank you.
Dr. Preeti,
Yes,
anything to add?
Yeah, Nivedita, this is a regular study, nothing new. What are the newer methods tried for preventing, inflating the cuff? Let's stick with your cuff only. Anything else has been tried?
And we can try with the normal saline.
Okay. Anything else?
Or else we can go for supraglottic airway devices in case.
With your endotracheal tube only. Have you seen alkalized lignocaine has been tried? Yes. Okay.
Parent articles are available, ma'am, but I haven't tried with alkalized lignocaine. I just used the normal 2% lignocaine.
Okay. Okay. All right. Yes. Nothing else bad from my side. Anything else, ma'am? You have tried?
Nothing much.
Okay. Yes.
We used to do blue.
Yeah.
Methylene blue also in some of the laryngeal surgery. But anyway, she has excluded that criteria.
Correct.
Okay, ma'am.
Okay, good.
Next speaker.
Good. Thank you, Dr. Nivedita. Next person will be Dr. Nevin. Yes. Dr. Nevin has joined.
Yes. Go. Okay, I just repeat my question.
Dr. Nevin, can you please start your slide?
Yes, ma'am. Yeah. postgraduate from Kidwell Memorial Institute of Oncology, presenting a comparative study between two different doses of dexmedetomidine on the attenuation of hemodynamic stress response in patients posted for elective onco surgeries. Direct laryngoscopy and endotracheal intubation are not just events that can cause profound cardiovascular changes that can be determined in these other patient populations. Dexmedetomidine as a pre-medication can be done. Primary objective was to compare 0.5 microgram per kg dexmedetomidine versus 1 microgram in attenuating this response to intubation. Secondary objective was to ascertain which among the two doses had lesser unwanted hemodynamic sequelae. It was a randomized prospective single-blinded study. These were my inclusion and exclusion criteria. Sample size was calculated to be 140 with 70 in each group. Patients who fulfilled the inclusion criteria were randomly allocated to one of the two groups. Group A received 0.5 microgram per kg dexmedetomidine. Group B received 1 microgram per kg dexmedetomidine. Standard NPO guidelines were followed for all patients. They were given pantoprazole and alprazolam on the night prior to the surgery. After arriving to the pre-op room, they were given their designated drugs with all monitors being attached and functioning. Once they were shifted to DOT, they were pre-medicated with midazolam, ondansetron, and injection fentanyl, 1 microgram per kg. They were pre-oxygenated for 3 minutes with 100% oxygen. General anesthesia was induced with propofol at 1.5 milligram per kg, and after confirming adequacy of ventilation, succinylcholine was administered. Patients were then intubated with appropriate sized cupped endotracheal tube, and general anesthesia was maintained with nitrous oxide, oxygen, and isoflurane with a MAC of 0.8. For maintenance of relaxation, veterinum bromide was given. Intraoperative monitoring was the standard ASA monitors. At the end of surgery, once neuromuscular blockade was reversed, patients were extubated. Once the reversal and the extubation criteria were met respectively, hemodynamic parameters such as heart rate, systolic, diastolic, mean arterial pressures were recorded before the administration of drug, before induction, before intubation, 1 minute, 3 minutes, 5 minutes, and 10 minutes after intubation. Data was analyzed using the SPSS 22 version software. Appropriate statistical tests were used for significance. There was a decrease in mean heart rate seen with both groups, but a greater decrease was seen with group B, and a statistically significant difference was seen within the two groups at all points after intubation. There was a decrease in mean systolic blood pressure seen with both groups, but a greater decrease was seen with group B, and a significant statistical difference was seen between the two groups at all points after intubation. There was a decrease in diastolic blood pressure in both groups, with a greater decrease seen with group B, and a statistically significant difference was seen between the two groups at all points after intubation. Mean arterial pressures also yielded similar results, but there was an incidence of 17.2% of hypertension in group B, for which a fluid bolus of 200 ml was given to maintain hemodynamic stability. There was no desaturation noted in either of the two groups. Demographic details were comparable between the groups. Getination compared 0.5 microgram versus 1 microgram per kg dexmedetomidine and found out that 1 microgram attenuated the response, whereas 0.5 did not, and no group showed any side effects. In our study, 0.5 and 1 both attenuated, but 1 microgram was attenuated the response with causing hypertension in 17.2% of cases. Sebastian et al. Found out that 0.75 microgram per kg attenuated the response without any side effects. In our study, 0.5 was enough in attenuating the response without any side effects. Our study hence concluded that 0.5 microgram per kg dexmedetomidine can be used as a pre-medication to blunt the stress response to laryngoscopy and intubation. 1 microgram can be used, but they were associated with increased incidence of side effects. These were my references. Thank you.
It's not audible to me. Dr. Preeti, can you...
Yeah, Naveen, yeah, I think he's got some background noise.
1 minute.
Yeah.
Is it better? Am I audible now, ma'am?
Yes, you are audible, but there's a little background noise. Yes. Okay. Ma'am, you're able to hear now, ma'am?
I'm able to hear, but I was not able to follow his slides. Anyway, you just proceed. I will just follow the...
Yes. Okay. So according, you found that 0.5 was equally effective to 1 mic per kg, right?
Yes, madam. That's what.
Yeah. And how long did it act? Both doses acted for the same duration, is it? Or what was the duration of action?
Both were given over the same.
And duration
Both were
post-operatively?
No, ma'am. We did not monitor intra-op or post-op. We just look for the stress response intubation.
Okay, only the intubation stress response, and you did not monitor the duration otherwise.
Yeah,
Okay.
yes.
Okay, yeah. So probably that might have helped knowing
Yeah, no,
the
ma'am.
difference between the effect of the two drugs, since you found that
Yeah.
both are good, but there's no real harm in giving 1 mic per kg. Right? You said that even though there was a fall in blood pressure, you were able to control with just 200 ml of fluid.
We can control it.
Yes.
Yeah,
yes.
that is what we have. Yeah.
Okay, all right. And your recommended studies, only one study said that 0.5 was not effective.
Both the studies which I had reviewed, they said 0.5 is not in. They said 1 and 0.75 would be better. But for our group of patients, 0.5 worked. So,
equally effective.
That was it was equally effective. Yeah.
Okay, thank you, Neville.
Okay, thank you.
Okay. Thank you, Dr. Neville. The next person will be Dr. Nidin.
Today, I will be presenting my paper on the comparative study of the performance of laryngeal mask airway in pediatric patients under propofol anesthesia with and without the use of scoline. Anesthesia has made major advances in recent years ever since the introduction of LMA by Archie Brain. Even in children, the use of LMA has increased in the recent years. It causes less direct stimulation of the airway as it is placed above the larynx. Insertion requires adequate depth of anesthesia to prevent complications like coughing, struggling, laryngospasm, and patient movements, and thus increases the success of insertion. Propofol is a most commonly used agent to facilitate LMA insertion. The dose required to produce sufficient depth varies from patient to patient. The use of adequate dose of propofol to prevent the insertion-related complication can lead to adverse hemodynamic changes. Numerous studies have shown that adding a small dose of muscle relaxant along with propofol increases the success of LMA insertion along with reduction of the complication associated with LMA insertion. Succinylcholine, which has been used in many studies, has a rapid onset, short duration of action, and is not very expensive drug. In this study, 60 patients belonging to ASA grade 1 and 2, aged between 3 to 10 years of age, and undergo elective surgery, were randomly assigned to groups. An informed written consent was taken from the caregivers of the children. It's a comparative type of study with inclusion and exclusion criteria as given. Group A received propofol 2.5 mg per kg with a small dose of scoline, that is 0.5 mg per kg. Group B will receive injection propofol 2.5 mg per kg. A detailed medical history, physical examination between preoperative investigation was done for all the patients. Before injection, invasive monitoring, non-invasive monitoring were connected. 100 BP saturation were monitored. After pre-oxygenation for 3 minutes, patients were pre-medicated with injection glyco and fentanyl, and Group A received propofol and succinylcholine, and Group B received propofol alone. Size of LMA classic will be chosen according to the weight of the patient, and insertions done by standard technique. Basal heart rate, BP, oxygen saturation were measured, and subsequent measurements done after pre-medication, after induction, and at 1, 3, 5 minutes after LMA insertion. At the time of insertion, adverse effects like coughing, gagging, limb movements, or insertion condition were noted. Categorical data were represented in the form of frequency. Association between variables were assessed with chi-square test. Quantitative data were represented as mean and standard comparison variable has been done with unpaired t-test. A p-value of less than 0.05 was considered statistically significant. These were the results which I got from my study. Adverse effects like coughing and gagging, we can see from this graph that was none for in Group A, while in Group B it was moderate or severe. Severe had 36.6% patient had severe coughing or gagging. Similar as a result with limb movement, 83% in the patients in the Group A has no limb movements, while in Group B, 53.3% has severe limb movements. Coming to overall inserting condition, 80% of population patient in the Group A has excellent inserting condition, while in Group B, 53.3% has poor inserting conditions. Coming to the overall adverse effects, 80% of population Group A has no adverse effect, while in Group B, 63% has adverse effects. The dose of propofol required in Group A was 2.5 mg per kg or less, while in Group B it required more amount, 3.03 mg per kg. Hemodynamics were not much altered. In our study, succinylcholine low dose significant decrease of propofol doses required for induction. Cheng et al. Used etomidate as an induction agent with low dose of succinylcholine with added advantage of lack of respiratory depression. Bonham et al. Also used load of succinylcholine and compared with the low dose of atropine for LMA insertion during therapeutic induction and found that overall insertion conditions were excellent with low dose of succinylcholine. Succinylcholine does improve the inserting condition as well as the correct placement of the LMA. After the first attempt, there was a trend towards reduced incidence of head or limb movements and coughing or gagging. Concluding, Unit dose of saxamethanin, like in our study, 0.5 mg per kg, was effective in improving the condition for LMA insertion. It reduced upper airway responses to LMA insertion and thus a dose of propofol required. These are my references. Thank you.
Okay, ma.
Yes.
Along with saxamethonium, definitely you will find it may be subapneic. I can't say that it is subapneic doses also. 0.5 milligrams, it's okay dose to reduce the reflexes. Okay, Dr. Preeti, anything to comment on this?
Oh no, there was nothing really new in the study.
Propofol with saxa
Yeah.
definitely will be a better choice.
Yes.
When compared to propofol alone. And Dr. She has given 0.5 milligrams. Okay.
Yeah. Which is,
Hello.
Yeah, you mentioned adverse effects. Which were these adverse effects which were more in the first group? Hello. Yeah, Nidhi.
Hello.
You
Yeah,
mentioned
ma'am.
adverse effects, no?
Yeah.
What
Yes,
are the
ma'am.
adverse effects which you are talking about?
Coughing, gagging, and like limb movements, mostly head and limb movements.
Okay. So maybe it was that your propofol or your fentanyl or whatever analgesic you gave, opioid you gave might not have been enough, I felt, more than any other thing. Okay. Yeah. Okay.
One
Yes.
question, ma. Do you, the patient had any explained or had any history of calf muscle pain with this 0.5 milligrams of saxa?
No, ma'am. We didn't observe anything like that, ma'am. No
Didn't
myalgia,
observe,
nothing.
didn't. Usually with saxa 1 milligram, you find calf muscle pain
But-
and muscle pains. With
Yes,
point,
ma'am, but we are using 0.5.
yeah.
With
Did
0.5,
you-
we didn't observe any kind of myalgia, ma'am.
You should have added that point whether you had observed, because you have not, you are telling, but you have not in that
mentioned it, so because that's
But
what
in my
usually
study,
finding.
actually, I'm not in my study, I'm not actually studying that myalgia or the sore throat associated with succinylcholine. But in many of the articles which I have studied, like nothing was observed with 0.5 mg per kg.
Okay.
Okay, but we should have added in our study also.
Okay.
Okay, thank you.
The main problem is the muscle pains, no?
Yeah,
When
ma'am. But most of the studies is like more on the higher doses, like more than 1 mg per kg dosage.
More
There will
than
be
one.
like myalgia.
Only we use 1 milligram itself to develop very severe pain. Sometimes
Yes,
a patient,
1 mg and more.
yes. So you should have added so that it would have thrown a light that it is not, muscle pains are not there.
Okay.
Okay, ma. Thank you. Next speaker.
Thank you, ma'am.
Thank you.
Thank you, Nidhin. The next candidate is Dr. Nidhi Sejpal.
Hello everyone, I'm going to present my paper on clinical comparison of two insertion methods for IGL placement, standard versus rotational technique. IGL is an innovative supraglottic second generation airway device made up of thermoplastic elastomer. Use of IGL has some advantages over endotracheal intubation, such as quick and ease of placement, devoid of hemodynamic response of laryngoscopy, lesser requirement for neuromuscular blockade, and less chances of sore throat and cuffet removal. So in SARAT technique, the IGL is conventionally placed with its concave curvature facing the mandible using pen holding grip, inserting device still fitting over the larynx. But the bulky design of IGL made insertion time longer, and sometimes the tongue size also affects the insertion. So various alternative insertion methods have been described. In rotational technique, IGL is inserted into the mouth, rotated 90-degree anti-clockwise, advanced downwards bypassing the body of tongue. Resistance is felt at hypopharynx. Then it is re-rotated clockwise to SARAT orientation, at which point it will be returned to the middle. In reverse technique, IGL is inserted just like how we insert Kugel's airway with its concavity reversed that is facing cephalic. Primary aim is to compare the success rate, insertion time, and hemodynamic response between the two different methods. And secondary aim is to know and compare complication related to insertion technique. Inclusion criteria are patients aged 18 to 60 years of either gender, planned surgeries under GA with duration of 1 hour, and modified myelopathy grade 1 and 2. Exclusion criteria are emergency surgery, any pathology of neck, upper respiratory tract or upper GIT, ASA grade 3 and 4, patient with mouth opening less than 2.5 cm, history of OSA, pregnancy, cardiac, hepatic renal abnormality, alcoholism, smoker, diabetes mellitus, and significant GRD. Such patients were excluded. After institutional ethical committee approval and informed consent, 100 patients were allocated into two groups of 50 each, group S for SAR method and group R for rotational method. Normal routine induction was done with appropriately sized IGL according to weight. Effectiveness of placement was based on square wave ETCO2 capnography, auscultation, and movement of chest wall. If there is audible air leak with peak air pressure of less than 10 centimeter of water, then manipulation like gentle advancement, chin lift, jaw thrust, head flexion or extension was applied. Even after such manipulations, if the audible air leak still persists, then the attempt was considered as failure and IGEL was inserted with the same technique again. The time of insertion was calculated from the picking up of IGEL to the initiation of mechanical ventilation. Maximum 3 attempts were allowed for 60 seconds each. Hemodynamic and respiratory parameters were recorded immediately after IGEL insertion. Any blood staining on device or incidence of sore throat was observed in post-op period. Now, observation. As you can see from this graph, when compared to standard technique, the success rate for IGEL insertion in first attempt is significantly higher with rotational technique than the subsequent second and third attempt. This graph shows that rotational technique needs more time for successful insertion when compared to standard technique, and the difference was significantly higher. This graph shows that rotational technique has less incidence of blood staining and sore throat in the post-op period. So in this study, no difference were observed in patient characteristics like age, sex, or ASA grade 2, ASA grading. First attempt success rate and insertion time is significantly higher in group R than group S, and incidence of manipulation is more in group S than group R. No hemodynamic changes were observed before and after IGEL insertion. Higher incidence of blood staining and sore throat was observed with standard technique than rotational technique. So conclusion is IGEL insertion using rotational technique has higher first attempt successful insertion rate, easier insertion, and less mucosal damage. So it should be practiced in routine. Now there are some limitations. So we try to minimize the bias by reducing the subjective endpoints. And we don't have disposable IGEL in our institute. So same IGEL is used after selection in multiple patients. So this is those multiple attempts in proper placement. So IGEL was inserted by a single expert in the study. So the results are not applicable to the one who are familiar with the standard technique for insertion. These are some of my references. Thank you.
Okay. Yes, good. I like the way you stressed on the limitations of the study as well. We were very frank about it. It was
Thank
good.
you, ma'am. Thank you, ma'am.
I personally have not used the rotational method, but after your recommendation, I want to try it. Let's see. Good otherwise.
Yes, thank you, ma'am. Thank you, ma'am.
Yeah, I think students, they keep doing that rotational method, but when it comes to the study, then it is known. Anyway, good presentation, and I do appreciate your negative points about your study. Good, ma'am. Okay.
Yes, thank you so much, ma'am. Thank you, ma'am.
Okay.
I think we have done with the 15 students.
One more, I think. No, is it?
No, ma'am. It's done. It's done. Any more question, ma'am?
No, I think.
Okay. Thank you so much, ma'am, for being the chairperson. Yeah.
Thank you,
We are
Shanaz.
done with our session, ma'am.
Yes. Okay. Thank you so much, everyone.
Thank you so much for your time, ma'am.
Yeah. Thank you.
I think we have done with the 15 participants.
Yes, ma'am. Yes, ma'am. They said. Thank you, ma'am. It was nice meeting you here.
See you somewhere.
Yes, ma'am.
You are nearby in Mangalore only.
Bangalore only. Okay, ma'am. Yes.
Okay, we'll catch up sometime.
Thank you,
you
Dr.
so
Alok.
much. Yeah.
Hello, everyone. I am Dr. Rashesh Diwan, the organizing chairperson for IASCON 2021. I welcome you all on behalf of the Governing Council of Indian Society of Anesthesiologists and the organizing team of IASCON 2021. We all know we have passed through a very difficult phase in the life, and now gradually we are trying to overcome the situation. Many of us suffered the pandemic, and of course, many of us also worked for the pandemic for the community, and we were praised all over the country and all over the world. It was a great learning time for all of us. However, we missed the last year completely for the academics. But now we are beginning, and we are beginning with a very mega academic fiesta under the banner of Indian Society of Anesthesiologists. This is the biggest ever hybrid conference and happening for the next 5 days. I am sure you will enjoy the most. We have made a humble attempt to accommodate as many presentations as possible. And in view of the overwhelming response for the presentations, we extended the conference on the pre-CME day. This is the today. We are starting today at 8 o'clock, and we have plenty of e-papers accommodated for 1 day. Once again, I thank you all for the participation in IASCON 2021 and wish you good luck. Stay safe. Long live ISA.
Hello, good afternoon. Dr. Prabha is there? Hello? Hello, Dr. Mamta is there. Am I audible?
Yes, you are audible.
Yes, ma'am.
And
You
Dr.
are
Prabha,
audible. I'm checking, ma'am. Just wait, ma'am.
Hello. Good afternoon, everyone. Am I audible? Hello.
Yes, ma'am. Yes, ma'am. You are audible, ma'am.
Okay. Good afternoon, everyone.
Prabha is our next. Shall we start?
Dr. Prabha has joined.
Hello?
Hello, Prabha madam has joined.
That's what Alok is checking. So we'll just wait for her to join.
Yeah, yes, ma'am. She is another chairperson.
Yeah, that's what I'm waiting for. Alok, can you check? Just a minute.
Ma'am, I am calling her, ma'am. I'm calling her, ma'am.
Okay. Sorry for the technical issues. We are just waiting for Prabha ma'am to join the session. She's chairing the session with a Mamta ma'am. So we are just waiting for her to join. Just bear with us.
Starting your camera.
Can we start?
Yes, start.
Okay, yeah. Good afternoon, everyone.
Yes, sir. Yes. Good afternoon.
Start, please.
Yeah, please start.
Share the slide after.
Yes, sir. We can start this.
Good morning, everyone. Topic of my presentation is analgesic effect of dexmedetomidine with bupivacaine and bupivacaine alone in patients undergoing laparoscopic cholecystectomy, a prospective randomized double-blind comparative clinical study.
Lab chole has become one of the most widely performed procedure that is associated with lesser blood loss, reduced pain intensity, better osmosis. Pain after laparoscopic surgery results from the stretching of intra-abdominal cavity. Intraperitoneal installation of local anesthetic agents alone or in combination with opioids or alpha-2 agonists such as dexmedetomidine have shown reduction in post-operative pain following laparoscopic cholecystectomy. Dexmedetomidine is a lipophilic alpha-methanol derivative with a high affinity of alpha-2 receptors. Vivitrol is an amide long-acting local anesthetic. Half-life is 2.7 hours. The aim of this study was to compare the analgesic effects of intraperitoneal port-site installation of dexmedetomidine combined with bupivacaine alone in patients undergoing laparoscopic cholecystectomy. Material methodology consists of study design, which is a randomized, double-blinded, prospective, comparative clinical study. Study population is of 80 patients. Inclusion criteria ASA 1 and 2 patients of either sex, age between 18 to 65 years. Exclusion criteria consists of patient less than 18 and more than 65, negative consent given by the patient, ASA 3rd and 4th, allergic to local anesthetic, acute cholecystitis, severe cardiac, pulmonary, neurological, and psychiatric disease, BMI more than 30 kg per meter square. Methodology was of two groups. Group A received intraperitoneal bupivacaine 0.25% 2 mg per kg made up to 60 ml. Group B received intraperitoneal bupivacaine 0.25% 2 mg per kg plus 1 mg per kg dexmedetomidine made up to 60 ml. Pain assessment was done using 11-point visual scale. The primary outcome was to compare pain, and secondary outcome was time to compare the time to first request of analgesic in post-operative period, total dose of analgesic used in 24-hour period, any adverse side effects, time to reach modified LDH recovery score, that is 9. Statistical analysis consists of sample size calculated using power and sample size calculator and assuming 30% improvement in pain scores with alpha error of 0.05. Power of 80% statistical analysis was performed using SPSS version 25 software. Results were expressed as mean plus minus standard deviation number in percentage. Test was used were sample t-test. There was no significant difference seen in diagnostic parameters. Hemodynamic parameters was comparable. Difference in one VAS and analgesic consumption of rescue drug used between two groups was significant in first 6 hours. These are the graph showing in comparison between bupivacaine and bupivacaine plus dexmedetomidine as compared to age, BMI, duration of surgery, time to reach modified LDH score of 9. In our study, there was no significant high hemodynamic changes. There was no significant difference in modified LDH recovery score. Total dose of analgesic required in the post-operative period was significantly less in both bupivacaine plus dexmedetomidine. In our study, VAS score for bupivacaine and dexmedetomidine combination group was lesser over 24 hours in comparison to bupivacaine group. Conclusion was that intraperitoneal installation along with port-site infiltration of dexmedetomidine and bupivacaine combination provides effective and safe post-operative analgesia in patients undergoing laparoscopic cholecystectomy in comparison to that of bupivacaine. These are the references. Thank you.
Open for the question.
Hello, am I audible?
Yeah. Yes, ma'am.
Double blind study, Nidhi. How you have done double blinding in this study?
Good afternoon, ma'am. And first of all, the anesthesiologist who was giving the drug, he was not aware of the drug, whether it's only bupivacaine or the drug is having dexmet also. And second was the patient. Even patient was not having the knowledge whether that patient got which group of the drug.
Okay, okay. And what parameter you have used to accept sample size preparation? Calculation of sample size? Which parameter you have used? Primary parameter?
Ma'am, primary parameter was hemodynamic vitals and the secondary was the adverse effects.
Okay, okay. Now, what is your result?
Ma'am, I found that the hemodynamic stability was more in group A and the adverse effects I found more in group B. Like when I've given the dexmet drug, I found that the hypotension, bradycardia adverse effects were higher than that of group A.
But is it within normal limits, or it is a significant hypotension and bradycardia for this patient?
No, ma'am, it was in normal limit. It was significant initially 6 hours, post-op initial 6
And it
hours.
is significantly reduced.
Yeah. Yes.
What you have done if there is a hypotension and there is a bradycardia? What treatment you have given?
Ma'am, I have given injection mephentamine.
Okay.
And
okay. And which pot? Who has injected the your study drugs? From the ports, all the ports, from all the ports you have injected the drug, or typically on the specifically on this cholecystectomy bedside you have injected the drug. 60 ml is how you have divided this 60 ml of drug?
ma'am, hello.
Yes.
Ma'am, I've given 30 ml pre-operatively during creation of pneumoperitoneum. Then I've given 8 ml at gallbladder base, and then 8 ml at port site, and 14 ml intraperitoneally at site of creation of pneumoperitoneum, and rest 30 ml I've given at the end on the same site.
Okay. Okay. Good. Prabha madam, if you want to ask, you can ask.
Yeah, I wanted to know what the recovery score was. It significant between the two groups?
Ma'am, the difference in VAS, visual analgesic score, and in the analgesic consumption of rescue drug used between two groups was significant for 6 hours.
And the sedation? Was there any significant difference in the sedation?
Ma'am, not that significant.
Okay.
Have you monitored sedation score in your study?
Ma'am, there was only VAS and VRS score I have monitored.
Okay. Okay.
Can we start next presentation, ma'am, as time is up?
Yeah.
Okay. Sure.
So,
Thank you.
Thank you, Niharika. Second presenter is Nikhil Sharma.
Hello everyone, my name is Dr. Nikhil Sharma from Saraswati Institute of Medical Science, Hapur. My topic for today is effect of intraperitoneal bupivacaine versus placebo on postoperative pain after laparoscopic cholecystectomy. LAPCHOL is one of the most frequently performed elective day care surgeries. Although pain after LAPCHOL is less common, the main reason for pain is stretching of the abdominal wall during the pneumoperitoneum and the release of inflammatory mediators, local dissection, and irritation of the peritoneum produced by blood, bile spillage, or CO2 used for pneumoperitoneum. Although a number of studies has been done after installation of intraperitoneal local anesthetic, some have shown reduction in the post-op pain, while some have shown no benefit. The aim of our study was to evaluate the benefit of intraperitoneal irrigation of local anesthetic, bupivacaine versus placebo on post-op pain after LAPCHOL. After ethical committee approval of the university and written informed consent, a double-blinded randomized prospective clinical study was done at our institute in patients undergoing LAPCHOL under GA. The study duration was of 2 years and 50 cases were included, 25 in each group. Group P, placebo, received 35 ml of 0.9% normal saline in the gallbladder bed, and Group B received 35 ml of 0.25% bupivacaine in the gallbladder bed. All patients underwent thorough medical evaluation and investigation. Intraoperative monitoring were used in all the patients. All patients received standard pre-medication and general endotracheal anesthesia were used. All surgical procedures were performed by an experienced surgeon. Standard 10 mm trocar umbilical port and epigastric ports were used. Intraperitoneal pressure was maintained at 10 mm Hg using a flow rate of 3 liters per minute. After removal of the gallbladder and hemostasis, the surgeon instilled 20 ml of the test drug in the subdiaphragmatic suprahepatic surface of liver and 5 ml in the gallbladder fossa. The patient was maintained in the right lateral Trendelenburg position for 10 to 15 minutes. Further 10 ml was used for port side infiltration. Pain scores were recorded immediately on arrival in the post-anesthesia care unit at 0, 5, 10, and 24 hours after surgery using visual analog scale. For breakthrough pain, injection PCM was used as first-line drug, and injection tramadol and injection diclofenac were used as the second line of drug for rescue analgesia. Results show that time taken for first analgesic requirement is longer in Group B when compared to Group P, that is placebo group. Discussion: many clinical trials have been carried out to assess analgesic effects of local anesthetic in the intraperitoneally installation in the gallbladder bed and right subdiaphragmatic space. The rationale for this route is that peritoneum is exposed to block the visceral nociceptive conduction from the area of an additional mechanism of analgesia. et al., Donsky, AM et al., whose result has been comparable with our study. The bupivacaine group has stable hemodynamics, and this can be attributed to the better analgesia provided by the local anesthetics over the normal saline. No adverse effects like systemic or local toxicity has been observed in any of the patients in our study. This shows that intraperitoneal instillation of bupivacaine in the volume and dose used in our study is not associated with any adverse effects. Limitation of our study is that the sample size is small and therefore the power of the study is less. A large sample size will establish further conclusive evidence. Conclusion: irrigation of the local anesthetic 25% bupivacaine at the gallbladder bed can be an effective method for decreasing post-op pain in the first 5 hours after laparoscopy. This technique of providing post-op analgesia is simple, effective, and will help in improving the post-op recovery profile of the patient and help in making it a truly outpatient-based surgery. Thank you. Hello.
Yeah.
Yes.
Mamta ma'am, your questions, please.
Nikhil, how you randomization?
Ma'am?
Randomization.
Ma'am, randomize the patient. Ma'am, we have we have made a slip and we have taken only those patients who are fit in our inclusion criteria. And we have taken 50 patients and we have made a slip and uske hisab se ma'am done the randomization.
Okay. See, in one group you have used only placebo. You are not giving any drug, any local anesthetic
Yes,
agent.
ma'am.
And
Yes,
in
ma'am.
another group you have used local. So
Yes.
which analgesics, even systemic analgesics, have you given to
Ma'am,
all the patients?
intraoperatively you are asking or after that?
Operatively or
Yes,
even
ma'am.
as a pre-medication?
Yes, ma'am. Ma'am, pre-medication, during the pre-medication, we have used butorphanol, 1 mg. Yes, ma'am. And ma'am, we have used 75 mg of diclofenac sodium.
In all the patients, in
Yes,
both
ma'am.
the groups?
Standard. Yes, ma'am. This was standard.
Okay. What was your result?
Ma'am, after the surgery, it was seen that those patients who have received intraperitoneally bupivacaine, they have asked for the rescue analgesia much later than those patients who have not received the drug.
But what should be the duration? Can you tell me the exact duration ki after this much time in placebo group?
Yes, ma'am.
You
Ma'am, in
require
placebo group, after 1 to 2 hours, they have started asking for the rescue analgesia. But in our group, bupivacaine, they have asked for the first 5 hours, they have not asked for rescue analgesia. So, ma'am, this was noted.
Ideally, you should use some drug, another drug or another local anesthetic. I think ideally, because those patients who are posted, you have included in placebo group, they don't have other analysis.
Yes, ma'am.
Is that different? No doubt, it's a subjective phenomenon, but still.
Ma'am, in our study, yes, ma'am. My aim was just to see intraperitoneally it is effective or not. That's why I have not given.
Want to see only that interpret.
Yes, ma'am. Yes, ma'am.
Do you know any other methods of analgesia in left cholecystectomy?
Yes, ma'am. Type block, ma'am, we can give transverse abdominal plain block. Ma'am, port side infiltration we can give.
Okay. Okay.
Yes, ma'am.
Thank you.
I also feel the group with placebo did not have sufficient immediate post-operative pain relief.
Yes, ma'am.
So that could be.
That is the aim of our study to see that if it is effective or not, intraperitoneal irrigation. So that's why we have not given any other drug in the placebo patient.
Okay.
Okay. Thank you, Nikhil.
Thank you,
Now
ma'am.
our next presenter is Nikhil Chandra.
Hello, my name is Dr. Nikhil Chandra. I am from Prathama Institute of Medical Sciences. Today we are going to discuss priming at the prime time. Rapid sequence induction using succinyl choline is an established technique, but succinyl choline has been associated with many undesirable side effects. So we are looking for other alternatives using non-depolarizing muscle relaxants with timing principle or priming technique. In priming technique, priming dose of 10% of inhibiting dose has been given, and this produces a rapid onset of neuromuscular blockade. Rocuronium bromide has faster onset time compared with other non-depolarizing muscle relaxant, and hence has been chosen to alternate the succinyl choline. The aim of this study is to evaluate the efficacy of priming principle using rocuronium for rapid sequence intubation and objectives to evaluate the efficacy of rocuronium with different priming interval on the time of intubation, to evaluate the intubating condition when rocuronium with priming principle is used. This is the priming principle is to cut short the time to produce optimum condition for intubation with non-depolarizing agents. It also decreases the clinical duration of initial dose. It also decreases the frequency and severity of dose-related side effects, and it also alerts the clinician of any undesirable sensitivity to the non-depolarizing relaxants. In methodology, we have obtained approval from Institute Ethics Committee of Prathama Institute of Medical Sciences, and 45 patients were studied with randomized double-blind study. The patients coming from emergencies and abdominal and peripheral limb surgeries were chosen from June 2020 to January 2021. Inclusion criteria: age between 20 to 50 years, both males and females, ASA physical status 1 and 2, weight between 50 and 100 kgs. Exclusion criteria: patient refusal, pregnant females, patients with severe hepatic renal metabolic disorders, and those with anticipated difficult airway, and any drug usage which interfere with the neuromuscular blockades. Here we have randomized the group into randomized the patients into three groups: Group A, Group B, and Group C. Group A received a priming dosage of 0.06 mg per kg of rocuronium, followed by 0.54 mg per kg rocuronium after 3 minutes. In Group B, 0.06 mg per kg followed by 0.54 mg per kg rocuronium after 2 minutes. In Group C, a placebo was given, and the intubating dosage of 0.6 mg per kg of rocuronium was given after 3 minutes. Intubating conditions were graded as excellent, good, and poor based on Cooper scoring system. That was based on jaw relaxation, vocal cords, and response to intubation. The results: excellent intubation conditions in priming group with 3 minutes priming interval were achieved at around 1 minute past intubating dose, and around 1.5 minutes in priming group with 2 minutes priming interval, and around 2 minutes in non-priming group. Here we can see in Group A, the intubation was done around after 60 seconds past the intubating dosage, and in Group B around 90 seconds, and in Group C around 120 seconds. Conclusion: priming with 10% of the standard intubating dose 0.6 mg per kg of rocuronium and priming interval of 3 minutes produces intubation time and intubating conditions similar to succinylcholine. Thus, rocuronium can serve as an alternative for succinylcholine. These are my references, and thank you so much.
Questions, ma'am?
Prabha madam, you can ask first if you want.
No problem. The included range of weight is up from 50 to 100 kgs.
Yes.
So,
Yes, ma'am.
yeah. So the intubating conditions from the extremes of group will be different. So how was the ease of intubation in those extremes?
Ma'am, actually in exclusion criteria, we have also added anticipated difficult intubation patients will be excluded from the group study. So around 50 to 100 pages the patients have been taken, but most average was around 50 to 80. But there were around 3 or 4 patients who were Mallampati grade 1, and not difficult anticipation was not expected in those cases. So those cases, only 2 or 3 cases were taken under 100 kgs below weight, around 100 kgs.
So the average weight was between 50 and 80.
Most of the cases, yes, ma'am. Nearly more than 80% of the patients were 50 to 80. Only approximately 20% were above 80 kgs.
Okay, okay.
In the exclusion criteria, we have also added clear refusal for difficult anticipated intubation, so that if such a rapid sequence cannot be induced, it will be difficult for the patient. So under ethical guidelines, we have chosen only Mallampati grade 1 and grade 2 patients.
Shall we move to next presenter? So she is Nikita Agarwal. Nikita?
Acromio-axillo-suprasternal notch index in predicting difficult airway in patients undergoing cardiac surgery. Difficulty in airway management is a major cause of morbidity and mortality in anesthetic practice. 85% of all mistakes during airway management result in permanent cerebral damage, and up to 30% of all anesthetic deaths can be attributed to management of difficult airways. But there is a very limited and conflicting evidence of cardiac surgery as a risk factor for difficult intubation. There is a physiological difficult airway present in all compromised cardiac surgical patients in view of hypotension or expected hemodynamic disturbances during induction and post-induction. If unanticipated difficult airway is present, then all these complications are multifolded. The primary aim of the study is to compare between acromio-axillo-suprasternal notch index, modified Mallampati grading, ratio of height to thyromental distance, ratio of neck circumference to thyromental distance, and upper lip bite test for prediction of difficult laryngoscopy in cardiac surgical patients. It is a prospective observational double-blind study conducted in NIMS Hyderabad after ethics committee approval. The inclusion criteria is age between 18 to 60 years, age of physical status 1, 2, and 3, and patients undergoing elective cardiac surgeries under general anesthesia. The patients who did not give consent, patients with ASA grade 4, patients who underwent emergency surgery, and with known difficult airway are excluded. RC. RC is measured with patients lying in supine position. Using a ruler, a vertical line is drawn from the top of the acromion process to the superior border of axilla at the pectoralis major muscle, which is line A. A second line is drawn perpendicular to line A from suprasternal notch. This is line B. The portion of line A that lay above the point at which line B intersects line A is known as line C. RC is calculated by dividing the length of the line C by that of the line A. During the preoperative visit, patient's height, weight, body mass index, upper lip bite test, modified Mallampati grading, and other airway parameters including RC were noted. During intubation, CLG grade was noted. The intubation difficulty score was calculated by noting the number of attempts, number of persons.
You have to accept that video.
Video is stopped.
Yeah.
Yes.
Sorry for internet connection lost. We play again video.
Are excluded. RC. RC is measured with patients lying in supine position. Using a ruler, a vertical line is drawn from the top of the acromion process to the superior border of axilla at the pectoralis major muscle, which is line A. A second line is drawn perpendicular to line A from suprasternal notch. This is line B. The portion of line A that lay above the point at which line B intersects line.
Hello, please share these slides. Yeah.
In supine position. Using a ruler, a vertical line is drawn from the top of the acromion process to the superior border of axilla at the pectoralis major muscle, which is line A. A second line is drawn perpendicular to line A from suprasternal notch. This is line B. The portion of line A that lay above the point at which line B intersects line A is known as line C. RC is calculated by dividing the length of the line C by that of the line A. During the preoperative visit, patient's height, weight, body mass index, upper lip bite test, modified Mallampati grading, and other airway parameters including RC were noted. During intubation, CLG grade was noted. The intubation difficulty score was calculated by noting the number of attempts, number of persons, type of laryngoscopy done, use of external pressure, and use of wound. Total 219 patients were recruited for the study. All the data was collected, tabulated in MS Excel data sheet. Elective cardiac surgeries under general anesthesia. The patients who did not give consent, patients with ASA grade 4, patients who underwent emergency surgery, and with non-difficult airway are excluded. RC. RC is measured with patients lying in supine position. Using a ruler, a vertical line is drawn from the top of the acromion process to the superior border of axilla at the pectoralis major muscle, which is line A. The second line is drawn perpendicular to line A from suprasternal notch. This is line B. Location of line A that lay above the point at which line B intersects line A is known as line C. RC is calculated by dividing the length of the line C by that of the line A. During the preoperative visit, patient's height, weight, body mass index, upper lip bite test, modified Mallampati grading, and other airway parameters, including RC, were noted. During intubation, CLG grade was noted. The intubation difficulty score was calculated by noting the number of attempts, number of persons, type of laryngoscopy done, use of external pressure, and use of wound. Total 219 patients were recruited for the study. All the data was collected, tabulated in MS Excel data sheet. The data was analyzed and following observations were made. CLG 1 and 2 are taken as easy laryngoscopy. CLG 3 and 4 are taken as difficult laryngoscopy. Intubation difficulty score with score less than 5 is taken as easy intubation. With score more than 5 is taken as difficult intubation. Results. The statistical differences between easy laryngoscopy and intubation and difficult laryngoscopy and intubation in respect to different airway parameters were tabulated. The RC showed the least p-value in both, that is 0.001. Sensitivity, predictive value, and accuracy of all the airway parameters to predict the incidence of difficult visualization of larynx according to CLG classification was tabulated. Here the RC shows the highest accuracy, that is 80.05. In our study, the RC has the highest specificity, sensitivity, predictive value, and highest accuracy of 80% compared to all other tests. RC has a good AUC of 0.712 in comparison to other predictive tests in predicting difficult visualization of larynx and subsequent intubation. Limitations of the study are, it has low sample size, it is a single-center study, the grading of laryngeal view was performed by different anesthesiologists. To conclude, RC is a simple bedside tool which can be utilized along with other airway parameters to increase efficiency of detecting difficult airway in preoperative period. RC also could be tested in patients who can't sit. These are the references. Thank you.
Hello. My questions to Nikita. How you have done double blinding in your study?
Ma'am, the person who was doing scopy and intubation was not known about this course, and also the patient.
Okay. So who has done this airway examination?
Airway examination was done by me, ma'am. But during the surgery, the intubation and all was done by our juniors, ma'am.
Acha. So no single person has not done intubation. Very different person has done intubation.
Yes, ma'am.
Okay.
That's the limitation on your study. The expertise should be same or similar.
Yes. Are they second year resident, third year resident, or first year residents, or they are first, second, third year residents in the group?
Ma'am, actually, first attempt will be given to second year resident, ma'am. If first attempt is failed, then I'll be watching for central lines, and also faculty will take over.
Okay. And when you have excluded your patients, when you cannot do intubation, is there any criteria? After 2 attempts or after 3 attempts, you have excluded?
3 attempts, ma'am.
After 3 attempts.
Yes.
What you have done? Is there any case, any incidence of failure of intubation?
No, ma'am, no such intubation. Like we have also used video laryngoscopy. So if after 3 attempts if we could not do intubation with normal laryngoscopy, we used video laryngoscopy.
Okay.
That is also in only 3 patients, ma'am.
Okay, thank you. So it's a changeover from intubation to video laryngoscopic intubation.
Yes.
Yes. Okay. Thank you. Madam Prabha, madam, we
can carry on.
Okay. Thank you, Nikita.
Thank
Our
you,
next presenter today is Dr. Nilesh Vania.
Good morning, sir. Myself, Dr. Nilesh Wani, second year anesthetic resident, Dr. Vijay Medical College. Here I am presenting a paper of video laryngoscopy in adult airway management comparison with the Macintosh laryngoscopy. Introduction. Airway management and endotracheal intubation are the fundamental skill for the safe conduct of anesthesia. Endotracheal intubation considered to be gold standard in securing the airway, which is commonly performed using the direct laryngoscopy. Difficulty in performing conventional direct laryngoscopy arises due to its angle of refraction, approximately 10 to 15 degrees, giving the limited vision. Without adequate visualization, intubation remains unsafe and associated with the risk of anesthesia-related morbidity, mortality, and risk of airway trauma. So to overcome this, we developed a new device, video laryngoscope. Aims and objective is to compare the effectiveness of video laryngoscope against the Macintosh laryngoscope for insertion of endotracheal intubation by comparison of first attempt suction, laryngeal view, time taken to intubate, hemodynamic changes, and airway-related complication. This is the prospective randomized control study conducted over the 120 adult age 1 and 2 grade of either sex posted for elective surgery using general anesthesia. After approval by institutional ethical committee, patient with Mallampati grade 1 and 2 incisor distance greater than 2 fingers on pre-anesthetic assessment were included in the study. After taking the informed consent, patient divided randomly by seal envelope technique into two groups each of 60. First group using the video laryngoscope and group B used the conventional laryngoscope. Exclusion criteria: patient younger than 18 years, mouth open less than 1.5 finger, upper respiratory tract infection, morbid obesity, pathology of neck, upper airway or alimentary tract. All the patients were kept fast overnight. On arrival to operation theater, standard monitor were applied and pre-op vital were recorded. Patient induced with pre-medication injection glycopyrrolate 0.004 milligram per kilogram with injection fentanyl 2 microgram per kilogram, followed by pre-oxygenate with 100% FiO2 for 3 minutes. Patient induced with injection thiopental sodium 7 milligram per kilogram with injection succinylcholine 2 milligram per kilogram, followed by mask ventilation and laryngoscopy done, and airway was secured by endotracheal tube. Following parameters were recorded: number of attempts, laryngeal view, time taken to intubate, heart rate and BP changes, airway related complication. All the data were entered into SPSS version 20 and carrying out significant p-value. P-value less than 0.05 is considered to be statistically significant. The number of attempts was success higher in group A, which was 95%. And CL grade view 1 in 85% in with group A, 61 to 67% group B. Time taken to intubate was longer in group A compared to group B. Heart rate and BP changes were higher changes in group B. And discussion in group A, first attempt success was significantly higher, 95% compared to group B, which was 80%, because in videoscopy extend vision beyond the distal end of blade and doesn't require the oropharyngeal tracheal tube alignment. Group A achieved the better CL view compared to group B. This is because of optical system in true view laryngoscope. Time to intubate was significantly longer in group B, group A compared to group B. This is because true view scope required a group practice and tube advanced blindly till entering the visual field. After intubation, significant hemodynamic alteration changes in group B compared to group A. This is because of supraglottic airway stretching, and incidence of post-op complication were higher in group B compared to group A. This is due to force applied to posterior. Main limitation is the study is not blind due to the unpierceability of blinding anesthetics using the scope. We conclude that the TrueView PCD video laryngoscope possesses more advantage over the Macintosh laryngoscopy and is considered effective in promising device for routine use in intubation process. Thank you, sir.
Hello. Ma'am, unmute. Ma'am, please unmute. Mamta, ma'am.
Okay, sorry. Nilesh?
Yes,
good evening. Is it channel laryngoscope, video laryngoscope, or non-channel?
Ma'am, it's a channel laryngoscope.
Channel.
Yes,
And which size of tube you have used for intubations?
Ma'am, in female we use 7.5 and in male, ma'am, 8. Yes,
Okay. Okay. Prabha madam, you can ask.
Yeah. Anyway, your findings are in accordance with what we generally believe between video laryngoscope and
yes, ma'am.
laryngoscope. Yeah, but was the person who was intubating the same for all cases?
Yes, ma'am. I myself intubated and recording was done by my colleagues, ma'am.
Okay.
Yes, ma'am.
So that at least cancels the personal variations.
Yes, ma'am. So it's nullify the.
So you feel a video laryngoscope is easier
Yes.
to.
Yes, ma'am. It is easier to intubate, but it's take more time compared to direct laryngoscopy.
That is the general consensus.
Issue, yes, ma'am.
Yes.
Yeah. Okay.
Yes. Otherwise, view and everything is good, ma'am.
Okay.
Any failed intubation have you observed with video laryngoscope? True view?
No, ma'am. Everyone is successful. Yes, ma'am.
All in both the groups?
Yes, ma'am. Both the groups.
Okay. Okay.
Yes, ma'am.
Thank you, Nilesh. Our next presenter is Nirav Sarja.
My topic is comparative study of magnesium sulfate and lignocaine-based gargle in prevention of post-operative sore throat following general anesthesia with endotracheal intubation.
Screen is not seen.
Introduction. Most common.
Yeah. Okay.
My topic is comparative study of magnesium sulfate and lignocaine-based gargle in prevention of post-operative sore throat following general anesthesia with endotracheal intubation.
Still, we are not able to see the screen.
Introduction. Most common adverse effect is following endotracheal intubation in general anesthesia. Various non-pharmacological and pharmacological.
Okay. Magnesium sulfate.
Introduction. Most common adverse effect, it is following endotracheal intubation in general anesthesia. Various non-pharmacological and pharmacological methods are used in our study. We used magnesium sulfate gargle and lignocaine-based gargle for reducing post-operative sore throat. Magnesium sulfate NMDA antagonist act both on central and peripheral nervous system. It has both anti-nociceptive and anti-inflammatory property, which help in reducing post. Aims and objective of the study is a comparison of efficacy of MGS over gargle with lignocaine-based gargle pre-operatively for attenuation and severity of post after using low pressure, high volume cough endotracheal tube in surgical patient. To evaluate post is the main aim of the study. Material method, we take 48 patients in a prospective randomized study and divided into two groups with 24 patients in this group. This is inclusion criteria, exclusion criteria, prior to preparative evaluation. In group A, patient receive MGS of 20 milligram per kg dissolved in 20 ml of 5% dextrose solution. In group L, patient receive 20 ml of 2% lignocaine viscous solution. According to group, patient were asked to gargle for 30 seconds, 15 minutes before induction of anesthesia. The gargling solution were given in no after we induce the patient and after OT extubation done, and post was graded on a 4-point scale, 0 to 3. 0 means no sore throat. 1 mild sore throat, complaint of sore throat only on asking. 2 means moderate sore throat, complaint of sore throat on his or her own. And 3rd, severe sore throat, changes of the voice or hoarseness associated with throat pain. Observation and research. There was reduced incidence and severity of post-operative sore throat in patients who were given MGS over gargle pre-operatively. Patient's age, weight, and duration of the surgery were not found statistically significant in between two groups. The incidence of the post in group M recorded lower than group L. Then severity, while comparing a higher incidence of the grade 2 means moderate sore throat was in group L as compared to group M. In group L, there were 10 patients, and group M, there were 3 patients. Now, severity of the post was lower in group M as compared to group L at 0.12, 4, 8, and 12. There were significant with p-value less than 0.05. At 24 hours, even though 2 patients of group L has post as compared to group M, 1 patient had post, but they are not significant, which had p-value 0.55. In our study, significant attenuation of the post was observed at 4 hours in group M compared to group L, p-value 0.005. Post-operative sore throat, even a minor complication, its incidence is very high after netrocal intubation in general anesthesia. Various non-pharmacological and pharmacological methods have been studied. MGSO4 has a nociceptive effect that are primarily based on inhibition of the calcium entry into the cell and block NMDA type of glutamate receptor. Also provide the anti-inflammatory and anti-nociceptive property of the MGSO4 after topical application. Lignocaine, the most common agent used in preventing post in severe way, such as daily topical application, intravenous, well, stress. The study also done in our study, MGSO4 conclusion. In this post-practice randomized study, MGSO4 gargle has lesser incidence and severity of the post when compared to lignocaine versus gargle. So we suggest the use of the MGSO4 gargle before induction of general anesthesia using endotracheal intubation as an effective measure to decrease the incidence of severity post. Thank you.
Hello.
Good evening, ma'am. Am I audible?
Yeah.
Yes.
Yes.
Hello.
Good evening. Yeah, ma'am.
Okay. Regarding this study, the nature of the both liquids, one was viscous and the other one was
MGSO4, ma'am, liquid.
The viscosity is not same with both.
Yeah, but in MGS lignocaine viscous, we dilute it, and there is no significance between both of two. According to natural of property of these two drugs.
And the laryngoscopy duration was comparable?
Yeah, ma'am. Actually, in my study, I duration are comparable, and based of the study duration, around around 2 hour study we can take. So there is no statistical significance in both groups. Laryngoscopy was done by me, and after post-operatively, I at 1, 2, 4, 8, and 24 hours asking the patient and taking the history about post-operative sore throat is occurs or not.
Okay. Durations of surgery also, because these factors affect the post-operative sore throat.
If duration of surgery long, then post-operative sore throat means no occurring. Yeah, ma'am. So time of surgery also important for this study.
Yes.
Okay.
You have used Maxself gargles. Is it available commercially or you have prepared it?
No, ma'am. Prepared, not available, but prepared it as we present in 25% DNS, and before operation, before 5 minutes, we ask to patient to gargle it.
Okay. Any hemodynamic changes have you observed between these two groups?
No, ma'am. No hemodynamically. In both groups, vitally and hemodynamically stable in both groups. Only observation is that about post-operative sore throat or not. But hemodynamically, both are stable in both groups.
Okay. And recovery from anesthesia, from general anesthesia? Any changes you have find in the recovery from?
Yeah, 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 man. MJSO for gargle, so it affect light much sedation. So patient recovery is a little bit late, but no any significant. A little bit late in MJSO for groups.
Okay, okay, thank you.
Extubation was done deep or after fully awake patient. How was it? What is the extubation criteria?
Yeah,
When you have extubated the patient, any criteria you have followed?
No, no, no.
So we want to know any delayed recovery in MEXEL group. Is there any delayed recovery from anesthesia in patients we have given MEXEL gargles?
Yeah, 2 or 3 patients in a mixed group gargle. Some 10 to 15 minute recovery late in MJS for gargle patient, but otherwise all patient same recovery occurs.
You have used 20 ml of gargles, no?
Yeah.
What was the duration when you have given gargles before induction of anesthesia?
For a 15 second or before 5 for 15 second ask to gargle and before 15 minutes of surgery.
Okay, thank you.
Yeah, thanks.
Thank you, ma'am.
That's it, I guess. Thank you very much, Nilesh. Our next, Neera, our next presentation is by Dr. Nivedita.
I'm Dr. Nivedita from BGS Gems Hospital, Bangalore, talking about my paper on comparison of dexmedetomidine and dexamethasone as adjuvants to local anesthetic and supraclavicular brachial plexus block with these headings. The technique of regional anesthesia has several advantages for upper limb surgeries over general anesthesia for both anesthesia and analgesia. Various drugs have been used as adjuvants to local anesthetics that include opioids, ketamine, dexamethasone, dexmedetomidine, tramadol. Dexamethasone is a long-acting glucocorticoid with anti-inflammatory, anti-emetic, and anti-nociceptive with acting on glucocorticoid receptors, reducing the nociceptive C-fiber activity, whereas dexmedetomidine is a highly selective alpha-2 agonist which has sedative, analgesic, and hemodynamic stabilizing property by blockade of hyperpolarization of activated cation current. My aim is to compare the effectiveness of dexamethasone and dexmedetomidine as adjuvants to bupivacaine in supraclavicular brachial plexus block. It is a prospective randomized double-blind study conducted from November 2020 to October 2021 with standard value of 80% power and 22 in each group. Inclusion criteria being ASA grade 1 and 2 patients aged 18 to 50 years of either sex, weighing 50 to 80 kg, posted for elective upper limb surgery. Exclusion criteria includes patients with pre-existing neurological disorder with hypersensitivity to the drug, inadequate block, and history of coagulopathy. Pre-anesthetic evaluation was done along with explaining about the procedure, and the patients were divided randomly into 2 groups. Standard NPO guidelines were followed and the baseline vitals were recorded. Under aseptic precautions, ultrasound guided supraclavicular brachial plexus was given. That is, Group D was given 20 ml of 0.5% bupivacaine plus 4 mg of dexamethasone. Group X was given 20 ml of 0.5% bupivacaine plus 1 microgram per kg dexmedetomidine. The following parameters were measured. That is, dull sensation to pinprick was noted as onset of sensory block. Motor blockade was noted according to modified Bromley scale. When VAS score is more than 4, rescue analgesic injection PCT 1 gram IV was given. Any side effects like hypotension, bradycardia, nausea, vomiting was recorded and treated accordingly. The p-value of less than 0.05 is considered statistically significant. The demographic values between the both groups were comparable. In our study, the duration of analgesia was longer in Group X than the Group D. In our study, the group X experienced significantly lower VAS score than group D. Mandeep Kaur et al. Conducted a study on the adjuvants and concluded that dexamethasone as adjuvants prolongs the duration of block and postoperative analgesia. Rajesh Meen et al. Conducted a study and concluded that dexamethasone prolonged sensory and motor blockade, mild sedation, and prolonged analgesia. Sunit Katuria et al. Conducted a study on dexamethasone and concluded that it prolongs both sensory and motor onset of the blockade, prolongs the duration of the blockade and analgesia. We concluded that supraclavicular brachial plexus block with dexamethasone as an adjuvant was associated with faster onset of blockade with prolonged sensory and motor blockade and prolonged analgesia as compared to dexamethasone as an adjuvant. Thank you.
Over to you, ma'am, for question and answers.
Yeah, because my video was a little problem, I didn't go through the full. Ma'am, you asked the questions this time.
Okay. Hello.
Hello, ma'am.
Yes, ma'am. Good afternoon. Used for supraclavicular brachial plexus block.
Pardon me, ma'am. Again, ma'am.
Have you used any now stimulator or USG guided or clinical method? Which method?
Ultrasound guided supraclavicular brachial plexus block, ma'am.
All the patients. And who has given this block?
Yes, ma'am. My senior staff who is done fellowship in the same had given the block, ma'am, for all the cases, ma'am.
Okay, okay. And both the study drugs you have used, dexmedetomidine and dexamethasone. Are the dose is equipotent dose, or they are the different?
Ma'am, I didn't take up equipotent dose, ma'am. Just the dose was comparable that I took, ma'am, from the previous studies.
Okay. Yeah, from previous study, it was used like this. 4
Yes, ma'am. Yes, ma'am.
Some studies have used 8 milligram of dexamethasone.
Yes, ma'am. But I took only 4 milligram of dexamethasone and 1 microgram per kg of dexmedetomidine, ma'am.
Okay. Okay. Any incidence of sedation in dexmedetomidine group?
Yes, ma'am. The sedation was more in case of dexmedetomidine group as compared to dexamethasone group, ma'am.
And does your dexamethasone group require any sedation or light general anesthesia, or they don't require it?
No, ma'am. Dexamethasone, not as such, ma'am. Only few cases required midazolam or fentanyl, ma'am, for sedation.
That you should, because in regional anesthesia, sometimes sedation is required. Though you provide pain relief and excellent block and everything, but sometimes it may require.
Okay. Well, the two groups were not standardized for angiolysis?
Both were standardized, ma'am.
Okay. Then why only some were given sedatives? Was there any demand?
Yes, ma'am. Only in dexamethasone group there was a demand, ma'am, because of the less sedative property as compared to dexmedetomidine, ma'am.
Okay. Okay. Nivedita.
Okay, ma'am. Thank you, ma'am.
Thank you, Nivedita.
Thank you, ma'am.
Next candidate is Dr. Noori. Noori Chandra.
Okay.
Gauri Harichandan. My topic is efficacy of single bolus epidural injection of 0.2% ropivacaine and morphine versus intrathecal 0.2% ropivacaine and morphine in patients undergoing laparotomy, a comparative study. Modern day anesthesia is concerned with perioperative pain management. Opioid analgesics produce analgesia by interacting with opioid receptors and CNS. Various modalities like epidural and intrathecal opioids are accepted technique. Morphine is a prototype opioid analgesic and exerts its action primarily through agonist activity at mu receptors. Ropivacaine is less cardiotoxic local anesthetic, more selective for sensory fibers, thus producing less motor blockade, which allows early ambulation and recovery to the patient in post-operative period. Primary objective of my study is to determine the time to first rescue analgesia, to determine the hemodynamic response, to assess pain intensity by visual analog scale, and secondary objective is to determine any adverse effects. Study design was a prospective randomized and double-blinded experimental study which was conducted after institutional ethical committee clearance at IMS some hospital Bhubaneswar for a period of 1 year. Patients were explained about the procedure in detail and informed written consent was obtained. Sample size was 60 patients divided into 30 patients in each group, Group E and Group I. Sampling was done by randomization by computer generated numbers and CTR registration was done. Inclusion and exclusion criteria. Group E patients were given epidural single bolus of 0.2% ropivacaine 8 ml and 2 mg morphine, whereas Group I were given 4 ml of 0.2% ropivacaine with 150 mics morphine intrathecal. After administering either spinal or epidural anesthesia, patients were induced. General anesthesia was given as per the protocol. After the surgery, patients were extubated and were transferred to post-anesthetic care unit. Patients were assessed by visual analog scale for pain. Injection tramadol 100 mg IV was given as a rescue analgesia. Nausea vomiting treated with injection ondansetron. Pruritus treated with injection dexamethasone 4 mg IV. Hypotension treated with IV fluids. Parameters observed are heart rate and mean arterial pressure at baseline and every 30 minutes till extubation, time to first rescue analgesia, assessment of pain by visual analog scale post-operatively, adverse effect. Age, gender, and ASA physical status did not show any statistical significance. Duration of surgery more or less similar in both the groups. Time to first rescue of analgesia is slightly higher in epidural group compared to intrathecal group. Heart rate and mean arterial pressure variations were analyzed and did not show any statistical significance. VAS score was analyzed every 4 hours for first 24 hours post-surgery and was found to be similar in both the groups with slightly higher VAS score was observed in Group I than Group E at 16 and 20 hours. Adverse effects, no patient had major adverse effects. 16.7 patients in epidural and 13.3% in intrathecal group had rash. In our study, time to first rescue analgesia was longer in epidural group compared to intrathecal group, which analyzed statistically significant. A similar study by C. Duell in cesarean section and Leslie et al. In liver resection showed a similar result. VAS score at 16 and 20 hours were slightly higher in Group I compared to Group E. A similar result was observed by C. Duell et al. No patient had major adverse effect. Similar results with side effects of morphine were found by meta-analysis conducted by Gehling et al. Urinary retention was not assessed as urinary catheter was placed. No patient had respiratory depression. Epidural bolus of 0.2% ropivacaine with 2 mg morphine prolongs the duration of analgesia with significant decrease in pain intensity than intrathecal 0.2% ropivacaine with 150 mics morphine without any significant difference in hemodynamic response, intraoperative analgesic requirement, and adverse effects. References. Thank you. Good afternoon, ma'am.
Good afternoon. You have compared effects in epidural versus intrathecal.
Yes, ma'am.
So see, intrathecal success rate is very high, but in epidural, what is the method you have used for epidural anesthesia?
Ma'am, to achieve epidural space, loss of resistance technique was used, ma'am.
Okay. Is there any failure in epidural anesthesia? Or
ma'am, in all the 30 patients of my patients in epidural group, there was no failure, ma'am. However, one patient, when we had found difficult to put a epidural needle, then we have changed it to a spinal group, ma'am.
So changeover, you have done changeover from epidural to intrathecal.
In one patient because of the anatomical difficulty, ma'am.
Okay, and you find that epidural analgesia is prolonged than intrathecal analgesia?
Ma'am, my study showed more or less both are similar with slightly more increase in time for first rescue analgesia in epidural group, ma'am.
And can you tell me what is the results in your reference study, the main reference study?
They also had an almost similar result, ma'am. I have seen two of my reference studies. One study was in liver resection surgeries, ma'am, and the other in lower LSCS, ma'am.
Okay.
And I have taken in laparotomies, ma'am.
Okay.
And your post failure of epidural, you said, how did you assess that? Because you induced GA after instituting
No,
the
ma'am, either spinal or epidural, whatever we are given, we are given it before inducing GA, general anesthesia, ma'am. That one patient, because we couldn't, patient was not so cooperative for repeated multiple attempts of epidural. We have attempted for the changeover.
What you mean by failure is a difficulty or failure in establishing the block,
Yes,
not in the quality of analgesia.
Quality, I did not find anything in our study, ma'am.
Okay.
Thank you.
Okay. Thank you.
Our next candidate is Dr. Nofia.
A warm welcome, everyone. I am Dr. Nofia SS, and the title of my paper is
Video not there.
Welcome, everyone. I am Dr. Nofia SS, and the title of my paper is Evaluation of ultrasound-guided measurement of tongue thickness in predicting deviation in surgery. A warm welcome, everyone. I am Dr. Nofia SS, and the title of my paper is Evaluation of ultrasound-guided measurement of tongue thickness in predicting difficult tracheal intubation in adult patients undergoing elective surgery. Adequate preoperative airway assessment is necessary for safe strategy for airway management, but the existing indices show low sensitivity and predictive value. A large tongue is a non-predictor of difficult airway, and USG can be used to measure tongue thickness accurately. But very few studies are done in this topic, hence we took this topic for study. Aim of our study was to evaluate ultrasound-guided measurement of tongue thickness in predicting difficult tracheal intubation in adult patients undergoing elective surgery. Our primary objective was to determine if USG-guided measurement of tongue thickness can be used to predict difficult intubation. And secondary objective was to assess whether this measurement can be used to predict laryngoscopy in adult patients, and also to find the correlation between MMP class and tongue thickness. The study was conducted at Department of Anesthesiology, ABMS, and Dr. Araman Hospital, New Delhi. A cross-section observational study was done on 61 patients after obtaining ethical clearance. Adult patients of either gender with ASA 1, 2, or 3 and posted for elective surgery under GA requiring ET intubation, intratracheal intubation was included for the study, and patient with trauma, tumor, or deformity of upper airway and difficult mouth opening were excluded from the study. 61 patients after obtaining written informed consent underwent pre-anesthetic airway assessment and USG measurement of tongue thickness with patient in supine with neck fully extended and probe under chin in median sagittal plane was measured with maximal vertical dimension from tongue surface to submental skin. In OT, CL grade 3 or 4 was taken as difficult laryngoscopy, and those requiring more than 3 attempts or more than 10 minutes or use of adjunct or alternate device was taken as difficult intubation. The results showed an age range of 90 to 65 and gender with females more than 70%, and BMI mean value was 23.88 in our study. We had 4 cases of difficult intubation at a cutoff value of more than 6 centimeter tongue thickness. ROC curve showed an area under the curve of 0.879, and it could predict difficult intubation with 75% sensitivity and 94% specificity. We had 6 cases of difficult laryngoscopy, and at a cutoff value of more than 5.8 centimeter, the area under the curve was 0.868, and they could predict difficult laryngoscopy with sensitivity 83% and specificity 81%. Our results showed there is no correlation between tongue thickness and MMP classification. The cutoff value for tongue thickness to predict difficult intubation in our study was 6 centimeter, and the similar results were found by W.E.M. and Binwang in 2017 and Rishabh Agarwal et al. In 2021. The cutoff value of tongue thickness for difficult laryngoscopy prediction was 5.8 centimeter in our study. Nabin K. Yadav et al. In 2019 had got a median value of 6.1 centimeter, and Yao and Binwang got a tongue thickness more than 6 centimeter for predicting typical laryngoscopy. Contradictory findings were found in Srikhar Adhikari et al. Study in 2011, maybe because of the different methodology they followed. Our study could not find any statistically significant relationship between tongue thickness and MMP grade, and similar results were found by Yao and Binwang. The strengths in our study was single sonographic measurement were used and had an easy learning curve and does not require any mandatory involvement of the patient. and had an excellent predictive value. The limitation were small sample size, lesser difficult airway cases, and it was conducted in a single hospital and is not based on anthropometric values. So our conclusion was ultrasound guided measurement of tongue thickness more than 6 cm can be used to predict difficult tracheal intubation, and more than 5.8 cm can be used to predict difficult laryngoscopy in adult patients, and there is no correlation between tongue thickness and Mallampati classification. Thank you.
Am I audible, ma'am?
Yes.
Yes, you are audible. Can we start with question answers?
Yes.
Prabha ma'am, yes.
Hello.
Hello.
Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay. The type of laryngoscope used was same in all patients?
Yes, ma'am. Macintosh we
Same
used
person?
Yes, ma'am.
And you said there was no significant correlation between Mallampati and tongue thickness.
Yes, ma'am.
Yeah. What does that infer now?
Like, ma'am, actually, Mallampati grade is also used for it is an indirect measurement of tongue volume, like tongue in relation to oral airway, but it was not at all like predicting difficult airway as compared to this tongue thickness, ma'am. Ultrasound guided tongue thickness.
So
And that
Mallampati is
values were
also a
also
visual observation of continue.
And that values were also like those patients which had Mallampati grade of 3, they had EEC laryngoscopy also, ma'am, and their tongue thickness were also lesser.
No, that's what I want to tell is, if there is a thick tongue, the increase as the tongue becomes thicker, even the Mallampati is affected, our scoring of Mallampati, because visualization becomes difficult with a thicker tongue. That's what, isn't it? So I was thinking they will be correlated, but here you say there is no correlation.
Ma'am, in other studies also that was not getting correlated. Like we also couldn't find any correlation because we had patients with Mallampati grade of 3, but their tongue thickness were less, and that was EC laryngoscopy also.
But in case of if tongues is thick tongue is you have observed, and is there is a what was the Mallampati score in that patient?
Actually, we didn't assess that.
Between,
Ma'am, we had around 23 patients with MMP grade of 3 and no patients with MMP 4. But still, we had EC laryngoscopy, and CL grade 1 we got with MMP 3, ma'am.
Okay. And how you have measured the tongue thickness on USG?
Ma'am, patient was kept on supine with neck fully extended, and the probe was kept on the median sagittal plane below the chin, and we will find the tongue with like it's pure, it's fully, and the maximum height will measure from the skin surface and tongue surface. Maximum vertical measurement.
It's a vertical measurement.
Yes,
and which probe you have used?
Ma'am, curvilinear problem.
Linear.
Yes.
Okay.
Thank you. Thank you, ma'am.
Thank you, Nufia. Our next presentator will be Dr. Nidhi. Waiting for our next
Good evening, everyone. My topic is effect of dexamethasone gargle and magnesium sulfate gargle on incidence and severity of post-operative sore throat in patients undergoing surgery for under general anesthesia. Post-operative sore throat is a common and a very unpleasant feeling amongst the patients who undergo general anesthesia after orotracheal intubation. Both magnesium sulfate and dexamethasone have been used by various routes like nebulization, intravenous, topical magnesium sulfate, and topical dexamethasone, magnesium sulfate gargles, lozenges, and with variable successes for decreasing both the incidence and severity of POST. While gargling is a simple and unique treatment, it does necessitate patient
Muted.
convenience.
हाँ मैम मेरी बात हो गई सबसे बात हो गई and
Dr. Nidhi is not audible.
Yeah.
Sample size was taken as 60. Following approval from the Board of Research Committee and registering to Clinical Trials of India, a total of 60 patients were randomly taken and they were divided into two groups using a computer-generated random list. Group 1 was a dexamethasone gargle group and Group 2 was magnesium sulfate gargle group. Inclusion criteria was ASA grade 1 and 2, age between 18 to 50 years of either gender, and patients undergoing general anesthesia. Patients were asked to gargle with a given mixture for 30 seconds and 15 minutes prior to the induction of general anesthesia. There was no significant demographic changes between the two groups, and the incidence and the severity of the sore throat at different time intervals of the different groups showed that the incidence was much less in magnesium sulfate group at 0 hours, at 2 hours, and at 4 hours. As we can see here, in 0 hour group A, that is the dexamethasone group, the incidence was 97%, and in the magnesium sulfate group, the incidence was 63%. At 2 hours, the incidence was 70% in dexamethasone group, and it was 23% in magnesium sulfate group. Incidence of cough and hoarseness was also much less in the group with magnesium sulfate gargles and was much more in the group with dexamethasone gargles. Both magnesium sulfate and dexamethasone gargles have been used in a variety of ways, including nebulization, intravenous, topical, and topical dexamethasone. Magnesium sulfate gargles and lozenges have been used to reduce the incidence and severity. There was no study that examined the efficacy of gargles of dexamethasone with gargle magnesium sulfate on the occurrence and severity. In all these studies, it was suggested that the reduction was due to anti-inflammatory effects of the administered drugs. In the incidence, the difference between the incidence was statistically significant between the two groups. Though we did not come across any significant side effects of either drug, we have to measure the blood levels of any of the drugs on the larger sample size. This study cannot be extended to include patients who underwent surgery for more than 4 hours or at extremes of age. In our study, we conclude that gargles of 1 gram of magnesium sulfate in 20 ml of 5% dextrose reduces the incidence and severity of post-operative sore throat in patients undergoing surgery under GA more effectively than 8 gram dexamethasone in 20 ml of 5% dextrose. Thank you.
Over to you, ma'am, for question and answers. Ma'am, please unmute yourself.
How you have monitored severity of sore throat? Any criteria or any scoring system you have used? Sore throat scoring system?
Good afternoon, ma'am.
Hello.
Hello, good afternoon, ma'am.
I'm not able to see the video.
Hello.
I'm not able to hear her.
Hello. Ma'am, can you?
Hello.
Yeah.
Audible, ma'am. Audible, ma'am.
Yeah.
Good afternoon, ma'am.
Say loudly, please.
Good afternoon, ma'am.
Good afternoon. Say loudly. Okay.
Sorry,
you are not. We cannot hear. It's okay. Any scoring system you have used for sore throat?
Yes, ma'am. We divided it into in the post-operative care unit, we divided into 4 grades. Grade 1, 2, 3, and 4. Grade 1 was when there was no complaint of sore throat. Grade 2 was
Nidhi,
when
you are not audible. You are not audible.
Audible, ma'am. Say loudly this.
Okay. Ma'am, we divided the grading, the post-operative sore throat in 4 grades. Grade 1 was when there was no complaint of sore throat, and grade 2 was when there was complaint of sore throat upon asking the patient, when the patient said that yes, there is slight pain. And grade 2 was when there was moderate amount of sore throat, and grade 3 is when there was change of voice and hoarseness. That was severe post-operative sore throat. We graded it as that.
And okay. And you mean to say incidence is less in MEC self group
Yes,
than
ma'am.
dexamethasone group?
Yes,
Okay.
ma'am. Yes, ma'am.
No other, any changes in hemodynamic parameters have you observed?
Yes, ma'am. In the dexamethasone group, ma'am, we noticed that the diastolic blood pressure was was lesser, significantly lesser than compared to magnesium sulfate group.
Why?
And
Why so? Any reason?
Ma'am, it was the finding which I noticed in my study, but otherwise it was not. It was demographically similar.
Otherwise similar. Okay.
Any reference was there regarding this finding?
No, ma'am. Ma'am, this was a finding, so I mentioned it in my study.
Okay.
Dexamethasone increased the diastolic blood pressure.
Yes, it. That's why. Thank you, ma'am. Okay. Okay, Nidhi.
Thank you, ma'am. Thank you.
So shall we start another presentation, Dr. Umana?
Okay.
Good morning, one and all. I'm Dr. Umna Makli from Indira Gandhi Government Medical College, a third-year resident, presenting on the topic perioperative challenges during bariatric surgery. Obesity is increasing worldwide, and so does the awareness of the bariatric surgery. Obesity is considered as a major risk factor for cardiovascular diseases, sudden cardiac death, type 2 diabetes mellitus, orthopedic diseases, cancers, and mental disorders. The bariatric surgery has been recommended by the National Institute of Clinical Excellence as a treatment for obesity. The obstructive sleep apnea can be graded based on the apnea-hypopnea index as normal, mild, moderate, and severe. Aims and objectives of my study was to find out various challenges faced in obese patients posted for bariatric surgery. The primary objectives was to find out the prevalence of various comorbidities, the airway challenges, grading of patients as per the BMI, grading of obstructive sleep apnea, and post-operatively, post-operative CPAP therapy, oxygen therapy, and ventilatory support given to each patient for assessed. The methodology which was adopted it was a prospective observational study. The age group was between 21 to 50 years, and both the sexes were included, posted for the bariatric surgery. Comorbidities were identified during the preoperative evaluation, and incentive spirometry was given in pre and post-operative period in all patients, and obstructive sleep apnea was graded based on the polysomnography. The results and observations of my study, the female to male proportion was nearly 71 is to 28%, which was similar to that of the study done by Mendel et al. Distribution of the study population based on the comorbidities were that the obstructive sleep apnea accounted to nearly 75% of the population, and the hypertension nearly 65%, and diabetes was only seen in 4% of individual, while hyperthyroidism was seen in 15%. The distribution of the study population was according to the obesity was done based on the National Institute of Health. It was graded into class 1, class 2, class 3, and super obese, and majority of my patients came in class 2 obesity. The obstructive sleep apnea was graded based on the polysomnography, and majority of the patients were categorized into moderate obstructive sleep apnea, that is nearly 71%, and only 11% had severe obstructive sleep apnea. The study population was classified according to the airway management characteristics as difficulty in mass ventilation, intubation difficulty, and malymphatic scoring. The mass difficulty mass ventilation difficulty was found in nearly 23%. Intubation difficulty was found in nearly 90% of the individuals, and 30% of the individuals. In this, 30% of the individuals were very difficult to intubate, and they were intubated with CMAC video laryngoscope. According to the malymphatic grading, majority of my patients came in grade 3 malymphatic. Postoperatively, some of the patients had to be kept in the ventilatory support. Some who had severe OSA or moderate OSA, the CPAP therapy had to be given, and oxygen therapy also had to be administered. Maximum patient had to undergo oxygen therapy, nearly 48%, and CPAP therapy accounted to nearly 37%, and ventilatory support was seen in 15% of my study population. So, in conclusion, it was concluded that the medical team should be aware of the morphological and pathological conditions associated with obesity. For the preoperative airway assessment, the detailed preoperative airway assessment remains the key to success in airway management, and the skill and experience of the anesthesiologist play a major role in airway management outcomes. Thank you.
Umanna, how many patients you have included in your study total?
Ma'am, the sample size was 16 in my study.
16.
Yes, ma'am.
All patients are obese patients.
Yes, ma'am. More than 80 kilo, and the BMI was more than 35.
More than? BMI more than?
30. The BMI was more than 34.5. One patient would belong to 34.5. All the patients belong to more than 34.5.
Okay, okay. So in case of difficult intubation, what you have done?
Ma'am, initially the CMAC was used as a conventional blade in my study, and McCoy was used as a conventional blade, and if there was a difficulty, the hinge was used, and further difficulty, we had to use the CMAC video laryngoscope.
Okay. In any patient, you have given preoperatively CPAP therapy?
Yes, one day prior to the surgery.
1 day prior to surgery. And have you monitored the saturation, baseline oxygen saturation level and postoperative oxygen saturation level?
Yes, ma'am. Actually, one of my limitations is 1 day prior to the surgery only we had given the CPAP. So the improvement with CPAP therapy prior to the bariatric surgery, we couldn't assess the patients. So 1 day after this bariatric, some of the patients had improvement, but it was a follow-up of nearly 10 days duration, and long-term follow-up wasn't done for my study.
Okay.
How many of your patients were anticipated difficult airways?
Ma'am, nearly 30% of my patients were anticipated difficult airway.
And you chose McCoy to be your regular one, and then depending on difficulty. Why was it not standardized for all the patients? Like your most difficult device that you use, you could have used it for all.
No, ma'am. Like McCoy was initially used, like Macintosh was planned, but without hinge, McCoy was used as the initioscopy. And but in some of the patients who had very difficult intubation and in whom seniors had to take over, in that cases with Bucci and Stillet, we had to intubate with CMAC video laryngoscope.
Knowing they were of high BMI, you could have standardized the use of the scope to the maximum difficulty level, isn't it? It would have avoided the multiple attempts on laryngoscopy. Okay.
Any more questions, ma'am?
No.
Okay. So shall we call Dr. Omar for the presentation?
Yeah.
Good morning all. Myself Dr. Omar PV, third year anesthesia PG student at Manya Institute of Medical Sciences. My topic for today is comparison of block characteristics of butorphanol versus tramadol as an adjuvant to bupivacaine and lignocaine for brachial plexus block among patients.
Yeah, well, tell us.
Please stay with us.
Upper limb surgeries. Good morning all. Myself Dr. Omar PV, third year anesthesia PG student at Manya Institute of Medical Sciences. My topic for today is comparison of block characteristics of butorphanol versus tramadol as an adjuvant to bupivacaine and lignocaine for brachial plexus block among patients undergoing upper limb surgeries. My co-authors are Dr. Shivkumar G. Sir, Professor and HOD, and Dr. Lokesh VC Sir, Assistant Professor. Coming to introduction. Brachial plexus block provides an useful alternative to a general anesthesia in patients undergoing upper limb surgeries by providing near ideal operating conditions like complete muscle relaxations, intraoperative hemodynamic stability, and by producing sympathetic block which reduces postoperative pain and edema. It also leads to early ambulation and reduced hospital stay. Various adjuvants have been used along with local anesthetics for extending pain relief without increasing the local anesthetic dose. Here, the aim is to compare block characteristics of butorphanol versus tramadol as an adjuvant to bupivacaine and lignocaine for brachial plexus block. The study was approved by Institution Ethical Committee. It is a prospective randomized double-blinded study. The sample size was 99. The sample size was calculated using NMaster2 software, which is developed and patented by Department of Biostatistics, CMC, Vellore. 99 patients fulfilling the inclusion and exclusion criteria of our study were subjected to simple randomization method by using computer-generated random numbers, and they were divided into 3 groups of 33 each. Group T or tramadol group. Here the patients received 0.5% of bupivacaine injection 18 cc with 10 cc of 2% lignocaine and injection tramadol 100 mg. Group B or butorphanol group. Here patients received injection 0.5% bupivacaine 18 cc with 10 cc of 2% lignocaine and injection butorphanol 2 mg. Group C or control group. Here patients received only 0.5% bupivacaine and 2% lignocaine. All the patients received peripheral non-stimulated guided supraclavicular brachial plexus block. Onset and duration of sensory block and motor block along with cardiorespiratory variables like heart rate, NIBP, SpO2, respiratory rate were recorded at predetermined time intervals. The sensory block onset time will be defined as the time between injection and complete loss of membrane cessation in C2 and T2 dermatom. Motor block would be assessed by Bromage 3-point score. The time taken to achieve complete motor block will be noted. Duration of sensory block and duration of motor block would also be recorded. Side effects and complications, if any, would also be noted and will be treated as per standard treatment protocols. Duration of analgesia will be taken as the time taken until patient depends on analgesia. The visual analog scale will be observed every half hourly in postoperative period till patient receives rescue analgesia. The collected data was entered using Microsoft Excel software and analyzed using IBM SPSS 17 software. And relevant statistical tests were used. Coming to results, there was no much difference in demographic factor, and all the patients in all 3 groups were comparable. Coming to block characteristics, onset of sensory block was 7.47 minutes in Group D, 8.68 minutes in Group B, and 13.62 minutes in Group C. Duration of analgesia was 356 minutes in Group D, 486 minutes in Group B, 235 minutes in Group C. Discussion. There were no side effects in any patients. All the patients were accounted for and completed the study. Both tramadol and butorphanol reduced the time taken for onset of sensory and motor block and increased the duration of sensory and motor block and analgesia duration significantly. The sensory block onset was much quicker in tramadol group when compared to butorphanol group, 7.47 versus 8.68, and the p-value was less than 0.001. Though motor block onset was also quicker in tramadol group compared to butorphanol group, it was statistically insignificant with p-value of 0.9079. However, the duration of sensory block, duration of motor block, and duration of analgesia was increased in butorphanol group compared to tramadol group, p-value less than 0.001. Our study is comparable to the study conducted by Regni et al. In the year 2000. Comparing the efficacy of tramadol as an adjunct to local anesthetics in brachial plexus block. Our study is also comparable to the study conducted by Sharon et al. In the year 2016, who compared additive effect of butorphanol to the local anesthetics in brachial plexus block. Coming to limitations, our study included only ASA PS1 and PS2 group. Hence, the result of our study cannot be extrapolated to patients belonging to other ASA PS groups. Our study did not assess that a rebound pain, which is a significant problem in patients undergoing peripheral nerve blocks. Conclusion: butorphanol is more effective in prolonging the duration of postoperative analgesia compared to control group and terminal group without any adverse effects. These are, thank you.
And both your studies were definitely longer analgesic effect than the control group, I suppose. You did not mention in the comparison.
Yes, ma'am. The control group, like additive, the butorphanol group and tramadol group, ma'am, both were prolonged. Duration of analgesia was prolonged, and it was statistically significant. Yes.
And butorphanol is longer acting as per your findings, and tramadol acts faster.
Only the sensory block onset was quicker, ma'am, and it was statistically significant. Motor block onset was also quicker, but it was not statistically significant, as p value was 0.0, more than 0.05.
So, what is more useful in your view for your regular daily practice?
Butorphanol will be more useful, ma'am, since it prolongs the duration of analgesia without any adverse effects.
Have you found any adverse effects in tramadol group?
We had expected to get some adverse effects, ma'am, but in our study we didn't get any adverse effects in both the groups, ma'am. Okay. So we had made that provision also to take into account, but none of the patients had received any developed any adverse effects.
Okay.
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 Thank you.
Thank you.
Any more questions, ma'am?
Carry on.
Our next presenter will be Dr. Lakshmi, P. Lakshmi.
Class miss. ನಾನು ಇಷ್ಟೊತ್ತು ಕಾನ್ಸಂಟ್ರೇಷನ್ ಇಲ್ಲ.
Hello all. The topic requirement among diabetic and non-diabetic patients undergoing lower limb fracture surgeries. Diabetes experience neuropathic pain has a decreased response to opioids. Fractures add to the pain and if not treated may lead to psychological impact and chronic pain. No data is available regarding related to fracture pain aggravated in diabetes. So we conducted this study with an aim to compare postoperative pain and analgesia requirement among diabetic and non-diabetic patients undergoing lower limb fracture surgery and also to correlate glycosylated hemoglobin with postoperative analgesia requirement. The primary objective of the study is to evaluate postoperative pain and analgesia requirement among diabetic and non-diabetic patients undergoing lower limb fracture surgeries. Secondary objective is to assess the effect of HbA1c with postoperative pain and to assess patient satisfaction. It's a prospective observation study with 80 patients divided into 2 groups of 40 patients each. Inclusion criteria ASA 1 to 3, age between 18 to 70 years, either of the gender, with the patients without anticipated difficulty spinal anesthesia and short duration surgery. Exclusion criteria: patients with deranged coagulation profile with compound fractures or combined spinal epidural analgesia or ASA4, or patients with cardiovascular dysfunction, or patients on multiple analgesia due to diabetic neuropathic pain. 2 groups, group non-diabetic group and a diabetic group is divided, and HbA1c was noted to assess glycemic control. Subarachnoid block was given with 2.5 cc of 0.5% heavy bupropion with 25 micrograms of fentanyl was administered. Any additional analgesia were avoided intraoperatively. In conditions with inadequate block were excluded from the study. In postoperative period, we measure parameters like vascular analgesia requirement, Wilson sedation score, side effects, patient's overall satisfaction. Rescue a medication was given each time when VASCO was more than or equal to 4. Results: VASCO was high in diabetic group with the p-values less than or equal to 0.05. Wilson sedation score shows statistically significant difference between both groups with high sedation score with the diabetic group. Rescue analgesic requirement was significantly different in two groups. Common side effects were nausea, vomiting, shivering were noted. Overall patient satisfaction of normal was a good experience with the non-diabetic group and fair experience with pain management in the diabetic group. This is the difference in the VASCOs in the two groups. This is the comparison of Wilson sedation score between the two groups. Side effects are observed in the two groups and overall satisfaction between the two groups in diabetic and non-diabetic patients. Diabetes has been found to have one of the most important factor leading to the more requirement of analgesia in the postoperative period. Specifically, uncontrolled diabetes has been found to have a direct effect on the postoperative pain studied by the team et al. Even osteoarthritis and diabetes commonly led to more analgesic consumption has already proved by the previous study. Combined impact of fractures and diabetes on the postoperative pain has not been studied. So this study was designed with an intention to evaluate impact of fractures and diabetes on the postoperative pain. Maximum studies has proved that diabetes decreases pain threshold, so leading to more analgesic requirement. Our study showed similar results, and also we could observe a good correlation between the glycosylated hemoglobin and higher VAS score. Conclusion: post-operative pain and analgesia requirements significantly higher in diabetic patients post-op for lower limb fracture surgery. Glycosylated hemoglobin had good correlation with the higher VAS score, suggesting significant high pain scores in patients with uncontrolled sugars. Thank you. These are my references.
Hello.
Hello.
Lakshmi, am I audible? Yeah. Good
Yes,
afternoon. You had a cutoff of what level of HbA1c before you accepted the case?
Both controlled and uncontrolled diabetic patients were included, ma'am, and HbA1c of more than 7 was included.
More than 7 up to? There is no upper limit.
No, ma'am, no, actually, if they are like both diabetic and recent onset diabetic patients were also included, ma'am.
You had
There's no upper limit for HbA1c, ma'am.
Okay, you had two groups, non-diabetic and diabetic.
Diabetic and diabetic, yes, ma'am.
Not controlled and uncontrolled.
Controlled and uncontrolled, both are included under.
Both were in the same.
Yes, ma'am.
So the effect of HbA1c on postoperative requirement or their VAS scores is not very accurate in your observation, because you have a high range of HbA1c in your patients. Variation.
Yes.
Okay. That's a good observation to make, that HbA1c can affect the VAS score and the requirement. Yes. So it will help us tell our surgeons, control your patients before you bring them for surgery.
Yes. Yes, ma'am.
Why there is a correlation between uncontrolled diabetes and pain, requirement of pain relief?
Because in diabetic, ma'am, the threshold for the pain will be decreased. So diabetic patients will have more sensitive to the pain, ma'am. So and also they'll be having a neuropathy, diabetic neuropathy.
Have you examined for diabetic neuropathy in all the patients?
No, ma'am. That is the limitation of my study. I haven't taken them into consideration.
Okay.
Yes.
And how do you infer that diabetic patients have less pain threshold?
Yes.
On what reference you have this observation that they'll feel more pain, diabetic people?
Previously, there was a study, ma'am. In that, they have compared diabetic patients and with fentanyl and morphine. So, regarding that study, we have started.
That was okay. You have a reference on that.
Yeah. Yes.
Okay.
Thank you.
Good questions, ma'am?
No, please.
Next candidate is Dr. Palakdeep.
My topic for paper presentation is efficacy of crystalloid preload versus codeload for prevention of subarachnoid block-induced hypertension compared to clinical study. Introduction. Despite the popularity and ease of use of spinal anesthesia frequently associated with hemodynamic instability, hypertension, and bradycardia, hypertension occurred due to main reduction in the vascular resistance by sympathetic nerve blockade, and bradycardia occurred due to relative dominance of parasympathetic system and increased receptor activity. Aim of the study is to compare and evaluate the effects of preload or co-load with crystalloid on hemodynamics during spinal anesthesia, and to evaluate any additional fluid and vasopressor requirement during spinal anesthesia. Material and method after approval from the Institutional Ethical Committee, written confirmed consent 50 adults 18 to 58 years of age, both sexes, ASC grade 1 and 2, inguinal herniorrhaphy surgeries. Exclusion criteria is patient with contraindication to spinal anesthesia, bleeding coagulation disorder, allergic to local anesthetic, ASC grade 3 or greater, any hypertension, morbid obesity, patient refusal to technique. Sample size estimation. To detect a 6 mm mercury difference in the mean arterial pressure between the patient with 80% power and 5% probability of type 1 error, 22 patients will be required per group with 10% dropout rate, total of 50 patients. Group allocation, patients were randomized using simple randomization method by computer-generated randomized number table. Two groups of 25 patients each. Group 1, 15 ml per kg ringer electric fluid will be preloaded within 20 minutes. 20 minutes before lumbar puncture, and group 2 is 15 ml per kg ringer electric fluid will be co-loaded in 20 minutes just after the lumbar puncture. Blinding technique. To avoid bias and mix study single blind, all parameters were recorded by the anesthesiologist who was unaware of group allocation not included in the study. Anesthetic technique monitors were attached under all aseptic precautions. Patients seated on the operating table. LC L4 intervertebral space. Narrow gauge 25 gauge was taken. 3.5 ml of 0.5% hyperbaric bupivacaine injected slowly. Sensory level assessed. When sensory level T10 is achieved, surgical anesthesia is considered. Observation: heart rate, SBP, DBP, mean arterial pressure, post spinal every 2 minutes till 10 minutes, and every 5 minutes till the end of surgery. Incidence of hypertension, bradycardia, nausea, vomiting, shivering. Number of doses of atropine, mefentramin, total IV infused to intra and post-operative complication. Results: all 50 patients were included in the data analysis. Demographic profile for age, weight, height, and age, physical status was comparable in between the groups. The mean duration of surgery was also comparable. Hemodynamic variables on the basis of data following observation were made was heart rate, SBP, DBP, mean arterial pressure in both preload and co-load groups, dose of mefentramin and atropine in both the groups, and episodes of complication. This is a table for the heart rate, different time intervals with both the groups in p-value. This is systolic blood pressure table. Next is diastolic blood pressure with group 1, group 2, and p-value, and mean arterial pressure, incidence of side effect, group 1, group 2, and the p-values. Discussion. In present study, the following observations were made. There is no statistical significant difference in the episodes of hypertension, episodes of bradycardia, dose of vasopressin, atropine in both the groups, episodes of complication like nausea, vomiting, shivering in both the groups. SB Parmer et al. Concluding study on the patients scheduled for lower limb surgery case that there is no statistical significant difference in incidence of hypertension in preload and co-load and in dose requirement of atropine and mefentramin as well as complication among the groups. The results are similar to present study. A. Ramakrishnan et al. Conducted a study including selective cesarean section cases that in incidence of hypertension was lesser in co-load as compared to preload group, and the difference was statistically significant, and mean total dose of ephedrine administered was more in preload than in the co-load group. The results are different from the present study probably because of different patients like pregnant females and different sample size. Conclusion: co-loading with 15 ml per kg of ringer lactis is as effective as preloading with same volume over 20 minutes in the context of prevention of spinal-induced hypertension in inguinal herniorrhaphy surgery. So it's unnecessary to spend valuable time to deliver preload before spinal anesthesia to prevent hypertension, specifically in patients with ASC grade 1 and 2 risk, and unnecessary delay surgery, though care must be taken for partial. This is my bibliography. Thank you.
Good, added that word, care should be taken in the parturient. The scenario will be completely different, or at least very different from inguinal herniorrhaphy and cesarean sections. So there really you have to take care. Because of the gravid uterus pressing, you probably need to preload than co-load in cesareans.
Yes, ma'am.
And the extent of sympathetic block is also different in these patients. So this study, though it's good, cannot be applied to blocks where we achieve higher dermatome levels and sympathetic blockade.
And yes, I want to also ask how many patients were we included in this patient? Total number of patients?
Ma'am, 50 patients.
One?
50 patients, 25 patients in both group 1 and group 2.
So I think your sample size is also low. I think for parturient patients, co-loading and preloading for that, if I am not mistaken. Otherwise, So no incidence of hypotension was found. What was the level of anesthesia you have given?
Was found, ma'am. Actually, it was between we just wanted to see if there's hypotension if we preload the patient 20 minutes before the surgery in group 1 and 20 minutes for 20 minutes after doing the lumbar puncture. So, ma'am, there was no statistical difference between both of it. So, study was not significant.
Not significant. Okay. Okay, thank you.
Thank you, ma'am.
Any questions?
So I guess we will call upon our next candidate. Yeah, it's Parveen Bano.
Myself, Dr. Parveen Bano. My PG guide is Dr. Anjum Sayed. My title is Efficacy of Bilateral Erector Spiny Plain Block on Intraoperative Drug Requirement of Fentanyl in Patient Undergoing Cardiac Surgery. Heart surgery is performed mainly by median sternotomy, which results in significant perioperative pain and non-negligible incidence of chronic pain. Regional anesthesia technique for cardiac surgery could be thoracic epidural analgesia, thoracic perivertebral block, erector spiny plain block, and fewer other facial block. Erector spiny plain block is newest technique described by Ferrero et al. In 2016. In this ultrasound-guided technique, local anesthetic is applied between the erector spiny muscle and the transverse process of thoracic vertebra, leading to spread of LA cephalic caudally and through perivertebral space. ESP is easy to perform and relatively safe method. Various complications like pneumothorax, spinal cord injury, epidural hematoma, central infection can be avoided. To increase duration of analgesia, we added dexmedetomidine with ropivacaine as an adjuvant. This study was performed to compare effectiveness of bilateral erector spiny plain block on intraoperative requirement of fentanyl in patient undergoing cardiac surgery by median sternotomy, intraoperative hemodynamic parameter, post-operative need for first rescue analgesia, and side effect also compare. Method study design as prospective randomized single-blinded controlled interventional study. We include adult patient age 18 to 65 years of either gender undergoing cardiac surgery by median sternotomy, had ASA grade second, third, weights 40 to 65, and we exclude patients who are not willing to participate in the study, history of allergic reaction, and infection on puncture site. The figure shows USG anatomy of erector spiny muscle. 60 eligible cases were randomly allocated into two groups using field envelope technique. Group A include 30 patients receiving single shot bilateral erector spiny plain block with 25 ml 0.5% ropivacaine plus injection dexmedetomidine 0.5 microgram per kg on each side and standard general anesthesia. In group B, 30 patients receive only general anesthesia without ESP block. Patient receive ESP block in sitting position with all aseptic precaution. Injection entropy monitor attached. Injection fentanyl given when entropy more than 60 in dose of 1 microgram per kg. Result. The table 1 shows demographic data in terms of age, BMI, ASA second, third, which shows not significant difference in all. Duration of surgery and extubation time also shows not significant difference. The table 2 shows intraoperative requirement of fentanyl. The group A 1.97 microgram per kg per hour and group B shows 2.55 microgram per kg per hour. This difference is lower in group A, but this difference is statistically not significant. The first rescue analgesia after block is high in group A, and this difference is statistically significant. Discussion. Demographic data was compared in terms of age, sex, weight, ASA status in both groups, which shows there was no bias in our study. We observed there was significant difference in heart rate, which can be explained due to dexmedetomidine that was added as an adjuvant and an analgesic effect of LA. The study done by SF Wasfi shows found intraoperative fentanyl requirement in microgram significantly less in ESP group. And study done by P. McRae on pediatric cardiac surgery was also found intraoperative subventricular requirement is low in ESP group. The study done by S.P. Kaushal et al. Was also found first rescue analgesia timing is higher in ESP group than control group. Conclusion: our study conclude bilateral ESP demonstrate decrease intraoperative requirement of fentanyl. There was statistically significant difference in time of need of first rescue analgesia in cardiothoracic surgeries.
What is the sample size?
Sample size is 60. 30 for erector spiny plain block group and 30 control.
And there was significant difference in the
first rescue analgesia, need of first rescue analgesia.
Okay. Seems to be a good alternative for providing them analgesia. But something you said about chronic pain after median sternotomy in your initial introduction.
Yes, sir.
How does this method help anywhere in chronic pain?
If we control acute pain, some study shows if we control acute pain, then it not convert in chronic pain.
Okay. I would like to know about those references.
Ma'am, Forero et al. And Adi Kare for done erector spiny plain block.
I'll look.
He include his study.
Because there are many patients who come after median sternotomy procedures. In years together, they'll have this chronic pain. We have tried many methods of pain relief with no avail. It's an interesting thing to explore.
Thank you.
Mamta ma'am.
What was the duration of analgesia in this?
Ma'am, ESP group is around 25 hours and block 25 hours after block, ma'am.
Okay.
Ma'am, extubation timing around 12 to 13 hours. When we ship patient ICU, we give injection paracetamol 1 gram in both group. After extubation, we calculate VAS score. That was 25 hours in ESP group and around 20 hours in non-ESP group, control group.
Good. It's quite a prolonged analgesia in this group.
Ma'am, we add dexmedetomidine for increased duration.
Increased duration. Okay. Okay. Good.
Thank you, ma'am.
Thank you.
Thank you, Parveen.
This was the last presentation from Parveen. Thank you, Parveen.
Thank you, ma'am.
I think we are concluding this session. Ma'am, any concluding remarks from you? Prabha ma'am and Shushma ma'am?
It was nice, Dr. Deepthi. And most of them were airway oriented. So the discussion went in one pattern. So it was good.
Mamta ma'am?
Yeah, thank you, Deepthi ma'am. And it was a very good experience. Okay. Residents are also doing very good job. They are answering very well. So it's a nice experience. And thank you, IASCON. Thank you.
Thanks, ma'am, both of you
Thank
for
you,
spending
Prabha,
your valuable time. And thanks all the presenters. And thanks, Alok, for conducting this meeting. So I think we'll call it a day. Thanks a lot.
Thank you,
See you in
Dr.
the
Mamta and
conference.
Dr. Deepthi.
Thank you, Prabha ma'am.
Nice,
Thank you.
nice meeting you.
Nice meeting
same
you.
here, ma'am.
Okay.
Bye-bye.
Thank you. Okay, bye.
Then tomorrow I don't have. Most of the studies were